Good morning. My name is Tirendri Naika, and I'm going to talk to you about craniospinal radiotherapy in pediatric tumors. So the indications for craniospinal radiotherapy in pediatrics are broad, but the commonly known indication are the embryonal group of tumors, and I'll talk a little bit about medulloblastomas, which is the most common indication.
can use the laser pointer. Good morning, everyone. And also, thank you for waking up this early to listen to radiology. It'll be very short and sweet because I only have 10 minutes, and I don't want to take too much of the time that's been allotted to me. So this is just a very rough overview on imaging protocols for primary CNS tumors. It's not possible to go through everything that's needed to go through, even for a non-radiology audience as well, because there are so many updates and so many new things happening, especially in neuro-oncology, imaging and follow-up that I cannot encompass in just 10 minutes. So thank you very much for having me. So by way of introduction, I think as we all know, neuroimaging is useful at all stages of CNS tumor care. So all the way from diagnostics, where we use imaging for detection and localization of lesions. We can do fancy things with spatial mapping, of course assessing anatomical relationships, things like functional imaging as well, to characterization and differential diagnosis, because not every intracranial mass is an intracranial malignancy, forming the basis of assessment of contrast-enhancing lesions, non-contrast enhancing lesions, tumor heterogeneity, things like necrotic tumors, mixed tumors, multicentric, multifocal tumors, all the way to treatment planning. Especially, imaging is especially useful for surgery and radiotherapy planning as well. So sometimes you may not be able to do maximum safe resection or supramaximal resection. You might just only be able to do a biopsy. So imaging is required, of course, for optimal sites, for optimizing biopsy sites. And finally, treatment response and surveillance, which is a heavy topic by itself, but I'll attempt to summarize it within the 10 minutes that have been given to me. So there's the concept of standardized brain tumor imaging protocols from the clinical trials that are happening all over the world. I think, again, I might be assuming, but just in case you don't know, MRI is investigation of choice in neuro-oncological imaging. CT sometimes is the primary modality when a patient comes in with non-specific neurological presentations, but when a CT shows features that are suggestive of an intracranial mass, an MRI really has to be done to characterize that mass. There's also a role for PET-CT, especially with protocols that may cause pseudoprogression versus true progression. And there's a role for FDG PET and FET PET, especially FET PET, in trying to figure out exactly what's happening with patients in whom pseudoprogression is suspected. Now, because scanners are a dime a dozen, institutions are many, different types of magnetic field strengths exist, different types of protocols exist depending on, again, a multitude of factors, the knowledge of the person writing up the protocols, the knowledge and skill of your techs, the availability of certain software on the machine. There's a lot of variability in MRI acquisition, and that can be very difficult when you're trying to assess imaging from a patient who is being imaged in multiple institutions or using multiple scanners. And so there's an attempt to try and harmonize brain tumor imaging protocols despite that heterogeneity. And so what the BTIPs try to do is to aim to reduce this variability while still ensuring high quality imaging, and trying to do this across the multitude of available scanners that are available. But the minimum really that we should have is a 1.5T in all our imaging institutions. So there's the ideal tumor imaging protocol on a 3T. and then, but it's not very different from the minimum protocol requirements that will be done on a 1.5T. The most important imaging sequences are 3D T1 weighted pre-contrast images and 3D T1 weighted post-contrast images. There are multiple parameters. I won't go into that. Multiple imaging parameters, imaging acquisition parameters on the T1, but they need to be 3D T1 pre-contrast and 3D T1 post-contrast images, so parameter matched pre and post-contrast images. Another thing that's very important about the post-contrast images is that sometimes you do get suboptimal acquisition of the post-contrast images, and I'll show you a very dramatic example of that that we've come across several times in our experience. But of importance is that the images should be acquired 4 to 8 minutes after contrast injections, because this is the peak time of uptake from multiple studies where it's been shown you have a peak contrast enhancement in those tumors that will enhance. And there are, again, a multitude of recommended concentrations of contrast, because the gadolinium contrast comes in multiple densities, so you have to use the recommended concentrations of that contrast as well. So the other set of images would be T2 flare, T2 weighted images and T2 flare images. You can also have post-contrast flare images if you're using a 3T machine as well. These can be acquired in 2D acquisition or 3D acquisition. These are a push towards 3D acquisition, especially on 3T machines. And there's also a push for post-contrast flare acquisition, especially on 3T machines. But again, what is more important is the slice thickness. Again, a lot of centers acquire very thick slices, 5 millimeter thick slices, which is not recommended. The slices should be 4 millimeters or less. And this is an update from the RANO 2.0 criteria, which I'll also go through very briefly. Diffusion weighted imaging is mandatory. You can use diffusion tensor imaging as a surrogate for this, but most machines, 1.5T and 3T, can do diffusion weighted imaging, and also the ADC maps from this. Dynamic contrast perfusion imaging is not mandatory, but is recommended especially on 3T images. And the software is recommended to get for brain tumor imaging. So of course, you know that for leptomeningeal seeding tumors, we have to complete neuroaxis imaging. So this is just wanted to see how it looks like for you. But these are just examples of the types of images we would acquire based on that brain tumor imaging protocol. The top panel has T1 non-contrast, FLAIR, axial imaging, and the DWI component of brain MRI. The bottom panel has a post-contrast T1. It's a 3D acquisition, as is labeled, hopefully you're able to see, yeah. A 3D post-contrast acquisition, a T2 weighted image, and that's the ADC map from the DWI. And of course, you can see on the pre and post-contrast T1, there's this necrotic tumor with irregular peripheral enhancement in the right parietal lobe. You can also see another area of enhancement there, elsewhere in the right parietal lobe. You can see there's the non-enhancing flare signal that's anterior to this enhancing portion, and areas of a different type of flare signal that's more feathery across the white matter that usually is very typical for vasogenic edema, but as you know, with high-grade gliomas, there's usually tumor mixed in with the vasogenic edema as well. But the DWI is used to as a surrogate marker for tumor cellularity, and when you have restricted diffusion, the physics of which I won't go into, it helps to give us an idea of the cellularity of the tumor. So this is like an imaging sort of summary of the brain tumor imaging protocols recommendations. You can have additional imaging, of course, as part of your clinical assessment. You can have this is a perfusion scan that shows that peripheral enhancing solid area taking up, being more perfused than the other areas of the brain. You can do MR spectroscopy. This is another patient, a different patient with a right frontal tumor. This is a FLAIR axial sequence that shows that heterogeneous abnormal FLAIR signal. And you can see the tumor here. These are diffusion tensor imaging just to show the involvement of the major white matter tracts. And these are optional, but if you're able to do them, they're very helpful in planning. This was the dramatic case that I wanted to share with you. This is the same patient, just 4 days apart. And the top panel is T2 and T1 post-contrast weighted images. The bottom panel, similarly, T2 and T1 post-contrast weighted images that were done with different post-contrast protocoling. You can see on the top panel, you barely have any enhancement. So, you know, enhancement is one of the things we use to determine whether a tumor is potentially a high-grade lesion or a low-grade lesion. And so this can actually have an effect on how you approach your reporting and your interpretation of this lesion, this T2 hyperintense lesion. The bottom panel scans, the exact same scans that were done 4 days later with the correct post-contrast protocol, and you can see it reveals that this is actually an avidly enhancing tumor, and it's very, we then have confidence to call this a likely high-grade glioma. So, RANO 2.0 is the most recent update in the response assessment in neuro-oncology. So as you know, TNM is not very useful in brain tumor assessment for various reasons. It doesn't, the size of the tumor does not usually correlate with the aggressiveness of the tumor, the prognostication of the tumor, and what matters is things like aggressiveness on imaging and the molecular profiling of the tumor. So, and nodes and METs are not really applicable in high-grade gliomas. So there's a different, response assessment when we are doing monitoring for treatment for brain tumors, and this is the most recent update, the 2.0 version. And it's been built upon data from multiple previous versions, which is very useful for us because we've been very confused for a very long time. And especially with new modalities coming in, there are all sorts of new responses to think through when you're looking at your imaging. Just because a tumor has increased in size or enhancement during follow-up, or the other way around has decreased in size or enhancement, does not normally mean that that's a definite response one way or the other. There are many factors to consider, including the treatment that the patient is getting, and also the timing of the imaging. So RANO 2.0 is very useful in providing a more clear cut guideline in that response assessment. I just want to highlight a couple of things. The primary baseline scan for follow-up treatment now is the post-radiotherapy MRI. So before, it has variably been maybe the preoperative MRI or a very early post-operative MRI less than 48 hours after surgery is done. But the current RANO 2.0 criteria guidelines are that the primary baseline scan is the post-CRT scan. And this should be done at approximately 4 weeks after the end of radiotherapy, so 21 to 35 days post-radiotherapy. There's also clearer guidance on follow-up MRI imaging, especially for high-grade gliomas. Follow-up imaging should be done every 2 to 4 months for the first 3 years, and then every 3 to 6 months. And for low-grade gliomas, every 3 to 6 months for the first 5 years, and then every 6 to 12 months. I won't go through this, but what I wanted to show you is that there are also numerical values to define, the different response criteria. So CR is usually, of course, very straightforward, but things like partial response, minor response, which has also been introduced using both 2D and 3D measurements. And none is non-inferior or superior to the other in studies that have been carried out. Stable disease and progressive disease all have very definitive numerical values. This is very helpful, as I mentioned before, in having cohesion for patients who are being followed up using MRI, because many times you might have a reduction in size, like I mentioned, but it doesn't meet the threshold to call partial response or even minor response. And that, of course, changes the way that the next step of treatment goes. Okay, this is my last slide. So for progression protocols, there are, again, guidelines on follow-up MRIs. So if pseudoprogression is suspected within the first 12 weeks after completion of CRT, and the patient is clinically stable, follow-up scans are recommended at 4 to 8 week intervals to confirm. Sometimes this is where the role of FET-PET or FDG-PET can come in as well. And sometimes you might have a difference between what the radiologist is saying. You might have features of a pseudoprogression on imaging, but the patient is getting clinically worse. And there's a role for using the patient's clinical, state to actually make a decision of true progression or not. So it's not written in stone, but these are good guidelines for MRI follow-up in this particular scenario. For progression confirmation, if this is outside of the 12-week post-CRT window, you don't need to do repeat confirmatory scans, because outside of that 12-week window, you're less likely to have pseudoprogression if there are features that suggest progressive disease. So some people may choose to do a confirmatory scan, but true progression can be called. And then for response durability, so for complete response or partial response, a confirmation scan separated by at least 4 weeks is required. So thank you very much. I haven't talked about future roles, the future directions for MR imaging especially. There is a role for AI segmentation in doing volumetric assessment, because that's another problem that we have, is what I measure and what someone else measures sometimes can be very different, and of course that changes the percentage by which we're going to call a response. But that, I think that's beyond the scope of today's talk, but there is exciting stuff hopefully coming up in the future. Thank you very much.
Wow, thank you so much, Dr. Mavuti. That was brief and very clear. Thank you, we appreciate. Let's clap and appreciate Dr. Mavuti. So having set the stage in terms of radiology, we now have to dive into how does the neurosurgeon translate this data into safe resection and subsequently molecular profiling. So you have Dr. Beverly Cheserem, an award-winning neurosurgeon based at Aga Khan Hospital, and she's also the current secretary of SNOSA. Welcome, Dr. Beverly.
Thank you for the privilege. Thank you for the privilege of being able to talk to the radio-onc community. I'm a little bit as a fish out of water because I'm used to being in theater, so be gentle with me. So what's a surgeon's role? I think that people see us in the middle in theater, but maybe secretly we think we're the ultimate good within the treatment of patients. And so I'm just going to discuss a few things where there is an overlay of what we do together for the benefit of the patients. I'm just going to go very quickly, and then we'll have an opportunity to ask questions. So I think overall we are involved in diagnosis, neurology preservation, functional planning, medical support, and device placement. So to plan most things in radio-oncology, you need to know what the tumor biology is so that you can have an accurate assessment of what treatment modalities would be best. And I think we think of patients not as individuals that we own, but a person that we support collectively. So certainly the practice that we have in Aga Khan is an MDT approach, which interestingly is, our MDT is led by our radio-oncologist here. And it anchors a lot for us in neuro-oncology. So the first thing that we tend to do at the range of tumors is to relieve of mass effect, whether that has caused hydrocephalus, whether it's caused displacement of eloquent brain, compression of the optic chiasm, etc. For the purposes of radiotherapy, cytoreduction is a very important aspect, particularly in primary tumors. If we look at the outcomes for high-grade gliomas, we know that the more cytoreductive a surgeon is able to achieve, the overall outcome is substantially different. For context, if we do only a biopsy and do nothing, high-grade gliomas normally have a survival median of 3 months. But if we have a full resection, I have a high-grade glioma patient who's still alive 5 years since the last resection with no evidence of tumor progression. But of course, this meant a collaborative approach between ourselves and our radio-oncology colleagues to ensure that the time between cytoreductive surgery and subsequent radiotherapy was as short as possible. Then biopsy, we have had very many mimics of tumor pathology. Within our context, we have seen TB as a mimic, we've seen neuroinflammation as a mimic. We've also seen discrepancies in tumor grading. This is particularly relevant because in the primary tumors, we now have a WHO classification from 2021 that encompasses molecular pathology, molecular markers. And that has seen an upstaging of otherwise radiologically more benign or lower grades, particularly, for example, in high-grade gliomas is being one. Midline gliomas in the pediatric population getting the right diagnosis between pilocytic and midline gliomas that have greater propensity to spread. It has been a game changer to be able to attain some tissue. And the variability between primary and secondary tumor approach. In primary tumor approach, cytoreduction is the main goal. In a secondary tumor approach, then we're looking at reduction of the mass, but also confirmation that the molecular markers are the same, because sometimes you can have a coexistence of two tumors. And we've seen that in a couple of cases, whether it's epithelial in origin, that you cannot make an assumption that because somebody has breast cancer, that the metastasis is automatically a breast tumor. They could be in a wider variety, for example, in Lish syndrome, where it's from the same germline distortion, but it's not the same tumor, and that may require a different approach. And then there is obviously the functional preservation. The aim of the surgeon is like a thief, to get in and leave minimal evidence of their presence within that context. And within our setting, we have tried to adopt as much as possible minimally invasive approaches. So in the middle there, we're seeing endoscopic approaches, for which I love to do, and we can do that through the nose, through the side of the head. We're now embracing increasingly, even in spine surgery, endoscopic approaches. And then other adjunctive technologies that help us in our work. Here you can see a patient, you can see neuronavigation, you can see neuromonitoring. This patient was done asleep, but we also embrace awake surgery so that we can preserve as much of the function. And then our our radiology colleagues really help us with functional mapping. I think you saw that my colleague showed one of them where you could see the tracts, and this is an important part of our surgical planning. So preservation of neurology. So there are two main. So we work in three main sections that a neurosurgeon will help you with. There is the brain, the spine, and there's a peripheral nerve. And in peripheral nerves, there is an important role in mapping, establishing diagnosis, preservation of vasculature, and allowing you to have access to the tumor with minimal damage to aligning tissues. In spine, we look at two components. In the pre-radiotherapy session is fusion, and we stamped spine stabilization as any procedure that allows the spine to carry the weight of the patient without neurological fallout or pain. And so if you think about myelomas and many of the other hematological tumors, they have a marked effect on the ability of the spine to support the patient. And so we offer fusion. Post-radiotherapy, I would ask that we consider the role of vertebroplasty as well as fusion in post-treatment stabilization of the spine, because once you've done radiotherapy to the tumor, the integrity of the spine stability may be affected. We look at whether we should undertake this with minimal access. We also do various aspects of neural decompression, whether this is within the CP angle as demonstrated here, within the optic, so I work on the pituitary to ensure that we preserve vision, but also allow there to be, whether it's you're using proton beam or SRS or SBRT, that your conformal planning can limit the damage to surrounding structures, both vascular and neural. And also, of course, we talk about hydrocephalus management, which is a key part. So if you see any, and here we say that hydrocephalus, we typically think of it as just enlarged ventricles. We urge that you consult us early, because in certain conditions, such as intracranial hypertension, the ventricles may not necessarily be markedly enlarged. This is particularly true for conditions like vestibular schwannoma, where CSF may have a higher protein content, and therefore, if you have any concerns, patient is vomiting, headaches, even if the ventricles don't look particularly enlarged, consultations with the surgeons for consideration of CSF diversion, so that even as they continue with their radio-oncology treatment, that there is limitation of neural fallout. And then there's our role in functional planning. I've seen here that there are many machines, whether that is CyberKnife, SBRT, SRS. And I know that you're accustomed to frameless using the mask, but there is a role of the neurosurgeon in applying the fixed frames, the Lexel, which is particularly useful for deep-seated lesions, such as, for example, within the thalamus, within the benzoganglia, or if you need precision, so in AVM, for example, atriovenous malformation, where there is a role for radio-oncology treatments, the use of a surgical support to ensure that the frame is appropriately applied, and also our radiology colleagues to ensure that the mapping is appropriate is key. And the functional planning exceeds beyond just tumors. We tend to think this, I think there's now a misnomer, and you may need to reclassify, because you're not just treating oncology. The scope for what your specialization offers now extends to other functional lesions such as epilepsy, movement disorders, mood, and obsessive compulsive disorders, amongst others. And here it calls for collaborative planning. You're the specialist in the machines. We, together with the radiologists, we can work on the planning and the mapping, and our neurology colleagues help us with the functional support post-treatment. Another role for a surgeon is device placement. I think the most commonly understood is the ventricular peritoneal shunt, but we also do put in the Ommaya reservoirs that can be particularly. So if I think of bleomycin in craniopharyngeal, where you have meningeal infiltration in advanced secondary tumors. There are now development of drug delivery systems for brainstem tumors. This is still in the trial phase, and just very few centers in Europe currently undertake them. But that may be a game changer for areas that are particularly radiosensitive in their, and therefore you want to limit how much radiation you give. Other things are pain. So whether it is whether it is post-tumor or other functional illnesses, a neurosurgeon may be of use to put in spinal cord stimulators, sphincter devices that help post-cord equina, We use transmagnetic stimulation for headaches, which can be a factor for some forms of oncotherapies, particularly if they have radiated the meninges, which are primary sensors, and deep brain stimulators if there's been a fallout from the basal ganglia, resulting in movement disorders, pain syndromes, etc. And then the future, who knows? We look now beyond just primary treatment into survivorship. What is the quality of life of a patient who's undergone oncotherapies or other therapies? And one of the other ones is the use of modulating devices. So Neuralink, for example, in restoring movement, emotion, balance, etc. Still in the formative stages, it's now being used to help people regain their ability to walk, function, read, some of the executive functions, but we're still in the early phases of what we can do. And the role here for the surgeon will be device deployment. Medical support. I think for the vast majority of communities of the neuroscience specialities, we don't have enough neurologists or neuroendocrine specialists. So we say that a neurosurgeon is a neurologist who happens to operate, or rather we're neurological surgeons. And so in many centers, we should still be involved in the overall medical management of this group of patients, such as seizures, pain management, electrolyte abnormalities, and endocrine fallout. So where the new considerations that are going to come, thermotherapy is increasingly being applied, and the benefit here is the reduction of the radiation exposure, as much as also focused ultrasound. We've seen it in gynecology with HIFU, the high frequency ultrasound, but this is also coming in the neural space. The idea that it can help in breaking down the blood-brain barrier and therefore allowing for better access. Sorry, I'm just asking quietly whether I'm being told to leave. So focused ultrasound is going to come into play. The question now is who will own this technology? Ultrasound currently sits most comfortably within radiology. I don't know if the radiologist would want to come and step into theater for this, or whether this will be taken up by the radio-oncology community. Once again, I need to rebrand the name. So it breaks down blood-brain barrier. It's also important in tumor-lysis, a factor that can be important, for example, in primary brain tumors in pediatric populations, or if we're looking at multiple metastases and we're looking for non-radiative therapies. Then there's liquid biopsy. So I said our role as surgeons is to acquire tissue, but increasingly there is an understanding that tumor cells migrate through the hematogeneously, and it might be that our role will increasingly be subsided by less invasive technologies. But also liquid biopsy has a different role within surgery. In some areas, the way we think about frozen specimens in theater, there is machines now that are doing liquid biopsies as you operate, and that allows us to ensure that our cytoreductive targets are better achieved. But there are still challenges. One of the challenges for Africa is research inclusion. These technologies are being pioneered in Asia, Europe, and America, and noticeably, we are being absent in the development of these new technologies. And that means that if the uptake is going to take longer, we will end up being in the post-research phase, which is often the most expensive phase to implement a technology, because now you're buying it at retail. And of course, the costings. Kenya is trying to work through to universal healthcare, and minimally invasive, shorter stay technologies often have an upfront cost, and at the moment not captured in our strategic health planning. And that's a challenge for a surgeon who may want to be forward thinking. And then of course, training and workforce region availability. The surgeon doesn't sit in isolation. You sit with many other providers of care. And if they are not trained in, then the system cannot carry. So if you work with a surgeon, what should you ask of them? The first is speed of access. There is nothing to compensate for availability of a colleague to discuss these cases. When you're trying to make a decision in an MDT setting or in acute setting, some things cannot wait. And so that's the first thing I would ask if you're working with a surgeon. The second is, have they embraced minimal versus maximal access? That is important because in a later one, I said the time to be able to commence your radio-oncology treatment is substantially affected by the route of therapy undertaken by the surgeon. And the more minimal access that we apply, the the faster the time to therapy it can be. I think recently in a patient, we were even able to say after 2 days, the benefit of starting radiotherapy was greater than the risk of complications. So we're able to put ourselves forward and say, I can't read that. That's 0 minutes, yeah? Okay, sorry. I get the hint. It was blank. And then impact on time to oncology treatment, scope of combined practice. I've talked about devices that we need to share, technologies that we need to share in a multidisciplinary way, device availability and in-country support, and the role of newer therapies. And then, of course, we have to always ask this one question: is treatment better than the natural history? Increasingly, I think I'm branding myself as a surgeon reluctant to operate, not because I don't care for surgery, but increasingly we're realizing that the natural history of some conditions are better left alone, and the interventions that we're doing are causing more morbidity. And that's an important question to always ask. I thank you, and I hope that many of you would have the opportunity to interact and maybe visit our center. Thank you.
Thank you, Dr. Cheserem. That was a great presentation. A crucial part of this radiation oncologist, and to give us perspectives on that is a meticulous radiation oncologist based at the Kenyatta National Hospital, Dr. Mongare. All right, so we'll have a change in our program. And to take us through the next session, we wanted to listen to photon therapy, but I think we'll jump straight into proton therapy. There's a lot of developments and emerging role of proton therapy. And to take us through that presentation is a visiting oncologist based in India, Dr. Sapna. I hope she's in the audience. Lovely, lovely. She's a radiation oncologist who has special
radiation is definitely one of the most difficult treatments that a patient has to go through. On the other hand, when we look at the outcomes, what we note is, this is from the NEVO post-op, which I should say is the most, recent most literature that has, a study that has been published. And we see that even in the study arm of this group of patients of advanced malignancy, about 63% of patients only were disease-free at the end of 3 years. So definitely there's a lot that needs to be done. And how does proton therapy help? This is a graphic explaining how the doses behave in the tissue. So while if that graphic represents the tumor, the X-rays travel through and through. However, protons stop at a particular point, and that is the Bragg peak. And the Bragg peak not only prevents the limits the radiation traveling distal to the tumor, it also results in high linear energy transfer, which means that the RBE is higher, and there is a possibility that there are a higher number of double-strand DNA breaks, which is what often explains why in certain radio-resistant malignancies, like this lady with an adenoid cystic carcinoma, with extensive involvement with the orbit, skull base, ITF, this is a lady who was treated about 3.5 years ago, and this is her current scan. So this is also one of the advantages of proton therapy, not just the Bragg peak and the sparing of the distal tissues, but being able to harness the advantage of RBE. I would say it is something that is in development. This is a comparison of the same patient's proton therapy plan in the top panel with the photon therapy plan. And I think it's to an audience of radiation oncologists. I don't think there is much to be explained. And we see even the 20% isodose, which is the last one, the blue one, is limiting the dose that is being received by the brain in this situation, or the contralateral cheek, or the pharynx, for example. A typical proton therapy department would have a cyclotron where the proton will be made, and then this 3 millimeter beam of protons will travel into one of the 3 rooms and administer the treatment. Why were we not able to deliver treatment to head and neck cancers and other complex targets earlier? Because we used different generations of protons earlier, and now the 3 millimeter beam of proton can actually deliver the treatment layer by layer and match and create isodose volumes which are complex. And the earlier generation of proton therapy machines did not have image guidance, while the current generation of proton therapy machines have image guidance as well as robotic couches. We've known about proton therapy for skull-based lesions where it is recognized as a treatment of choice, and we also know of its role in re-irradiation. But what is also fascinating to know is the expanding role of this treatment modality in salivary gland tumors, nasopharyngeal cancers, oral and oropharyngeal cancers. I'll start first with skull-based lesions. Naturally, this is a location which is in close proximity to the optic nerves, the temporal lobes, the brainstem, all of which are radiosensitive structures. Radio-resistant lesions like clavicle chordomas or adenoid cystic carcinomas require much higher doses. And what proton therapy allows us to do is to reduce the possibility of underdosing the tumor. So what you see on your left is a comparison of the proton therapy plan with the photon therapy plan, where there is some amount of compromise to spare the optic structures, while in the proton therapy plan, we don't see that. And the coverage that is also reflected in the numerical values, where 95% of the prescribed dose is covering more than 99% of the proton therapy volume. On the other hand, if we look at other non-essential tissues like the pharynx and the oral cavity, etc., there too there is an advantage, and that becomes relevant especially when we are giving concurrent chemoradiation. So when we look at the proton therapy data, there is no head-to-head comparison. There is a systematic review. So there's no randomized trial. So we can only compare previous data with previous published data. So this is from the MD Anderson Cancer Center, 3-year local regional control of 88% versus the most recent photon therapy data where the local control is in the range of about 65%. There is a systematic review published in 2014, which looked at particle therapy, not only proton therapy, and noted a survival advantage and a disease-free survival advantage when comparing protons with photons. At the Proton Center, we've treated about 70 patients, primarily clival chordomas, skull-base adenoid cystic carcinomas, and paranasal sinus tumors. This is a patient who was particularly challenging. This was a photographer. He had this lesion extending from the ethmoid sinus intracranially, underwent an endoscopic transnasal excision, a craniotomy, and then the histopath was a poorly differentiated squamous cell carcinoma. This is what his proton therapy plan looked like. We used BID fractionation so as to be able to spare the optic apparatus. And the patient remains well, disease-free, with his vision intact, which was very critical for, and 2-year local control of 90.4%. I'll switch to nasopharyngeal cancer, which is where we have a lot of patients seeking treatment, young adults, where young adults, because it allows them to preserve their cognition, and older adults, because it allows them to take chemotherapy, easier because we can spare the midline mucosa much better. So here again, there are 2 systematic reviews. There is one systematic review published by Anna Lee, which tells us that the toxicity is less. And then there is a propensity-matched comparison from Taiwan that tells us that the survival was better for their group and the tube feeding rates were the same, though the cochlear toxicity was, tube feeding rates were less, but the cochlear toxicity was the same. Now, this is a comparison of a proton plan on the top panel with the photon plan and the extra dose that a patient doesn't receive. This does become critical in these patients who have received significant amount of neoadjuvant chemotherapy and are going to receive some concurrent chemotherapy. And this is a 73-year-old gentleman where this was one of our first patients, and we were very intrigued by how much we would reduce the dose to the organs at risk involved in cognition. And as you can see, the number is quite substantial. The comparison, the temporal lobe doses are down by nearly 60%, or the hippocampal doses are reduced, the optic nerve doses are reduced. So this, in short, is nasopharynx. I'm switching gears to salivary gland pathology, and here the patient group is completely different. They are going to have well-lateralized tumors. And the reasoning for giving proton therapy is completely different. So these are young men, 23, 30, and 27, with mucoepidermoid carcinomas involving the parotid. And here the reason for giving protons is a reduction in the integral dose so as to reduce the possibility of having second malignancies. We know that the hazard ratio of developing a second malignancy from 2 population-based studies that have been done is about 0.3 to 0.4 for patients who undergo proton therapy vis-a-vis IMRT or 3D CRT. There have been some unusual salivary gland pathology applications, such as this lacrimal gland adenoid cystic carcinoma patient, as you can see in a very critical location. He unfortunately went on to develop lung metastases and is currently grappling with that. So technology doesn't always win. Of course, biology is very, very important. And this is a gentleman with a sublingual, if I have a pointer. So you can see at the mentum what we have marked out in blue. That is a sublingual gland adenoid cystic carcinoma eroding into the mandible. He was an elderly gentleman with multiple comorbidities, and he was one of our first patients treated with a definitive approach, and this was in July 2022. He remains well in July 2026, though he has recently developed an ORN after having undergone a dental extraction. So here again, the results are very satisfying with the 2-year overall survival of 87.1%. You will note that the locoregional control is higher, and that's because in adenoid cystic carcinoma, the patients will not fail locally, but instead develop lung metastases, which is why we see that the overall survival is actually lower than the local control. Proton therapy is considered a kind of like a natural choice when we are doing re-irradiation. However, I would like to say here that re-irradiation is not something that we do casually, and protons are not something, again, that we would offer casually, because the risk versus benefit ratio has to be factored in. So in certain situations like this lady with an esthesioneuroblastoma, proton therapy allowed us to treat the entire tumor without impacting the optic nerves, unlike the tomotherapy plan where you can see that for the same optic nerve dose, we would have underdosed the tumor. But the critical fact is that the advantage of proton therapy, this is the MIRI consortium paper. The MIRI paper told us that the best outcomes in re-irradiation are in patients who have completed at least 2 years since the previous course of radiation and have undergone surgery. And that is actually the group that receives the maximum advantage. So we see that from 62%, which the MIRI group had noted, we are also in the same range as about 69%. However, all other patients who otherwise have very poor prognosis continue to have poor prognosis, irrespective of the technology. The ones who do really well, the 82.4% 2-year survivals, are the non-squamous, such as the adenoid cystic carcinomas and the clival chordomas. Those are the patients who do the best. And in my last segment, I'll touch upon oral and oropharyngeal cancer. There have been 2 recent trials, one published by the MD Anderson, 21 institutions, 440 patients, primarily HPV positive patients. Significant reduction in toxicity in that the tube requirement was about 1/3 less. The survival was significantly better. In one section, the trial had certain flaws. It had a lot of crossover. So that is one of the critiques of the trial. But in the original intent to treat population, there was a survival advantage. There was another trial on the other side of the Atlantic, the Torpedo, run by the NHS, where the endpoint was gastrostomy tube insertion at the end of 12 months. I'm not very sure how relevant it is. As oncologists and perhaps even as patients, we might defer that, we may be more interested in acute toxicity or survival, etc. Again, primarily HPV positive patients. So there was a significant reduction in the toxicity, 72% grade 3 versus 50% grade 3, but the trial did not meet its endpoint. Our focus has been on reduction of mucosal toxicity, and our interest has been on tobacco-induced oropharyngeal cancer and oral cavity tumors, which is basically our disease type in India. I'll be very interested to discuss over coffee okay. So we have published our results of mucosal sparing radiation, wherein we have demonstrated that when we use proton therapy, the dose to the oral mucosa comes down substantially. This is data that we are presenting. This is my last slide. This is data that we are presenting at Astro this year, where we have demonstrated that for this radio-resistant group of patients, HPV was different, they're radio-sensitive, and perhaps there was no advantage of proton, but in this fairly stringently propensity-matched group of patients, we have seen a survival advantage for patients undergoing proton therapy. This is a group of 53 pairs of oral cavity and oropharyngeal patients. And I'll close here to say that it's a technological advance that is allowing goals of care on head and neck radiation in head and neck cancer to be fulfilled. And it allows the residual burden of toxicity and suboptimal outcomes that remain after IMRT. This is something that is, growth in that direction. It is effective across age spectrums in the sense, in the elderly, it allows uninterrupted treatments. In the young, it reduces the possibility of second cancers. And in the middle-aged, it allows them to get back to employment early. This is, again, data from MD Anderson. I'd like to take a minute to acknowledge my team of head neck surgeons, medical oncologists, swallowing therapists, etc. It's definitely not a single person who makes head and neck treatments happen. And that's the radiation team and the physics team who have worked hard to bring this to the country, to our part of the world. And again, I'd like to acknowledge the team. Thank you so much.
Thank you so much, Dr. Sapna. That was an exciting talk. And swiftly, we move on to something very different. So for us to deliver precision radiotherapy, we require extreme efficiency. So we have Ms. Ekta here to tell us what the developers at Varian are doing to improve the use of AI and efficiency in radiotherapy delivery. Welcome.
Thank you very much. And while my laptop is being connected, just want to acknowledge the efforts of making this time, especially given that I have added the complexity with my flight schedules and making the day a little bit shorter in terms of how we get through. So I really appreciate the efforts that have gone into allowing me to be here today, and waiting for my clicker so I can maybe. And it won't run on the slide mode. So what I'm talking about today, and yesterday we touched on what are the innovations happening in the treatment delivery systems. While we were talking about the introduction of Halcyon with an integrated environment, what the advantages or the advances in the treatment platform have been, I also mentioned that we will touch on what is happening from a software portfolio development, from an integrated version, and we've also seen what the requirements and the challenges in the field today are. What that really brings me to today is the advances in the software portfolio. So today I do want to touch on that, but before I get into the details of the advances there, I want to acknowledge that all this morning and yesterday we have seen the importance of the patient navigation, the complexities in each of the steps. So what I want to also recognize and highlight when we take a step back is that cancer care is really complex. And it doesn't just start with the treatment delivery system or from the imaging as we started the day today, but it starts right from those screening protocols, right from that one single diagnosis that can feel different. And there it goes. So they why these fragmented ecosystems still exist and what are the points that we can help with in simplifying. So while each of those points is never going to be a complete linear journey, but where we can really support is bringing those siloed data sets together, is to bring all of these specialists to be working from one source of truth. So you don't have to spend your time in duplicating that data. You don't have to spend your time in simplifying the elements that can harbor collaborations and can work from that one unique and a unified data platform. So towards that, how do we provide the necessary ecosystem? That is through what we call as ARIA Core. Now, ARIA Core is our software platform, is our platform of oncology management systems that provides the backbone of radiation therapy. This gives you the oncology information system, which creates and manages every single data point, every single patient appointment, encounter, whether it's with your radiologist, whether it's with radiation oncologist, whether it's a nursing check appointment, whether it's from a consultation, all of those elements can be saved within ARIA Core. Now, the benefit of this system is not that you have one place for all of the patient appointments, but the benefit, the true benefit of the system is that it has a single database, not just for the patient data systems, but across the entire journey. So you have your treatment planning coming from the same source of data. You're not having to import and export your images, whether it's CT data set, whether it's MRI data sets, ultrasounds, dental appointments, any of that. Everything is in that single database. So you have all of those elements from ARIA Core. And here you see multiple modules of ARIA Core. At the center is the database that is accessed by the oncology management system, that is accessed by mobile access. So we have ARIA Mobile, which as radiation oncologist, or any other professional, if you're on the go, how do you still access the data so you are not blocking your team back in the department from moving forward? If you needing to just approve something, look at some data sets and continue, you can do that while you're on the go through your ARIA Mobile. The radiation therapy management, the treatment planning. We now also have a new module called Insights, which gives you the ability to analyze all your data. And this gives you freedom to be able to manage your resources across your center. So you can analyze going, okay, with so-and-so number of staff and with across the different machines, where is my gap? Which machine is overbooked? Which machine has the potential to get more patients on? Who are the staff members that are skilled? And all of that data, but also management of your clinical data trials, clinical trials, management of and optimization of your QA platforms. All of that can be done through the Insights dashboards, and they can be customized to your departments. And the patient engagement. So we've talked a little bit about the need for patients to be part of their treatment journey. We've highlighted that patients are more and more wanting to be engaged and have a decision in their own treatment journey. And that can be done through a platform called Nuna, which is a patient-reported, patient outcome-reported management system. But it also allows patients to report their symptoms through the patient diaries and through abilities to contact the clinics directly. What that means is that once they have, even if it's at 2 in the morning when they're at home, if they're experiencing a certain symptom, they can report it via the app without having to wait in queue for the phone calls or to be able to travel multiple kilometers to get to the hospital. They can report it on the app itself, so the clinic can then be triaging, saying you actually do need to come into the clinic, or this is not as severe, you can manage it in this way at home. So that is the power of Nuna, especially for patients that are not at the clinic in that moment of time. So moving gears a little bit, I promised we start with the treatment planning journey and how are we making the advances, especially taking the AI into consideration. How are we bringing the data silos in treatment planning? So I talked about the single database used from ARIA Core. Now that same database is running as the main thread across Eclipse. And Eclipse can touch on all the other patient touch points that is required to complete their journey, that is required to get your imaging data sets. So once your imaging data set is acquired on either the CT or the MRI or ultrasound, you have that image residing in the ARIA Core database, which is then accessed by Eclipse, by Velocity, which gives you an ability to register and do multiple different types of registration in the platform. But then we go into the contouring element and how that uses the same data set, how that is then automatically saved, and I will get into more details of it. But we will touch along that journey from registration to contouring to planning to optimizing the plan, multiple treatment techniques that plans can be generated, and then the approvals, etc. So once again, when we are not in an integrated environment, there is a lot of studies that have shown that the more and more of errors creep in because there is manual movement and transfer of data. Up to 39% or almost 40% of errors that are happening in radiation therapy can be avoided if you're automating that data transfer. A lot of that comes down to the manual transfer of data. So if you have an integrated treatment planning system and an OIS, that eliminates the manual need for moving and importing and exporting. So for our platforms, once you finish the plan, you don't even have to export it to get the treatment delivery system. As soon as the plan is approved, you have it available on your treatment delivery system so it can be delivered and it can be QA'd on there. So that gives you the efficiency improvement. And once, even if it is 3 clicks, even if it is 2 minutes per patient, when you scale it up for 100 patients, 200 patients, it all adds up. And that efficiency gain, as per the studies that have been published, shows a 29 to 30% increase in efficiency based on these sorts of elements. The other aspect is when you think about all the different parts of the system that requires this import-export, that requires the multiple steps, that can save you almost half an hour per patient. And that is significant when you integrate or when you add it up for close to 100 or 200 patients. So I did digress a little bit from what I started to talk about with regards to the AI contouring. So I will keep us moving forward and talk about what the value of integration in AI contouring itself is. Or we start with why do we need AI contouring today? So while on the one hand we were talking about the holistic patient journey going and the importance of integration, the manual elements of it is the most pronounced in the contouring time. And you as radiation oncologists, some of you here in the audience, know how long you spend just contouring organs at risk. Here, if you imagine that as soon as your scan is done on the CT, when you get that scan opened in Eclipse, all your contours are already coming in along with the scan. Then you've at least saved 20 minutes if I'm being very, very conservative per patient. Or sometimes up to even 70 to 75 minutes if it is a complex head and neck case, and our head and neck colleagues here can assert or confirm that time frame that it can take based on the number of or the complexity of the plan. So you're saving all of that, but the bigger advantage there, more so than the efficiency, is the standardization. Because no two oncologists contour the same. Getting those protocols standardized and allowing the same level of accuracy across becomes quite a challenge. So that standardization and following of the protocols becomes extremely valuable in these cases, especially when you're then planning to automate the next step in the process going forward. Especially when you're trying to bring in AI in multiple other elements, you know very well from using ChatGPT, from using everything else, that AI is only as good as your data is. Whatever data you are inputting into the environment is the basis of the accuracy of what your AI models are going to generate, and therefore having that standardized data sets, having a standardized way of getting all your contours done is extremely valuable to get yourself ready. Also, that structured data set is going to set the foundation for your future department. So getting that structured data set ready today is going to give you value tomorrow and is going to help you become more efficient in that space tomorrow. What does AI contouring additionally do? So far we've been talking about reducing the workload, we've been talking about standardization, that seamless integration, but I've also, and maybe I'm missing a slide there, what I also wanted to highlight is so far we were only talking about organs at risk. We were only talking about contouring that is based on CT scans. Now you are able to have AI contouring on MRI scans also, but also for multimetastasis. So when you have the brain or multimet in the brain, you have an AI contouring ability to contour all your targets, not just your organ at risk. All the targets can also be contoured through AI contouring. And when you combine that with something like a HyperArc solution that is an automated planning as well as an automated treatment delivery, your entire patient journey becomes a very seamless automated journey that gives you back at least a couple of hours when you think about what you're treating those patients or how you're treating those patients today. So that gives you those efficiencies and an automation, but also frees up your capacity in the department itself to do and to focus your time on the patients and their well-being and their whatever their attention requirements are. So that was AI contouring, and a value of the unified platform, as I have highlighted, there is more standardization that reduces the manual interventions, but also makes the efficiency and the handover of tasks go seamless, hence reducing the risks or errors that can be creeping into your environment. Next step into that part is how do we then go from there to automating our planning itself. Now, planning on one hand requires personalization. So automation without the personalization element is no good to us. So how can we keep the personalization element while making the plans go faster or give you the ability that you can really plan in an automated way? And that is where Rapid Plan comes in. And Rapid Plan has been around for a number of years. However, I do want to bring it into this discussion so you have a visibility of how every step in that patient journey can be automated now. What is Rapid Plan and what is the value of it? While I talked about standardization of your contouring protocols, Rapid Plan enhances that and elevates that to the next level by giving you a standardized way of planning across every body site. So if you have some specific protocols that you're following for prostates, and if you've got 20 patients that you've put in hours in the planning timelines, then all of that knowledge that you've acquired doesn't have to go waste, and you don't have to reinvent the wheel for every time you're trying to treat another prostate patient. That plan can go into the model generating, and you can really use all of that knowledge, put it in Rapid Plan, create a model out of it, and therefore when you're using it for the next patient, it automatically gives you a prediction of what your DVHs can look like, what your dose distribution can look like, and hence your oncologists are able to then say, yes, this is the outcome I'm looking for, or I need a little bit of tweak here. So that whole process can reduce the time by at least 40%, can improve, or 95% actually, in terms of planning time, because you're not creating a plan at all from scratch, and can reduce the number of optimizations or iterations that you have to go by 70%. And that really means that you're reducing that time in planning and efforts in planning for every single patient down to almost 20 to 25 minutes, which could easily have been 2 to 3 hours per patient, depending on the complexity today. So that is what Rapid Plan does, and and what it is a knowledge-based planning system. So this is what, well, AI and machine learning are very new terms relative to where, when Rapid Plan was introduced, we didn't hear too much about AI. We knew of machine learning, but what this is that base model of machine learning. It is acquiring all your patient models or all your patient data sets, and you can collect that plans, like I said, put it in the model. Along with those plans comes the patient geometries, the patient anatomy, the plan geometry, and combines that to give you the plans, to give you the dose distributions, and therefore you are using all the knowledge and not letting and reinventing the wheel every time you're planning. So that was Rapid Plan. Now, I yesterday alluded to the introduction of a new technique. So this is not IMRT, this is not BMAT, this is a new treatment planning technique called Rapid Arc Dynamic. And we introduced this a couple of years back, and this is a turning point in arc therapy. Why is it a turning point in arc therapy? Because it is created from a whole new set of algorithms that can really, we call these blue lake algorithms. So it is really designed to have taken into consideration what your hardware can do and design your software applications based on the ability of the hardware also. These optimization algorithms are created from the ground up. So you have the ability to really take into consideration what the personalization part of your plan is requirement, and take that into the optimization of your planning itself. The other element of Rapid Arc Dynamic is the ability to create static ports during your arc therapy. So imagine if you're doing a VMAT technique or an arc, that means you're starting your gantry in one position, going, delivering the arc, and stopping at another position. Now, with the introduction of static ports, means you start your gantry, stop at a certain angle that is most desirable for that specific plan, deliver the dose boost or the boost in that specific angle, and then continue with your arc delivery, and so on, up until the point where you've achieved the desired dose distribution and the desired organ at risk bearing. All while your collimator is also rotating to match the anatomy and the direction or the angle of the anatomy. So that gives you a really, really specific way of how a rapid plan or rapid arc dynamic can shape the dose much more accurately and gives you much better organ sparing, because it is also fast. And so while it's giving you that sparing, it is doing that without needing additional resources from your team, from your staff in terms of planning, because the optimization algorithms are so fast that you do not need to wait. So today, maybe some of you are going away for coffee or maybe lunch after letting it run for its optimization cycle, but with this algorithm, you will not even have time to go get a coffee. Before that, it will have finished its iteration. So you will be able to create that optimization much better and in a much shorter time, while the delivery speed is also increased. Not as significantly, admittedly, because you are introducing static ports, but you're now able to reduce the number of arcs that were once required to deliver the same plan. So what our current clinical users are reporting with regards to what the advantages they have found is in breast cases, for example, they have reported a 22% reduction in a heart dose. So think about your left breast patients. Now, these patients may be getting better today, but 10 years down the line, they are reporting comorbidities for cardiovascular diseases. They're reporting comorbidities or toxicities even with cardiovascular diseases. Now, if the heart dose can be reduced by 22%, you may be eliminating that 10-year cycle. So of course, I do not have the data to prove that today because the technique has just been introduced last couple of years. So we will have to wait about 10 years to get that data and validate it. But the dose reduction of around not just heart dose, but all the other cardiovascular doses that are reduced or cardiovascular structures that are reduced in the doses is already showing a predictive model that can be showing reduction in those morbidities that we are talking today. They've already reported reduction in their planning and their optimization times. They're reporting how reduction in number of ARCs is valid, and they're already reporting more and more such clinical benefits from reduction of and sparing of organ at risk doses across different body sites. And I've only just talked about breast, but the same is true for lungs, the same is true for pancreas, the same is true for a number of other body sites. And if you are interested, we do have a list and bibliography of all of these publications, so feel free to reach out and I can share all the clinical evidence that exists around the rapid arc dynamic. So this goes into a little bit of details in what this looks like, what the algorithm looks like. So I've talked about the results in seconds. It is a deterministic algorithm, which means that no two, so it is calculating from your inputs. And it is an iterative approach, but it's not going to give you the same results if you've changed the objectives. But what deterministic really is meaning is that if you haven't changed your goals, if you haven't changed your optimization parameters, then the two iterations will give you the exact same results, which today you're not having that trust in. So the algorithms is building on your trust, and the algorithm is building from your inputs. The last is the intuitive interaction. So you can really use and drag your isodose lines to be able to shape your desired dose distribution along with it. So I won't go into too many details, but I would love to interact and invite you to come and talk to us if you need more information about it. But this shows you what the rapid arc dynamic static model allows you to do. So it is a very intuitive user interface that allows you to set your angles at your desired ports and allows you to shape the modulation. So it also shows you what the collimator or rotating the collimator at the desired angles could look like. And going forward, it talks more about the dynamic collimator, but also about the plan optimizer that I have already discussed. Finally, it also allows one additional, and this may be the favorite feature of rapid arc dynamic, because as a physicist, as I told you yesterday, in the clinic, I have spent hours trying to get that virtual bolus aligned better and to introduce that on every field for the patients. Here, having the auto skin flash tool means you are not having to do that. That itself saves you at least 20 minutes, and any radiation therapists in the room, please confirm that you are spending at least 20 minutes on if you need to add a virtual bolus to a patient. The skin flash tool is automatic. You can just, with a click of a checkbox, can automate that and introduce the skin flash. That gives you the robustness in your plan, and that allows you to introduce the bolus without having to go through the painful association of the bolus, creation of the bolus, X, Y, and Z. So going forward, I talked about hyperarc briefly yesterday, and this gives you a little bit more of an insight on what hyperarc truly is. We talked about how in AI contouring, you can already have AI contours define your MRI-based metastatics. So your contours are already automated. Once you've got it, it is with click of maybe 6 or 7 clicks that a plan can be generated. That itself is automated, but it uses algorithms and it uses the automatic low dose objectives, etc., to really give you very defined dose distributions that reduces the bridges of the dose bridges between two mets. And that could be very important and very crucial, especially when you're treating multiple mets. So there are really defined normal tissue objectives for HyperArc, and that is specifically for your SRS multi-met treatments. And that also includes not just automation in planning, but also automation in the treatment delivery of it. So again, it is a single isocenter multiple target SRS treatment that can be automated across the board. So going forward, I wanted to just briefly mention multiple criteria optimization, because this allows you to remove that iterative process between the planner and your radiation oncologist, where once a radiation oncologist has said, these are the objectives, the planner goes away, creates a plan, and once the radiation oncologist looks at it, doesn't like it, wants to change something, then adds another iteration, and so on and so forth. Here, you could be sitting with the radiation oncologist while they are just dragging the isodose lines, and the slider bars there could help you with optimizing, with prioritizing where you want the objectives to be prioritized, which ones need to be locked in, and you could finalize the iteration or the optimization while they're sitting with you. So no need to have that iterative process, and you could cut down your time in terms of what the requirements are that itself. I won't again go into the details of those, but we have a lot of information if you're interested. Very quickly, with the introduction of version 18.1, which was last year, we have already demonstrated improvements in that speed with regards to 56% reduction in time for head and neck, 50% on lung and pelvis, and that was only with the advances in the algorithm itself. We haven't even talked about the specific treatment planning based algorithms, right? And that introduces, if you have a GPU, then that again saves you even further time of close to 70%. So your time requirement for each planning stage and each element of that is really coming down, while your accuracy for each of that is increasing. So I'm not taking too much time here, not just for your time, but also so I make it for my flight. So please bear with me on that. But I do want to close with talking about the LEAF models and the SBRT NTO. So there have been significant R&D in the LEAF model area, because we've heard when all of the physicists here and across the world were talking about how there are inaccuracies in the modeling of the leaf, in the leaf tip. Now that leaf tip is modeled, but so is the screws, and so are the tongue and grooves effects modeled. And we are calling it an enhanced leaf model, which has improved the accuracy down to 1% or 1.5% for TrueBeam and 1% for Halcyon. We've also introduced SBRT NTO. So while HyperArc and the SRS NTO was specifically for brain, SBRT NTO gives you the ability to optimize for the body. It doesn't give you the automated treatment delivery. I will be the first to highlight that, but it does give you the ability to optimize your plan such that your dose bridges are reduced, such that you don't have to introduce those concentric circles just to be able to plan and optimize better. So SBRT NTO already gives you more and more of that ability and the control. And finally, I do want to talk about if you are struggling in implementing any of these, we have services available within the organization that can support you in all of your needs. But before I play the video very briefly, I also want to highlight that we have a local team available for your support, whether it be from the machine part, whether it be from the software part, whether it be in an implementation element. The local teams are well trusted and well trained in all of these elements. You probably all know Rufus. They are always around, they're always present. But I would also like to give one word of caution with trusting third-party systems or third-party teams with your machines, because these are not team members that were trained by us, so we cannot validate their use of our machines. We cannot validate third-party applicators. I kept getting asked about number of questions with brachytherapy applicators. So we cannot validate third-party applicators on our machines. So be very, very cautious, especially with brachytherapy when you're introducing these. With that, I do want to play the video so you get an
Thank you so much for that insightful talk. I think it's just something, AI is here to stay with us. So coffee break is just around the corner, and we have 2 more talks remaining. We'll have Dr. Mongare from KNH, who is a radiation oncologist, to give us a talk on precision radiotherapy in CNS tumors. He's also a lecturer at University of Nairobi. Karibu, Daktari.
Good morning, everyone. I'll be presenting about precision radiotherapy for CNS tumors. Okay, so our outline will be as follows. I'm going to look at the introduction, brief definition, the clinical rationale around it, the history, technical modalities, the target delineations and margins, evidence, future directions, and the take-home message. So you could define precision radiotherapy as the multidisciplinary integration of advanced imaging, biologically optimized fractionation, and highly conformal dose delivery to maximize tumor control while minimizing damage to functionally critical neurostructures and preserving neurocognition. It is not a single machine or technique. It is a philosophy that starts with seeing the tumor in relation to eloquent brain, continues with planning, dose follow-off measured in millimeters, and ends with a patient who retains their memory and function. So the clinical rationale behind it is to uncouple tumor control from neurocognitive decline by exploiting biological and physical differences between malignant and normal CNS tissue to widen the therapeutic window. We are moving from treating a contour on a scan to treating a person with a future. So precision radiotherapy allows us to give enough dose to kill the tumor and no more than absolutely necessary to the brain that surrounds it. This is not just physics, that is medicine. So the history of how it came to be. In 1951, there was a Swedish neurosurgeon called Lars Leskel who described the concept of stereotactic radiosurgery. Well, you may be asking why a neurosurgeon, but they used to have tumors which were deeply seated and used to be quite risky to get them. So they may have thought about a way of safely managing the patient without causing morbidity. And that's why in the history of stereotactic radiosurgery, you'll see there are many neurosurgeons who've taken part in the development up to where we are now. And in 1961, the first gamma unit installed in Stockholm, Sweden. They had 179 sources of cobalt-60 distributed with collimators to create a sharply circumscribed disc-shaped lesion. Of course, that has been refined. It's more refined now. It's not like it was at the initial stages. And in 1983, the first clinical use of linear accelerator for stereotactic radiosurgery was reported. And this was again by neurosurgeons from Argentina, but I can't remember their name. In 1997, Adler introduced the CyberKnife. That was in the States, I think Stanford. And they used a frameless stereotactic radiotherapy system that mounts lightweight 6MV linear accelerator on a highly robotic arm. So for the technical modalities, precision radiotherapy of CNS tumors is delivered through a toolkit of stereotactic localization, conformal dose sculpting, image guidance, and motion management using modalities ranging from photon-based SRS, VMAT, to particle therapy and real-time adaptive systems. I think you've seen one of the presentations that were done about protons. And in that table there, I've just given some of the modalities and what it does and the clinical indications. For instance, for SRS, when giving single fraction, where they deliver 18 to 24 gray in one fraction using a rigid framework mask with sub-millimeter accuracy. And we're going to see in a later slide how these doses came to be. And the indications here are like brain metastasis, less than 3 centimeters or less than 3 lesions, arteriovenous malformations, vestibular schwannomas, and the likes. I'm hoping my slides are not mixed up. When I was trying to convert from Keynote to this, I think they got mixed. So you'll bear with me. So the photo there shows, for those who have not had a chance of seeing a CyberKnife, there's one in KUTTR. And that's how it looks like. There's the Linac mounted on a robotic arm. And the patient lies down there, and then you can see the couch, the cameras, the scans that are used for treatment of this patient. And on the image there is a gamma knife, which is also used for stereotactic treatment. And for linear accelerators, you still have the linear accelerator-based SRS treatments. So when talking about precision radiotherapy, there are 4 clinical pillars to consider, and one of them is anatomical vulnerability. See, the problem without precision, the CNS organs at risk have extremely low radiation tolerance. But when you have precision, with the sub-millimeter targeting via stereotaxy and MRI co-registration, the patient benefits by avoiding morbidity like blindness, deafness, brainstem necrosis, and memory loss. Another pillar that's considered is infiltrative biology. Tumors like glioblastoma extend microscopically beyond the visible enhancement. And the solution with precision is biology-guided CTV expansion and dose painting, e.g. 60 grade to GTV, and 46 to 50 grade to the flare volume deals with that. So you don't have a large volume of the brain being treated. So it's able to treat microscopic disease without irradiating the whole brain like you'd have previously, maybe in the past, where you're using whole brain radiotherapy. There's the dose response paradox as well, another clinical pillar to consider. CNS tumors, especially metastases and low-grade gliomas, have low alpha-beta ratio. They respond better to high doses per fraction. So the only way to navigate to that is by using precision so that you are able to spare as much normal brain as possible. And the SRS exploits this difference, while normal brain, low alpha-beta, tolerates it poorly if volume is large. So as some of the studies showed, this achieves more than 85% local control with fewer fractions, and there's patient convenience and also cost savings. Another final pillar to consider is cumulative toxicity. When using whole brain radiotherapy or large fractions, there is progressive leukoencephalopathy, and dementia and secondary malignancies can arise later in the patient's life. So the solution that comes with precision is there is reduced integral dose to the normal brain, as most of the dose will be deposited where the tumor is. And this preserves neurocognition and the quality of life, especially in long-term survivors. So this is just a table showing the target delineations and margins. These ones are as per RTOG and ESTRO, where you have GTV defined as the visible macroscopic disease, and how it's delineated. You have the T1 weighted post-contrast enhancement plus resection cavity, if post-op, then the CTV with the microscopic infiltration and the margins indicated there, and the other targets, as you can see. So I'm going to focus on stereotactic radiosurgery. We don't have much time to talk about all the precision radiotherapy that there is. So some have called it as the knives of radiation, which is the highly precise, non-invasive or minimally invasive radiotherapy technique that delivers a single or limited number, typically 1 to 5, of high-dose radiation fractions to an intracranial target using stereotactic localization and image guidance to achieve sub-millimeter accuracy, with this steep dose fall-off to spare adjacent critical structures. It can be delivered via dedicated systems like the gamma knife, the cyber knife, or modified linear accelerators with specialized collimation. So you could say that SRS is precision radiotherapy in most elegant form. And I will spend some time talking about LINAC-based SRS. Like you all know, in the radiation oncology space, electrons are accelerated to a tungsten target, then photons are produced and used to deliver the treatment. So the convergent beams or arcs are used to target a well-defined lesion, and you have steep dose gradients at the margin of the tumor and normal tissue. So that helps in the patient in that they suffer less toxicity. And some of the techniques that are used with this LINAC-based are static MRT and VMAT. I have a diagram showing VMAT targeting at a lesion in the brain, and you can see how the arcs are made, and a lot of the dose is deposited at the target. So for evidence, how did the doses that are used in precision radiotherapy come to be? And I'm going to talk with special reference for metastatic brain disease. So one of the seminal studies, the RTOG 9005 by Shaw et al., published in the International Journal of Radiation Oncology, Biology, Physics in May 2002, they set out to determine the maximum tolerated dose of single fraction radiosurgery in patients with recurrent, previously irradiated primary brain tumors as well as brain metastases. And these were patients between 1990 and 1994. So they had 168 patients with solitary tumor recurrence, which had to be less than 4 centimeters after the prior brain radiotherapy. And the radiotherapy that had been given was between 30 and 60. 30 was for the metastatic ones, and then 60 were for the primary ones. So the patients received single fraction SRS, and dose was dependent on the size of the tumor. And they did the planning on CT or MR. They also allowed gamma knife or LINAC, and the dose was prescribed to 50 to 90% of the isodose line. So the question was operationalized through a dose escalation design. So the patients were grouped by tumor size, less than or equal to 2 centimeters, another group 2 to 3 centimeters, and the other last group 3 to 4 centimeters, 3.1 centimeter to 4 centimeters. And the initial doses were set at 18 gray, 15 gray, and 12 gray respectively. So these doses were escalated in 3-grade increments, provided that the incidence of unacceptable CNS toxicity remained below 20% within 3 months of treatment. So ultimately, the final established maximum tolerable dose was 24 gray, 18 gray, and 15 gray for the 3 size groups respectively. Though for the tumors which were less than 2 centimeters, the limit was determined by investigators' reluctance to escalate to 27 gray rather than excessive toxicity. So there was another study that came later by the Cleveland group, which was published in the Journal of Neurosurgery in 2006. And it was a retrospective analysis of 202 patients treated at Cleveland Clinic using the RTOG 9005 dosing treated using gamma knife. So from their analysis, they found out that for those tumors that were given 24 gray, which are less than 2 centimeters, they had 85% local control at 1 year. The ones that were given 18 gray, which were the ones between 2 centimeters and 3 centimeters, the 1 year local control was 49%. This directly implied that the RTOG 9005 dosing scheme, which prescribed lower doses for larger tumors, resulted in inferior local control for those larger lesions. So this finding was a key step in moving the field towards fractionated SRS regimens for larger metastases. Another study that may be of interest was the Italian study where they did multifractionation for multifraction SRS for lesions more than 2 centimeters. And they did a comparative analysis of 289 patients that were treated with SRS for brain metastases that were more than 2 centimeters. So some patients got the RTG 9005 single fraction regimen, while others got 9 times 3 fractions, 9 gray times 3 fractions. And they noted that the 1 year local control improved with 3 fractions SRS. So the local control was 77% for single fraction versus 91% for the multi-fraction, and the p-value was 0.01. They also noticed that there was decreased radiation necrosis with 3 fraction SRS, as the radiation necrosis was 20% with the single fraction and 8% with the multi-fraction. So, the future directions. What is in store for precision radiotherapy? So we are looking forward to a time when there will be biology-guided and adaptive radiotherapy with MR, Linux, and PET-guided systems, allowing us to treat not just where the tumor is today, but where it will be tomorrow, and which parts are most aggressive. You also have flash RT, ultra-high dose rates, which may spare normal brain entirely. If the flash effect translates to humans, because at the moment it's preclinical, we could treat CNS tumors with virtually no cognitive toxicity. And this is a game changer. Then there's a synergy with immunotherapy using SRS not just to control brain metastases, but to trigger systemic immune responses that control disease everywhere. And also, potential future direction is personalized fractionation driven by radiomics, liquid biopsies, and hypoxia imaging. So we prescribe the right dose to the right tumor in the right patient, not just based on size alone. And of course, already we're in the AI space, like the other presentation was given. So what's the take-home message? Precision radiotherapy is not about better machines, it's about better outcomes in CNS tumors. And precision means curing without collateral damage. Thank you. That's the end.
Thank you so much, Dr. We are on to our last lecture. Do you have any urologists in the house? Any neurosurgeon? Anyone? The next topic is about to raise some major questions. So it's my honor to invite Prof. Mark Roche, who is one of the world's leading authorities in radiation oncology and prostate cancer, whose research has helped define modern standards of radiotherapy across the globe, Beyond his standing scientific contributions, he has been a tireless advocate for equity in cancer care, mentorship, and global oncology. Today, we are honored to learn from his wealth of experience and expertise. Please join me in giving a warm welcome to Prof. Mark Roche.
Thank you very much. I can't tell, those are a lot of good talks and a lot of information. I'm sure there's fatigue, and not just me from flying 18 hours to get here, but just sitting and hearing all these lectures. So I hope you can stay awake for part of my talk at least. The bottom line is that for many years, there's been controversy about surgery versus radiation for prostate cancer. And one of the problems is that the urologists, I don't know if there are any urologists, probably not any urologists in here, but urologists refer us to patients. So you don't want to irritate, agitate, or piss off your urologist because they're sending you the patients. And also, urologists are hard workers. They were taught a long time ago that the best way to treat prostate cancer was to cut out the prostate. And they believe that. And even patients come in, they say, Doc, I just want to get rid of it. I want to get it out. But the take-home message today is that the preponderance of evidence suggests that the best treatment for prostate cancer is radiation, period. And it's not just, you know, there are a lot of quotes that I like to use when I give talks. One of them is, everybody has a right to their own opinion, but not their own facts. And my presentation will basically focus on some of the facts associated with prostate cancer outcomes. So one of the reasons, so there are a lot of biases, and one of the reasons that people have been convinced for a long time that surgery was better is because of the type of data that was used to compare surgery and radiation patients. It's counterintuitive. I mean, you think if you cut it out and it's gone, I can't tell you how many times patients have come to me after they had a radical prostatectomy and said, I don't know why my doctor sent me to you. I had my prostate removed, so how can I have cancer? And they don't understand the biology of prostate cancer. So the bottom line is that the biology of prostate cancer is a real thing. The Gleason score, the risk of microscopic disease, the technical aspects. You know, a radical prostatectomy is not actually a radical operation because they want to spare the rectum, they want to spare the neurovascular bundles, they want to spare the external sphincter, and they have all these structures around there. We can radiate those things and leave them in place. So part of the confusion, and one of the most important, these are two important studies that are based on population-based data. So the study on the left was written by a doctor who looked at data from adjusting for all the known variables using, I think it was SEER data, surveillance epidemiology end results. And what you can see is that if you look at survival rates, that men who underwent radical prostatectomy had a better survival than people that did not even have cancer. Now what that's telling you is that these patients are highly selected. The median age of diagnosis of prostate cancer in the US is 66 years. Now, by the time men get to be 66 years old, I can tell you there are a lot of men that are in terrible shape. They've been smoking, they've been drinking, they're overweight, they got diabetes, they got all these medical problems. And those are not the ones that the surgeons want to operate on. And many times those patients say, look, I'm not a good candidate for an operation, so I'm not going to get an operation. So the men who get radical prostatectomies are healthier than men in the general population. And this other study is an extremely important study. They looked at 13,000 men, and they were looking at the risk of death. What did the men die of? And if you look at the data, and I don't know if I can generate a mouse here. Can you see that? No, you can't see it. Do you have a pointer? No. Anyway, these numbers represent standardized mortality rates. And so if you look at men who undergo radical prostatectomy, their risk of heart disease, 0.27. Their risk of chronic lung disease, strokes, diabetes, car accidents, infections, those numbers are incredibly low. Surgery is not causing you to have a lower risk of getting in a car accident. This is just a reflection of the differences in the people who choose to undergo surgery. And there have been, this is, and I'm actually, in the interest of time and fatigue, I'm going to go through this very quickly, but one of the most popular papers that the urologists at every major meeting that I went to back when this paper was published back in 2015, this Dr. Wallace from Canada did a systematic review and meta-analysis of all surgery studies versus radiation studies. And he concluded that surgery was better, and he used this methodology to show that, you know, that there was no bias. And again, in the interest of time, I'm going to skip discussion here. The bottom line is that the technique that he chose to show there was no bias had been proven previously to not work. So he used a bogus technique to do that. And there was clear bias. There were studies that he included in his analysis that have been analyzed and shown to be based on flawed data. So this meta-analysis, the surgeons were so happy when they saw it. Fortunately, we have now a number of randomized trials that have answered these questions. But this is just one of the curves that showed the selection bias, and I had written a letter back in 2007 explaining the biases there. This is another study from my institution, Dr. Cooperberg, that looked at large data sets and concluded that the survival rates were better in men who underwent surgery. Fundamentally flawed, again, I'm going to skip the details there because we now have data from randomized trials that I'm going to just move to in the interest of time. But while I was waiting for that randomized data to mature, this is an analysis that we did looking at adjusting for all these various variables, and we concluded that the cancer-specific survival with surgery and radiation were within 1% of each other. And again, that's been borne out by the randomized trials. So this is the important trial that I think we really need to pay attention to. You're all familiar with the PROTECT study. This is a study that was done in the UK. Patients were randomized to observation, surgery, or radiation. And the bottom line is that the metastasis rate was reduced with either surgery or radiation, and there was no difference between the two, and that was with the 10-year follow-up. They've subsequently published 15-year results and shown that the surgery and radiation are superimposable out at 15 years in terms of metastasis-free survival, and a little bit better than patients who were initially observed. But more importantly, so the outcome data look the same, but the complication rates don't look the same. So the risk of incontinence, the risk of erectile dysfunction, the risk of those things which are important to men in particular were better with radiation. So radiation has equal cancer control rates going out if you take all the patients at 10 and 15 years, but a lower risk of incontinence and erectile dysfunction. More recently, there has been, and I don't know if you all are familiar with this cribiform histology data that's being discussed, but they've gone back and looked at the data more carefully. These are patients from the PROTECT study. First of all, this slide is just showing that they were generally very favorable patients. And what they showed is that if you look at the cribiform status, whether cribiform negative or cribiform positive, what you see a big difference between the cribiform negative and the cribiform positive, suggesting a much higher risk of metastasis in the cribiform positive patients. So when you're thinking about active surveillance, when you see patients that are low risk that are walking in the door, this feature is a critical feature. And, but the more important part of this, and this is looking, these are the cribiform negative patients. And if you look at the cumulative incidence of metastases going out to 15 and 20 years, in very early patients, there is not much happening. But the patients who need to be treated, these are the patients that are the cribiform positive patients. You can see that the radiotherapy patients are doing much better than the patients treated with active surveillance or surgery. So the bottom line is that in favorable patients, based on data from a large phase 3 trial with 500 patients in each group, that many of the patients don't need treatment. But if a patient has adverse pathology, if they're cribiform positive, the preferred treatment is radiation. And this just shows that in a forest plot. Now, the people in the UK have done a number of studies, PACE A, PACE B, PACE C. This is the PACE A study. So this is a randomized trial of radical prostatectomy versus SBRT, stereotactic body radiotherapy. And what you see is substantially worse continence and substantially worse erectile function. So this is a separate study than the PROTECT study showing the same thing. There are many population-based studies showing the same thing. So when you see a man with early prostate cancer who's a candidate for radiation, here you're talking about 5 outpatient treatments. No catheters, no anesthesia, no incontinence, no increased risk of erectile dysfunction. 5 treatments with a much better outcome than patients treated with surgery. I'm going to skip this. This is about chemo. These are high-risk patients. So the data I was just talking about was for favorable patients. This is a study comparing 2 large cohorts, matched cohorts in high-risk patients that are getting hormone therapy and radiation versus comparing them to a surgical series. And the bottom line is that the radiation-based treatments are better in high-risk patients. So I just showed you the data that we have available showing that in low-risk patients, the preferred modality is radiation. And this is a matched comparison looking at high-risk patients, large numbers of patients, 8-year results. These are patients, again, that are matched, showing better results with high-risk patients. So the fact that sometimes patients say, well, you know, I got high-risk disease, I think I need surgery, the evidence does not support that. And this is actually from my trial, RTUG 0924. This is not published, but this is the largest phase 3 randomized trial ever done in localized prostate cancer. And if you look at the risk of distant metastasis going out, these are only radiation patients. You're looking at a risk of less than 10% at 10 years in patients treated with hormone therapy and radiation. These are patients that had unfavorable intermediate risk or favorable high risk. Favorable high risk means they're clinically by rectal exam, not T3, but they have a high Gleason score and a high PSA, so they're considered high-risk patients. No surgical series has better results. This is a prospective phase 3 trial. If we look at the cancer-specific survival in favorable high-risk patients, 95% at 10 years are surviving prostate cancer with hormone therapy and radiation. No surgical series with comparable patients has similar results. There have been population-based studies looking at Gleason, specifically in patients with Gleason scores of 9 to 10. So these are the very worst patients, looking at surgery versus radiation. The bottom line is radiation is better than surgery. And this is, again, so the same author that did the systematic review and meta-analysis of surgery versus radiation also did one to try to say that radiation increased the risk of second cancer. Now, radiation does increase the risk of second cancer, The problem is that in the studies that he used here, he took patients treated with surgery and used them as a control group against those treated with radiation. And I go back to that paper that I showed you before. If you look at the standardized mortality rate for death from second cancers, that's that 0.45 there in that red box. That's the risk of second cancer difference between men who underwent radical prostatectomy and men who did not have cancer. So the point is that if you have a radical prostatectomy, you have less than half the risk of getting a second cancer just because of how you are selected for the prostatectomy. So you should never publish a study in which you take patients that had radical prostatectomy and compare them to patients treated to radiation and use them as a control group because of this huge bias in terms of patient selection. I'm almost done. So this is a paper that actually I had a young radiation oncologist from Egypt who wanted to come work with me. So he came to work with me, and I said, okay, here's a project for you. We want to look at what is the effect of the patient's age on their outcome for prostate cancer. So we know older people die faster than younger people. But the question is, if you look at cancer-specific outcomes like biochemical failure, like metastases and so forth, the bottom line is that we had observed, based on previous studies, that age was a favorable prognostic factor in patients within RTOG, within our studies. But I had also noticed that there are some studies that suggest that age is an unfavorable prognostic factor in men who underwent surgery. So we did a systematic review. We found all the studies that we could find that reported outcome and used age as a variable 70 plus or minus 5 years. So that means 65 to 75. They take age as a cut point and they look at cancer-specific outcomes. And what these bars show you is that if you look at the patients treated with radiation, over 50% of them showed that age 70 plus or minus 5 years was a good thing from a prostate cancer outcome when you use radiation. And another 20% of them said it was a trend for it to be better, and about 25% said it did not have an effect. So there were no studies during the time period between 1999 and 2023 that we could find that said age 70 plus or minus 5 years was a bad thing for a patient that was getting radiation. But if you looked at the surgical experience, 50% of the studies said age 70 plus or minus 5 years was a bad thing, was an adverse prognostic factor. And what I mean by that is if you take two cohorts of patients and you match them, PSA, Gleason score, and stage to make them comparable, but one group is older and one group is younger, when you get the final pathology, the older patient has more advanced disease. So age was an adverse prognostic factor. And so there were no studies that suggested that with surgery, age was a favorable prognostic factor. So the bottom line is that not only is radiation better than surgery in early stage prostate cancer, not only is radiation better than surgery in people with high-risk prostate cancer, but radiation is better than surgery when you take into account age and performance status of the patient. And this is just a study looking at 30, 60, 90-day mortality with radical prostatectomy, higher. And this is just a summary of some of the reasons that this is a take-home message, is that surgeons are operating on high-risk patients because they were convinced by where they trained and what they thought, and biases in the literature in terms of what we call attribution bias. When you look at what did somebody die of, if the diagnosis is listed anywhere in the first 3 lines of the death certificate, it can be attributed as a cause. So when you have patients that have more medical problems, diabetes, hypertension, other problems, they're more likely to die. And if they're more likely to die, then they're more likely to have prostate cancer called as a diagnosis, and that's more likely to occur in patients treated with radiation. So there's all kinds of biases. I've talked about some of them, and also the 30, 60, 90-day mortality. And I'm going to close with this quote. The wise boldly pick up truth as soon as they hear it. If you ever have a meeting, urology, I notice there's no urologist here. If there is a Kenyan Urology Society, I don't know if there is, and they have a meeting and they need somebody to debate them about radiation versus surgery, I volunteer. And they can give them, I'll take on, give me 3 surgeons or 4 surgeons, and I'll take them all by myself. Thank you very much for your attention.
Thank you so much, Prof. I think we are going to take 5 minutes for questions. Any burning question? Yes, please.
Thank you, Prof. Roch, for such a very informative talk, and welcome to Nairobi.
Thank you.
My question is for radiation oncology. In terms of the technology, we're talking about, you talked about 5 sessions of radio, SBRT, versus conventional radiotherapy. I know most men in our setting, if you tell them that you're going to have erectile dysfunction, that is enough to convince them to go for radiation therapy. I just wanted to know about your thoughts.
Yeah. No, that's true. That's, that's assuming they have erectile function. A lot of them don't, so, But yeah, no, it depends. When a man is diagnosed, when a person's diagnosed with cancer, the first thing is they're afraid. They hear that cancer word, it's bad news. They're just worried about their life. And if the urologist talks to them and says, you can get that out right away, and they trust the doctor, a lot of times they don't even get a second opinion. They don't worry about erectile function. They don't worry about incontinence. They're just afraid that they're going to die. And they don't understand that one of the most interesting things in terms of learning, understanding the biology of this disease is that in a typical patient that walks in the door that I see today, if that patient is ultimately going to die of prostate cancer, between 50 and 80% of those deaths will occur between year 10 and year 20. Most people have no idea what they're talking about. They don't follow the patients. They don't see the patients. But I could give you detailed data that show you that in fact is the case. And when we looked at my trial, RTOG 0924, unfavorable intermediate risk, our risk of dying in the unfavorable patients is less than 0.5% at 10 years. So the bottom line is, if a patient gets good treatment, conventional treatment, hormones and radiation, if they need it for unfavorable intermediate risk or favorable high risk, you're looking at cancer-specific survival rates exceeding 95% at 10 years.
Thank you so much. Any other burning question?
Yeah.
Patients with what do you call it? Favorable high risk. Radiation-based treatment is the preferable option. Is that because the systemic treatment adds to their survival? ADT?
Can you, wait.
So
Ask the question.
Is specifically pertaining the comment that radiation-based treatment is preferable in patients who have high-risk disease. Is there an element that ADT is adding to that survival?
Well, ADT is clearly adding to that survival. We've shown that in randomized trials, patients with unfavorable intermediate, RTOG 9408 is the classic study, but there are other studies that show that adding short-term hormone therapy, whether it's 4 months or 6 months, in patients with unfavorable intermediate risk disease benefit. In high-risk patients, the key question is not whether they should get hormone therapy, but how long they should get hormone therapy. And that's where it gets complicated. That could give a whole lecture on, should it be 18 months? Should it be 36 months? Should it just be 6 months? Should it be 4 months? For a typical patient with intermediate risk disease, if you're going to use hormone therapy short term, the sweet spot is 4 months. You know, we did a randomized trial called RTOG 9910 that showed that 4 months was as good as 9 months, and there are other studies that support that. So the key thing is that if the patients are favorable intermediate risk, in most cases they don't need hormone therapy. In the future, I think what would be a relevant talk would be biomarkers. So I gave a couple of lectures on biomarkers in Morocco and in Argentina, specifically looking at things like Decipher, Artera, Prostox, these biomarkers that can help you define which patients might need hormone therapy, which ones don't need hormone therapy. If you look at the Artera data, and again, I have no conflicts. I don't consult for any of these companies. I don't have any biases, and you know, some of the stuff still needs to be validated, but in the Artera analysis from RTO, based on the Artera assay in RTOG 9408, which is a study of radiation alone versus radiation and 4 months of hormone therapy, 2/3 of the patients don't benefit from hormone therapy, and only 1/3 does. And so if you can define who that 1/3 is, now from my study we have 2,500 patients that we have biomarker data that's being worked through. So in the near future we will have biomarker data because nobody wants to take hormone therapy.
Okay, I have a question apparently for Dr. Beverly. You mentioned in your talk that there is a safe time period after surgery that the patient should have radiotherapy. From your experience and your practice, what's that duration, that safe window? I just wanted you to elaborate on that. Thank you.
So I think the answer is as soon as possible. I think that historically we have said that the patient should wait 2 weeks until there are historical things. In many places, follow-up after surgery tends to be the 2-week window by which time the histology is back. The surgeon has had an opportunity to assess the wound, and then that's when they go to radio-oncology. I would argue in today's world, with more minimally invasive procedures possible, we need to get rid of the 2-week window and treat every patient on an individual basis. The surgeon needs to consider having as short as possible surgery, minimal access, smaller wounds, and reducing the steroid burden so that the radio-oncologist can be brought on board much faster. I think we take too long. I don't think it's always necessary. That's my personal opinion. And maybe one of the ways to get past that is to have regular MDTs that navigate patients for optimized care. I think at the moment we are what Formula One was 40 years ago, where everybody does their bit and then we hope that the car still gets on time. But I think we need to think about patient-navigated pathways that are very much more integrated than they are at the moment. I had a question myself, or rather a comment. I know I'm not a urologist, but I welcome the changes that urology and Red Onc have done towards prostate cancer. I think there's still a role for a surgeon, and I think that our care needs to be integrated. But I hope that the same would also apply for women's health. I think in women's health, we are not using the same forward technologies as we do in prostate. Yeah, so prostate, you're always thinking about, in men's health, we're always thinking about quality of life. I would like to see the same in women's health.
Well, women's health is actually ahead of men's health in terms of,
no.
It depends on how you define it. So in the US, if you look at how much money is spent on cancer care, women's health is ahead of men's. Talking about cancer. If you look at the breast cancer budget that's spent on research, and breast cancer trials were done much earlier, much larger, and bigger. So there are issues related to women's health, clearly, but when it comes to certain cancer sites, there are discrepancies in budgets and that kind of thing.
I think probably I should expand what I mean. When I started my training, radical prostatectomy was very, very common. And there was a clear understanding about what it meant for the quality of life for the patients. And there was a radical adoption of minimally invasive procedures and now even missing surgery completely. A lot of things in women's health don't talk about survivorship and quality of life. So if you think about primary breast construction, it's still not the norm around the world. If you're looking at gynae tumors, the induced menopausal and perimenopausal challenges, if you look at how fibroids are managed, we are doing more, but when you're asking, what does the quality of life for this woman look like? We're still not asking those questions in the way we should.
Well, but if you look at things like breast conservation, you see, women got rid of the big breast operations very early when men were still getting radical prostatectomies. You know, and in fact, I actually literally did this. I went to 3 women who are colleagues, and I said, which do you think has the biggest impact on a person's life, a mastectomy or a radical prostatectomy? And they looked at me like I was crazy to ask such a question. 9 out of the 10 women said, obviously, the mastectomy has a bigger effect on a person's life. And I'm like, they don't understand incontinence, erectile dysfunction. You can do a breast reconstruction. Nobody could necessarily know. And so it depends on your perspective about what's important. But clearly, in terms of preserving function, the decision that many people still consider radical prostatectomy the standard of care, despite the preponderance of evidence that it shouldn't be, I would argue that men's care, in comparing surgery for prostate cancer versus surgery in the breast, those are the 2 most common cancers we treat. Men are way behind women. Women wouldn't be walking around incontinent with erectile dysfunction, and despite the evidence, because women are more, if you want to, I work in community hospitals. If you want to get men screened for prostate cancer, you talk to the wife. The wife will, and they bring them in for their appointments. Women are more health conscious and demand a lot of attention and demand a lot of funding in the U.S.
I think we will have to talk about this over coffee,
yes,
because I hold a very different view as a woman.
I think this doctor may have, I know, but that's the point. It depends on the view. I think he had one other question, and then maybe we can close out. He's been holding his hand for a while.
Prof, I had a question. Thank you for the talk. I have 2 questions. One, I know we've had a long discussion about surgery versus radiotherapy, and in our Euro MDT, I think that's always the discussion, because depending on who sees the patient first, the patient will be oriented whether to surgery or to radiation. Yeah. So I hope one day will come when we see a new patient jointly, then you put, both options on the table. That not being said, number one, I think I'd like your comment on the rectal and bladder side effects post-radiotherapy, because it's one of the things that the urologists are very loud about, that we're not managing well, or are we getting any better? And then secondly is how to navigate or assess for radiation in this era of other molecules like abiraterone, apalutamide, docetaxel upfront. How do we now interpret the benefit of radiation in that setting?
Well, those are great questions. The problem is we don't have enough time to answer, especially that last part. But let me say this. My second talk is about doing the radiation. And clearly, the quality of the radiation depends on the complication rate, right? It's how you do it, not just whether you do it or not. And clearly, one of my biggest problems with radical prostatectomy is I've been to many meetings, and I will see a urologist get up, and he will show somebody else's data. He'll show you the results from Johns Hopkins. He'll show you the results from Catalona, from WashU. But his own results may be published, but he's not talking about his results. So if you're a urologist practicing in Kenya, your experience and your training is not the same, because even in the US, they have high-volume surgeons and low-volume surgeons. And the papers are published by the high-volume surgeons, and most of the surgeries are done by low-volume surgeons, and low-volume surgeons in general have more complications and less success. So the bottom line is that arguing for surgery using some data from the US or Europe, show me some radical prostatectomy, you don't need to show me, it's not going to be better in Kenya, okay? So, and the complication rates in radiation are based on the dose and the volumes that are radiated. And one of the biggest problems in the world, in developing countries, is that people don't use fiducial markers. Fiducial markers, typically, we've been using gold seeds in prostates for more than 25 years. And I think that the urologist's job should be to do the biopsy and put in the gold marker seeds to improve the accuracy of our radiation and send us the patients and let them get the best treatment. And we can talk offline about the addition of other drugs. That's for more advanced disease, but for the patients that are typically, again, you get a 10-year survival rate of 95% for favorable high-risk patients with just hormone therapy, conventional hormone therapy, and radiation. Nearly half of those patients did not get long-term hormone therapy. We left it up to the doctors, and 47% got just 4 to 6 months of hormone therapy, and still the patients. So in terms of adding those other drugs, there are certain patients that might benefit, maybe the node-positive patients, maybe the patients that have biomarkers such as Artera or Decipher that suggest that their phenotype is such that they might benefit, but the preponderance of patients don't need those other drugs. And maybe the last question here.
Yes. Thank you, Mark. I'm just being inquisitive.
What's that?
I said I'm being inquisitive.
Okay.
In the States, a lot of patients are being given some supplements.
Are given what?
Supplements.
Supplements,
by the urologist.
What do you mean by supplements? You mean like?
Prostagenics, Prostar PH, Prostar Pro.
Well, they don't have to be given it by the urologist. They take it on their own. They don't need a urologist to take supplements. But
yes,
go ahead.
Because of the steroid level. And when they are giving their data, don't you think this contributes to why they feel prostatectomy alone is superior to external beam radiotherapy?
I don't think I'm missing something. I'm not sure. What's the question?
The question is that not contributing to why they think prostatectomy is superior?
I don't think that the supplements have anything to do with why they think prostatectomy is superior. When my mother got breast cancer, I said, Mom, so what are you going to do? She looked at me kind of strange. She said, what do you mean what I'm going to do? I'm going to have my breast removed. I said, Mom, you don't need to have your breast removed. You can get a lumpectomy and radiation. So she got a lumpectomy and radiation. So people that don't know medicine think that if they cut it out, it's better. Period. Whether there's supplements or no supplements, most people think, oh, I got prostate cancer, I need to get it removed. And the bottom line is they don't need to get it removed. I don't think the supplements have anything to do with it.
Thank you so much, Prof, for the insightful talk. A round of applause, please. Now, as we are heading for coffee break, there's a surprise for one person in the audience. Who is it? There's a surprise for someone. Who is the camera facing to? Where is she? I can't see her. Which table? It's a surprise.
Lucy, welcome to the stage. So yesterday, when we were happy having the cocktail party, Lucy decided to hijack our Afro cake, saying it's my birthday. So she had to take all our cake. Instead of singing happy birthday Afro, it was happy birthday Lucy. We said, no. We need to do better. So thank you to our president. Special cake for Lucy. So Lucy is our patient who has been surviving cervical cancer. And she has many questions. She came here to learn more the advances in cancer care so she can become a patient advocate to inform out there like treatment is possible and patients are doing well. This is your moment. Thank you. DJ, cut a cake. Tupe ribo.
Happy birthday to you. Happy birthday.
We're welcoming all survivors to join her here. All survivors, please join her. Wait, go, wait. You're going to cut together. Together, yes.
Nauma leo kusema kwa wema. Happy birthday to you. Happy birthday to you. Happy birthday to you. Happy birthday to you.
Asanteni sana, asanteni sana. The party will continue today during the gala dinner. You are all welcome. Please kindly register for the gala dinner tonight. There where the party is going to continue. Asanteni sana. So with this, we are going to close this session. Kindly, we are behind the schedule. I'm kindly requesting everyone, let us take our tea and come back here in the room and have our tea inside the room and we continue, please, so we can catch up with the lost time. So just 2 minutes to go and pick your tea to come back here. And as a brief meeting also going for the AFROC team and the local organizing committee, which will be happening at the holding room. So the local organizing committee, the AFROC members, to the room for 5-10 minutes, we catch up, then we come back here and we join the talk. The first talk is going to be again Professor Mark Roach continuing with what he has started in the previous. Is that correct? Yeah. Yes. Okay, thank you. Yeah, please let us have our tea. Yeah. Thank you so much. Yeah, sure. Okay. And also, if you're not an AFROC member, please kindly register to become an AFROC member.
Good morning.
What is that?
Hi everyone, it's Dr. Catherine Nyongesa once again. Today was the official launch of the African Radiation Oncology Group Conference, and we had dignitaries. Among them, the CS of Health, Honorable Aden Duale himself. We had Professor Anyang Nyong'o. We also had Professor Shaukat, and it was amazing. So we kicked off the meetings at 8:30 in the morning, and in that period before the official launch, we discussed many things. Among them, still patient voice was very key. We discussed broken pathways for cancer patients. Sometimes it's not just the equipment, it is the journey that they go through, and a lot of time is lost when they try to navigate the complex system. Afterwards, we discussed about smarter ways of treating patients using shorter fractions of radiotherapy, which are evidence-based. We also went on to discuss about the role of artificial intelligence in improving access to care. And more so, we had industry players presenting innovative ways of treating cancer patients, showing us state-of-art equipment. And what we know is, apart from the equipment, you need the people. Our CS committed himself to support cancer care in Kenya and positioning Kenya as a leading country in the region. We also talked about partnerships, multidisciplinary care, because no one can do it alone. We had the president of KESHO, Kenya Society of Hemato-Oncology, Dr. Gladwell Kiari herself, who came to talk about PAP inhibitors in prostate cancer. These are new therapies in prostate cancer. And she also reminded us about the upcoming KESHO conference, which will be in November this year in Mombasa. We also met the chair of the Oncology Nurses Society, who also talked about the upcoming conference in September. It will be here in Nairobi at the Weston Hotel. We are all in this together. We talked about the three musketeers, who are radiation oncologists, medical physicists, and radiation therapists. And we also reminded by the Ministry of Health and in support by NCCP that we also need to add on more people. Biomedical engineering should also come as part of sustaining radiotherapy. Many cancer centers, the radiotherapy machines are down because of biomedical engineering support. We had talks by the National Cancer Institute, Dr. Elias Meli, the CEO, who told us what the NCI is doing in expanding research. In fact, they have allocated funds for research, focusing in oncology. This afternoon, we had more talks, industry players, individuals showcasing their science, the research they have done. And of most important, we are also looking beyond cancer treatment. We are looking about cure. How can everyone else get involved in this cure? We have talked about financing. Cancer care is very expensive. And we had people committing themselves on how they will finance cancer care. We've also talked about education in oncology, and many companies committed to promote education, both virtually, running workshops, to reach more people, to create more awareness.
therapies. Thank you.
Great presentation. For our next speaker, Suleiman. Sir Suleiman is a senior radiation therapist at the hospital. Karibu sana.
Good afternoon. Okay, I'm going to talk about our experience of treating a child without sedation for his radiotherapy sessions. So more than 50% of cancer patients benefit from radiotherapy, which demands proper immobilization to maximize the therapeutic window. However, young patients often struggle with the need to remain still during treatment. As a result, daily use of anesthesia over the treatment course has been adapted. Daily anesthesia is resource intensive and confers an increased risk of potential short and long-term complications. This presentation highlights our clinical experience of the successful delivery of radiotherapy to a child without sedation or anesthesia. Our patient was a male 4-year-old with residual high-grade glioma of the frontoparietal region following surgical resection. The radiation prescription is as indicated. We used a 3D CRT technique for his treatment. So anxiety alleviation interventions that we used included patient education and counseling, child-friendly approaches including simulation mocks for the sessions, mock simulations for the sessions, play therapy, and audiovisual. As in, we took the child to the various areas, like in the CT simulation, we tried talking to the child, placed the child on the couch, did a mock setup for him, just to reassure him and to encourage him to go through the processes. So some of the toys that he used, as in the figures, then we noted that mild discomfort was experienced during masking and the first treatment. Eventually, the patient was successfully simulated and completed treatment without anesthesia, as in the child was treated by the same team and in the same machine for all his treatment sessions. So consistency in how we handled the patient made him gradually gain confidence, and the fear gradually decreased. So these are some of the clinical images that we obtained as the patient was going through his treatment sessions. So when the patient was in the treatment coach, we constantly talked to him. We also allowed the parents to come to the control room, talk to him and reassure him. Then upon completion of the treatment, we celebrated the child. We rang for him the bell. We sang for him songs just to make him happy. And in addition to that, we gave him some presents. In conclusion, it is therefore possible to treat pediatric patients without sedation. I would encourage clinics or various treatment units to explore other avenues of making such young patients comfortable before resorting to sedation, because sedation has some disadvantages. It could lead to clinical disadvantages like airway or cardiovascular risks. It could lead to medicine side effects related to the daily anesthesia. It could also increase healthcare costs to the parents because they have to chip in and pay for the extra drugs, pay for the sedation procedures and all that. Then it is also time consuming in that longer treatment times are used. The patients are required to fast. For young kids, they become irritable. So I'd really encourage that to be considered. Thank you.
Thank you so much. We'll quickly move on to the next presenter, Dr. Leila Mod Omar, who is going to be talking about pediatric brain tumors at KNH. Karibu.
Good afternoon to everybody. My name is Dr. Leila Mohammed. I'm a resident in radiation oncology. I'd like to acknowledge and appreciate AFROG for this opportunity to present on our study that we did on treatment outcomes in pediatric brain tumors were treated in Kenyatta National Hospital in Nairobi, Kenya. And this was a retrospective 5-year review between 2019 and 2023. And this was in conjunction with my supervisors, Drs. Njoki Njiraini, Dr. Sarah Muma, Susan Karanja, and Dr. Kalen Kamboka. So, childhood cancers are a significant global mortality, like a global burden, and an incidence of 400,000 patients are diagnosed every year. So, out of that number, about 26% are brain tumors globally. In the sub-Saharan Africa, around 16% of a number of 59,000, and in Kenya, out of 1,050, around 17% of that number is pediatric brain tumors. So the mortality is still quite high in the low, middle, and income countries, as opposed to the high-income countries. And outcomes largely depend on the tumor biology, the time, whether the patient had timely diagnosis or not, and if the patient had access to multidisciplinary care. So with this in mind and the disease burden, we realized that the data, our local data was quite limited, and this is important in policy and also guiding clinical practice, and this is what formed the basis of our study. So the aims of our study was to determine the 2-year overall survival, the mortality rate, the relapse rate, the rate of disease progression, and the factors that are associated with the outcomes, majorly being the mortality. So it was a retrospective cohort study, and we analyzed 305 patients. Out of those, 196 met the eligibility criteria. And these eligibility criteria included patients between 0 and 19 years and who had complete records. For the exclusion criteria was any patient with brain tumor but was above that age diagnosis of 19 years, and anyone who had missing records was excluded from this study. So we recorded 49 deaths amongst the patients we reviewed and 33 recurrences. So on the demographics, so according to the age distribution at diagnosis, we had a median age of 7.5 years and a mean age of days. There's a minority group that actually received either best supportive care or no treatment at all. So in terms of survival on Kaplan-Meier curves, 73% of 0.6% of our patients had a 1-year overall survival. The 2-year overall survival was at 71%, and the 3-year overall survival was at 69%. So these findings at least give us a baseline clinical data and on our survivals, and also they highlight the challenges, especially treatment delays that have an impact on survival. So in terms of stratification based on grade, we found that tumors that had high grade were associated with poor survival. So what is in blue here is the patients who had low-grade tumors. They did better than the patients who had high-grade tumors, which is represented in orange here. When this figure was statistically significant with a p-value of 0.031, showing that high-grade tumors had an important prognostic factor in the survival outcomes of our patients. So to further determine to predict the predictors of mortality, we did a multivariate analysis, and what we found was high-grade histology was also associated with an increased risk of mortality. So that was at an adjusted odds ratio of 3.43, meaning that if you compare a high-grade and a low-grade, the patient with a high-grade tumor had threefold risk of mortality compared to the low-grade tumors. And in contrast, patients who had treatment completed on schedule were associated with lower risk of mortality at an adjusted odds ratio of 0.26. Also emphasizing the need for us to complete our treatment on schedule and avoid delays as much as possible. In terms of age and male sex, that did not show significant predictive value in terms of mortality. So the strength of our study was that it was a relatively large cohort size. We had 305 patients that we reviewed. This was relatively large for a single resource constrained setting. And we had comprehensive clinical and treatment data, and we used survival analysis rather than the crude mortality alone. But however, this is not without limitations. It's still a retrospective design study. We still had missing records, which led to incomplete documentation, and we still do not have molecular classification. And because of these, we have some few recommendations that we need to establish a prospective pediatric neuro-oncology registry, and we need to standardize our multidisciplinary board pathways, as this has shown to really improve the outcomes in our young children. And we need to also improve our follow-up systems and also expand molecular systems where it's applicable. So the findings were consistent with what our colleagues in other institutions have done. To quote Lemon et al. In Western Kenya, this was a similar study that was done, and they also showed that medulloblastoma was their most common diagnosis, which was similar to what we found in our study. However, in terms of overall survival, we recorded a higher overall survival as compared to the figure that was given in the same study in Western Kenya. Comparing to international context, we found the high-grade histology was also associated with poor outcomes, similar to what we found in our study in Kenyatta National Hospital. And in some countries, we found medulloblastoma as our highest leading in terms of the tumor subsite, but in other countries for them it was pilocytic astrocytoma that was leading. So this highlights that in as much as we have some differences depending on whether you're in the low middle income country or the high income countries. So in conclusion is that we found that high grade tumors independently predicted mortality, and we need to continue treatment and also ensure that the treatment is on schedule so that we can improve outcomes for our patients. And this study highlights the importance of early risk stratification. We need to stratify our patients early enough, timely treatment for our patients. The importance of multidisciplinary approach cannot be underestimated so that we can improve survival outcomes for our patients with brain tumors that are treated in Kenya. Thank you.
Thank you, Dr. Leila. That was actually very excellent. And at least this study has laid a foundation for brain tumors. So our next presenter is Dr. Njoki Njiraine. She's a clinical oncologist at the Kenyatta National Hospital, where she's the clinical co-lead in breast and lung carcinomas at the Cancer Center. And she's going to take us through pediatric normal tissue effects in the clinic.
Thank you, and thank you to the organizers of the conference for this opportunity. So just to start off is that is a representation of where children live on the globe. What is in red is basically where we are in sub-Saharan Africa, and that is where the highest population of children between the age of 0 to 14 are. So for these children, when they get cancer, then our problem is already set out for us. Apart from that, it is projected that the children needing radiotherapy will continue to increase, and I think when we got this data, we thought 2035 is very far away. It is now here, and that's where we're sitting with the numbers. And in consideration that this is where the children are, I did not want to put another map on top for DIRAC for where the radiotherapy centers are. Neither did I want to put where dedicated pediatric radiotherapy centers are. Then I think this is already set out for us. So what is PENTEC? PENTEC mirrors QuantTech in adults, but it is pediatric normal tissue effects in the clinic. Professor Louis Constantine he says, the work of his life, because for the last 10 years, he's been collecting data on anything published in terms of normal tissue complication probability to look at how can we predict for what is this level that you will say past this, you will get toxicity in children. But why do we need PENTEC? Professor D'Angelo, who passed on in 2018, who is reckoned as the father of pediatric radiation oncology, then in a statement that he made, he said, cure is not enough for children, because we have to think about after we cure them, what happens after that. They have to live with long-term side effects of radiotherapy. And that children are not small adults. So depending on the age of the child, the site of their tumor, what dose of radiation are you giving? That is something that we always have to have at the back of our minds, and that the association of age at time of radiation and the dose relationship is completely different from what we have as adults. So we have to think of the normal tissue complication probability ratios or formulas in a very different way from adults. That being said, there's a lot of background work that has been done. We know about EMAMI, we know Rubin, we know QuantTech, and now with hypofractionation, we have HITECH. And I hope these are already things that we're using in the clinic. However, the modification of radiotherapy has long-term effects in terms of health and health-related mortality in childhood cancers. And the context here is you get a child who needs, let's say, bone marrow transplant, you're going to give total body irradiation, or a child who has a medulloblastoma that you're going to give craniospinal radiation. You then have to think that if you're curing this child, it's at what cost in terms of their long-term side effects. So we are now improving the selection of patients where we are de-escalating care. Patients, because of adequate imaging, adequate pathology, good surgeons, we are de-escalating their radiation. The second thing is that we have improved radiotherapy techniques. So everybody will show their nice machine, the fanciest one, but does VMAT have an advantage in children over 3D? Because with VMAT, you're giving a higher integral dose. What does that mean for this child in the long term? And again, because we are doing better with systemic therapies, then the role of radiation keeps reducing. I like Dr. Opakas's presentation because in Wilms, even those doses are being adjusted downwards because we are doing better with chemo, we are doing better with surgery, so we may not need to give such a high dose of radiation. And again, we have improved diagnostics. So we are picking up these children earlier, we are following them up for longer, and then we also have to think about how do we image them in the long term. Are you going to be doing CT scans for this 5-year-old till they get to 16 years, or you will adjust your follow-up protocol? So in terms of the methodology, one was the physics considerations, and it's good that here, as people who work in radiation, the physics team then has to sit about doing what dosimetric quality that you're giving. And I'll put this as a challenge. How many of us are documenting how much dose a child gets from your planning CT scan, radiotherapy, and your EPIDs? Just by a show of hands. Are we doing that for adults? Do we know how much total dose we are giving? So in children, it is completely different because you want to expose them to non-ionizing radiation as much as possible. Then the second one is, how do we determine and analyze the endpoints? When we say in the heart, we are talking of the volume given to 10% of the heart at 25% for 5% risk of getting an endpoint. How have we assessed that? And now, based on that, I hope that you can see. It's very small. I feel like you might want to do this. But for the whole brain, remember for adults, we talk of Dmax of 60 gray, and it's for endpoint or risk of getting brain necrosis. But in children, we have to start thinking of other things like lower down is the IQ, because that's one of the long-term things that you have to follow up these children for. It matters. Which part of the brain are you irradiating? What dose are you giving? What age are you irradiating this child? The other thing we talk about a lot in adults, if we irradiate your lens and you get a cataract, it's well and good because we can replace that cataract. And the ophthalmologists are very good in doing that. Maybe 25 years ago, the dose to the lens was so important because we used to worry about patients developing cataracts. Right now, when we're giving radiation and someone develops a cataract, it's not a big deal. We can replace your lens. But what happens in children? Children will not tell you that they can't see very well. So do we need to send them to the ophthalmologist to check whether they are developing cataract? And these guidelines look at self-reported rates of cataract versus ophthalmology-assessed rates of cataracts. And that makes a difference in how we are assessing our dose volume histogram or our coverage in terms of approving a plan for this child. In the kidney, it even gets more complicated. Has this child had chemotherapy? Which chemotherapy? Do they have one kidney? What is the endpoint in terms of chronic kidney disease and the risk of getting that? So that is why these guidelines, I feel like they're the most robust we've had, but it just complicates how we are going to give radiotherapy, and we have to be cognizant of that. The whole document I have summarized, and I don't mind sharing the slides, because then this looks at all the endpoints that you're looking at and the acceptable deviation, which is the minor or unacceptable deviation that you will have. And that sort of is for the brain. This is for the cochlea, and I think this is important, especially when we are talking of medulloblastomas. As we saw in our cohort, we have a significant proportion of patients that we're giving craniospinal radiation. If you're going to give 36 gray to the entire craniospinal axis for high-risk disease, then this is something that we need to consider, because these children will develop most probably hearing loss, compounded by chemotherapy that they will get in the adjuvant setting after that. And that's, I think, the final busy slide, and as you can see, it's quite detailed. So in conclusion, Pentec, I think, is here, and the reason why we need to talk about it is that it is available, and I hope that out of this program, we will be looking at Pentec being printed and put in our radiotherapy units or our planning units, that we're actively looking at it the same way we look at Quantec. But we need to sit in our tumor boards to decide which child needs radiotherapy. How much radiation do they need? What therapy modality are we going to give? Protons are well and good, but they're not the solution to all the effects of radiotherapy that are there. Then in terms of long-term follow-up, when you treat a child at 5 years and they get to 12 in my hospital, at 12, you're no longer a child and you're not an adult. So which clinic are you in there? So there is another move to introduce AYA clinics, which means It's not the pediatricians, it's not the adult oncologists, but there's a clinic where these young adults can actually be seen. And we need to document and document in the most robust way, because that's the only way we are going to assess and monitor for these children. Thank you very much.
Thank you very much, Dr. Njoki. That was an elegant presentation. So in the interest of time, our next session is going to be the Q&A session. We'll only take 2 questions before we move to the next session. Okay.
My question is, Dr. Njoki, just wanted to find out how you balance between thinking about using IMRT and maybe comparing with 3D, because we don't have proton therapy, and trying to balance between the integral dose and now the acute effects of high dose on organs at risk when you want to use something like 3D, and maybe you want to treat maybe a brain tumor. I can see your patient, you use 3D for the patient that was presented. So how do you get that balance?
Thank you. There's no straight answer to your question. I think it matters what is the age of your child, what part of the brain are you treating, what is the indication for getting radiotherapy. So 50.4 gray to the brain, for a child who had a tumor in the parietal area, you're going to be giving high dose to the entire parietal area, the entire hippocampus, the entire temporal lobe. If you're giving VMAT, it means the integral dose to the entire brain, the low dose area, will actually be much wider than a peripheral lesion that you're going to treat with 2, an anterior beam and a lateral beam, and the exit dose will be less. So I'm not saying there's no value for VMAT, but in children, the benefit that we see in terms of VMAT, in terms of dose escalation vis-a-vis sparing the organs, you have a higher integral dose, so you have to balance that. I know the team in Cape Town, I think they've pushed hard in terms of giving CSI with VMAT, and how they've done that is that they don't do complete arcs, they do small arcs over the spine, so that you reduce the amount of dose or integral dose you get to the rest of the body. So you need to think of which area are you treating. For example, Wilms, there's no benefit of doing VMAT with Wilms. Standard APPA fields or 3 fields work better and reduce the dose to your contralateral kidney. Yeah.
Thank you. One more question. Okay. I believe this session was awesome. It was brief, and if there's no more questions, it means everybody understood. We've taken something from this. So we'll move on to the next session, and for the speakers of this session, please, if you kindly move to the stage on the right side so that we could take photos. Thank you.
Hi, everyone. It's Dr. Catherine Nyongesa once again. Today was the official launch of the African Radiation Oncology Group Conference, and we had dignitaries. Among them, the CS of Health, Honorable Aden Duale himself. We had Professor Anyang Nyong. We also had Professor Shaukat, and it was amazing. So we kicked off.
I'll talk about RTOG 0415. SBRT, we talked about PACE A earlier. Well, I'll mention it again, PACE B. So the standard of care has evolved. NCCN guidelines have been. Questions that we have to deal with is what about prophylactic pelvic nodal radiation? Now, earlier today somebody talked about the Roche equations. They're still very useful, been validated more recently. There were a couple of papers, and I'm not going to talk about it in my talk, pelvic radiation, so I just want to make a couple of points. There was a paper published by Paul Nguyen and Anthony D'Amico from Harvard entitled, "Oh, the Roche equation overestimates the risk of lymph node involvement." There's a paper from Yale. But subsequently, there was a series using more than 3,000 patients that underwent extended lymph node dissection from the Briganti group. This is an Italian group that has the world's most experience with extended node dissections that validated and said the Roche equation's fine. Subsequently, a paper from Heidelberg looking at patients undergoing PSMA PETs that also suggested it. So I think the more recent data tends to suggest that it's still a useful, it's certainly cheaper. There's no cheaper test to estimate whether a patient is at risk for lymph node involvement, and it's a good place to start. I am going to talk about MR-Linacs. I'm not going to talk about biomarkers. The biomarkers are a hot topic. These are the guidelines. They're very similar now that the NCCN and looking at the different fractionation that's acceptable, whether brachytherapy or external beam radiation, and moderate fractionation is in circle, and SBRT is there. My standard fractionation for a patient that has a low risk, I think, for toxicity is 950 times 4. But the most common fractionation is 725 times 5. Usually it's every other day. I won't talk about the data, but there's a randomized trial from Canada where patients were randomized between 725 times 5 every other day versus weekly treatment. And they showed that the toxicity was reduced with weekly treatment and the biochemical control was comparable. So when I have patients that are older, patients that live further away, extenuating circumstances, I will treat patients weekly over a period of time. So it's a useful approach. But for me, my standard, I haven't used conventional fractionation except in post-op patients in many years. And in high-risk patients, in lieu of doing HDR brachytherapy with pelvic radiation, I do SBRT for high-risk patients. Many years ago, we published, this is back in 2002, some guidelines on erectile dysfunction with radiation, suggesting that you should minimize the dose to the bulb of the penis to reduce the risk of erectile dysfunction. And we published in the so-called Quantec, this is going back many years, evidence of a dose response using, so you want to keep the dose to the penis as low as possible. But there were some studies that suggested that there was not a relationship between the dose to the penis and the risk of erectile dysfunction. And we wrote this paper on erectile dysfunction, and we did something that we called a reliability score. So what we did is we gave points for different things, like were all the patients potent to start out with? Did they use a validated instrument? What were the dose ranges that they used? And so more points meant more reliable. And so if you took the studies that had the highest number of points, they showed a correlation with erectile dysfunction, and those that had fewer points, there was a lack of correlation. So we think that all radiation-induced complications are dose and volume dependent, and erectile dysfunction is probably one of those things. When you generate a plan, I was talking to a young lady, I'm not sure I see her here now, maybe I ran her off somewhere, but anyway, she was telling me that we don't need to use fiducial markers, we don't need to use certain image guidance techniques because our complications low and so forth. But when you generate a plan, either in the computer or put it on, print it out as a PDF, and you say, this is the dose distribution, then you are telling that patient that you are committed to making this happen in their body the way it is in the plan. You don't do a plan around the spinal cord area and then not execute with precision. And I think in prostate patients, it's important to be precise, and so I'm a big fan of image guidance. Now, this was a paper, actually Alvaro Martinez came from he used to be at William Beaumont. He's going to get a gold medal this year. They did some studies back, this is back in 2005, so again, more than 20 years ago, where they looked at, well, what if you just do this once a week? If you do image guidance once a week and then adjust for it, is that sufficient? And what this study shows is that it's not sufficient. You should do it every day. And this is a study that would be relevant to the young lady who I don't see in the audience. This is a study from MD Anderson. What they did is they looked at patients, they looked at what did the patient's anatomy look like at the time they were simulated. Was their rectum dilated? And what they found was that those patients that were simulated with the rectum dilated with gas had fewer complications. They had fewer rectal complications, but they had a higher biochemical failure rate. So the question you have to ask yourself, when you're simulating patients for prostate cancer, what are you doing at that time? How is their anatomy at that time going to compare to their anatomy when you're treating them every day? And one of the reasons that I'm a big fan of fiducial markers is that you can adjust for that. Now, what we do in practice, if I'm going to do SBRT for a prostate patient and their simulation shows that they have a big air bubble in the rectum, we actually take a red robin, we call a red robin tube, a rubber tube, and we actually stick it in their rectum and let the gas out because we want them to set up precisely for this treatment. But if you have fiducial markers, that can help you address this problem. So I could imagine that if somebody wasn't paying attention to this problem and they were saying, oh, my complication rate is low, my patients are doing fine, but they're not tracking them in terms of long-term biochemical control, they could be misled by how important it is. So we pioneered the placement of fiducial markers more than 25 years ago now. These are some examples of what you see. These are old images. We don't use this format anymore, but it's useful for teaching. These patients have 3 markers. They're 1.1 by 3 millimeters. They're 24 karat gold. There's one at the apex, one at the midgland, one at the base. This is back in our 3D days before the routine use of IMRT. And this allows you to very precisely deliver treatment and adjust for setup error and target motion. And this is an example. This is the first paper that I wrote that, you know, normally when I submit a paper for publication, the reviewers say, oh, you should have done this, you should have done that, what about this, what about that? This one, they just accepted it. This is based on 3 patients. So these patients are morbidly obese. And what we show here is that if you use the tattoos to set the patient up, there are patients in whom you would miss the prostate. I'm not talking about be off a little bit here, a little bit there. With morbid obesity, you can move the tattoos where you want them to be. And so there are patients who don't have morbid obesity but are just fat. And they too can have their markers moved. And if you treat these patients, you can look at the percentage of time they're off by a centimeter, half a centimeter to a centimeter, and less than that. And clearly you cannot accurately deliver the treatment that you showed the patient on the paper in the computer if you don't account for for how big the patient is, where, you know, what kind of, how much gas was in the rectum, and so forth. Now, this is from a Cochrane systematic review and meta-analysis looking at hypofractionation. And the bottom line, this is an old study from 2019. The bottom line is that they concluded that it was likely, that it was safe and likely to be effective and so forth, but there weren't enough studies and blah, 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 and the studies have now been done. Now, you've all seen these so-called alpha-beta calculations for BED and prostate cancer, suggesting that prostate has a low alpha-beta ratio and therefore would be better served by using large fractions. But I've thrown in a few other variables. What about C? What about D? What about E? What about F? What are the other parameters or metrics that might be relevant to understanding this? So you have to be careful about the dosimetry, because the alpha-beta ratio doesn't say you accurately treat the prostate. If you're not using image guidance and you are given the right dose per fraction, but you're not treating the right spot, and even the assumptions about what the alpha-beta ratio should be have more uncertainty than the dose distribution. There was a lady that gave this very long talk this morning. I think she was from Siemens or Varians, that was talking about accuracy of 1%. The most important critical point in the chain where the largest errors are made are the doctors, the MDs, based on what volumes. If you look at inter-observer variability and you look at how people develop the anatomy, we worry about dose distributions of accuracy of 1%, but if you have 3 doctors design the same treatment, you're going to get considerable variability. And if you don't use image guidance, you're going to tend to underdose the target. Fractions, big fractions work. And what about some of the, what I call faulty logic about where, why? Is it logical that, so like I said, the alpha-beta ratio doesn't take into account target motion? It doesn't take into account the volume that you treat, whether you have big margins, whether you treat the pelvic lymph nodes, the extent of disease. The alpha-beta ratio data was supported by studies that were based on the first ASTRO definition for biochemical failure, which doesn't predict for survival. So there are a lot of issues that aren't addressed. This is an example of that. This is an interesting point about nomograms, okay? So on the left is the nomogram that you use to predict the probability of recurrence of PSA failure. And on the right, also created by Catan, is a nomogram that predicts the probability of metastatic disease, which correlates with death. And what you see here is that they're different. If you look at which one gets the most points if you're predicting metastatic disease, it's Gleason score and T3 disease. If you look at biochemical failure, the most important metric is PSA, even modest increases in PSA. So when you make decisions about a risk group, someone asked me about PSA over 20 as defining high-risk prostate cancer. PSA is the most overrated prognostic factor. There's the first 2 papers that showed that PSA over 20 predicted death from prostate cancer, I wrote both of them, but it wasn't that big of an effect. The major drivers of death from prostate cancer are Gleason score and T-stage. This is the paper that I referred to earlier about age. Over 70 or greater than or equal to 70 versus less than 70. And if you looked at, this is biochemical failure. So if you look at the p-value, you can see that age was a more important parameter than many other things, performance status, and competed very well with Gleason score and PSA. Now, I alluded to this study earlier, 0415. This is a randomized trial run by my friend Robert Lee. And this was a study comparing 73.8 gray and 41 fractions versus 70 gray and 28 fractions. And this study actually showed that the people that got the lower dose in a shorter period of time had fewer biochemical failures. And this was supportive of the fact that it tended to support the notion that this is explained by having a low alpha-beta ratio with differences in biochemical failure. So, but the question is, what about the impact on survival? In the US, this is one of the early papers looking at SBRT versus IMRT. If you looked at toxicity, certainly the price is substantially less in the US back in those days, and it's still less. But if you looked at toxicity in this report, those people that got SBRT tended to have more GU toxicity, although the GI and the other was also slightly different. Now, this was the early experience with SBRT. Not everybody did MRIs to better define the anatomy. Not everybody used fiducial markers to do image guidance. We didn't all understand the dose constraints. So, you know, this is population-based data, not randomized data. And when we started our program doing SBRT many years ago, the way that we designed the SBRT program is we used the same fractionation that we used to do with HDR brachytherapy. So when we did, for high-risk patients that got HDR brachytherapy as a boost, we gave 950 times 2, and we did the same thing for the patients that were getting, as the HDR and the SBRT are the same, but the SBRT was less invasive, no anesthesia, less bleeding infection, less pain medication, and the patients did not have to spend overnight in the hospital. And we compared dose volume histograms. This is looking at rectal doses. They were similar between SBRT and HDR brachytherapy. And these are just images from a review article that we wrote some years ago. So we put in 3 markers, one at the base, one at the midgland, one at the apex. Then we do CT-MR fusion. We line those markers up so we can transfer the detailed anatomy from the MRI to the CT to better define where the urethra is. And then we use, in this case, this is with CK, this is a CyberKnife plan, hundreds of beams. We avoid the urethra. We carve out to prevent a hot spot in the urethra. And then every day before each treatment, we image the patient. There's also been a systematic review and meta-analysis of SBRT that suggested that more studies were needed. Again, this is back in 2019, and more studies have been done. The RTOG, we did a study looking at 5 fractions versus 12 fractions that showed excellent control. This is actually a 6,000 patient study. I did more than 1,500 LDR brachytherapy, and we still have people at my institution that do HDR brachytherapy, but I've abandoned doing brachytherapy mainly because I don't want to go to the operating room and it's across town. So I tell my patients, if you want brachytherapy, I can send you to these other people, but if you want to be treated by me for high-risk disease, I like SBRT. For high-risk disease, I give 2 fractions of 950 times 2 first, and then I treat the pelvis. Did anybody have any questions about the first part of this? That's hot? Okay. Now, because I'm going to shift and talk about one of my pet peeves. This is MR-guided versus CT-guided stereotactic radiotherapy for prostate cancer. First of all, I don't like the title. MR-guided versus CT-guided. It's not really guided by the CT. It's guided, if you're using fiducial markers, it's image-guided. You're using the fiducial markers, it's not really CT-based, but I mean, you could use CT. But this is a randomized trial that was published in JAMA Oncology. The primary endpoint is acute physician-scored genital urinary toxicity. I don't like the endpoint. When you do a single institution study with technology that that institution has and nobody else has it, and you're going to just ask them which of these is better for the patient, that creates inherent bias, which I'll talk about in more detail. So they were randomized to justify the 40 gray and 5 fractions. The most common fractionation is 725 times 5, which is 3625. This also creates a bit of a problem. So their study was stopped by the Data Monitoring Committee because they said, oh, we see a difference in acute toxicity that was worse in the patients that got the so-called CT-guided versus the MR-guided. And this was primarily acute genital urinary, but you know, this is what they concluded in their randomized trial. Now let me explain why this study I think is flawed. Let's imagine that you had 2 identical machines and you decided that you were going to randomize them between 2 millimeter margins or 4 millimeter margins. And let's say you had more side effects in the 4 millimeter margins. Well, how could you possibly conclude that the technology is better in the one that you chose the 2 millimeter margins? The side effects are not due to the technology, it's due to the margins. And they decided that they were going to do 4 millimeter margins on the CT guided one and 2 millimeter margins on the MR guided because they assumed that they didn't need as big a margin because they were doing it with MR guidance. And this is not the identical machine, but it's another type of technology. Then how can you assume that this is due to the technology when you're radiating 70 cc's versus 102 cc's? So the treatment with the MR takes 1,100 seconds, and the other one takes 230, so 5 times longer. So you have an opportunity for more motion on the MR guided than you do with the LINAC-based treatment. So you have more opportunities for target motion, more opportunity for errors, and they said they did beam adjustments if greater than 10% of the prostate volume moved outside a 3 millimeter gating boundary. But they never tell you how often that occurred. So the rationale for using a 2 millimeter margin was that, oh, you could adjust for it if there was motion there, but they didn't make motion adjustments all the time. They had to have greater than 10% of the prostate volume outside of a 3 millimeter gating boundary, and we never found out how often that occurred. So they used higher than typical doses where they used 40 gray, and there were some imbalances which I'll talk about. And the main reason that they were trying to do this was to prove that this MR technology was better. So in the supplemental materials of the study, if you look at the population of people that got, and they allowed pelvic nodal radiation to be added, or you could boost intraprostatic disease at the investigator's discretion. Okay, this was in the details of the paper. If you look at the CT guided, high or very high risk features, 39% versus 25% with the MR patients. So if anything, there might be a tendency for more investigators, because they had more advanced patients, to want to give extra dose to a dominant lesion or to add pelvic lymph nodes. So there was bias in terms of the distribution of the characteristics of the patients. There were a few more patients that got rectal spacers. I don't believe in them, but they do. In the group than the CT guided one. So compared to, no, it was no rectal spacer. So there were more CT guidance who did not have rectal spacer. If you looked at baseline GI comorbidity, 23% versus 15%. So if you consider each one of these things as potential adverse factors to increase the risk of GI toxicity, there were 93 of these potentially adverse factors in the CT group, but 74 in the MR group. So there were potential imbalances in the patients in terms of the patients, although this was supposed to be a randomized trial. This is a very interesting study. What they did here, this is a study where they look at observer bias in randomized trials. What they did is they take studies that had blinded results and unblinded results. And so when you do a study that is unblinded, if you looked at unblinded, favors unblinded, that there were a lot of studies that were positive. But if you compare them to the blinded and the unblinded, the likelihood of getting a false positive study is much higher if the study is unblinded. And this randomized trial was an unblinded study where the physicians were reporting the primary endpoint was physician-based. And what do we know about physician versus patient-reported outcomes? So what this is a patient versus physician-reported outcomes in prostate cancer patients treated on randomized trials. So if you ask the physician in blue, frequency, nocturia, urgency, dysuria, incontinence, the physician consistently reported less side effects than the patient. So patients always say they have more side effects than the doctor does. But in this randomized trial from UCLA, the physicians reported that there were more side effects on the CT guided one, statistically significant, but when you ask the patients about using a validated quality of life instrument, they didn't report differences. So when you see a study where the physicians are reporting more toxicity than the patients, and the validated part of the instrument is showing no difference in toxicity, you know there's major bias. This is another relevant study. This is a study looking at the magnitude of the placebo effect in randomized trials. This is for seizure disorders. So they took people, they randomized them to be on with an effective drug or with placebo. And what they found was that 13% of people said they had a greater than 50% reduction in seizures. So when you have these patients that are being treated on a study of MR-guided versus CT-guided, the patients that are getting the MR know they're getting the MR. They know the MR is supposed to be associated with less side effects. That's why they were testing it. And there's an intrinsic potential bias for a placebo effect for the patients to report less side effects. So regarding this so-called Mirage trial, I wrote a letter to JAMA, subsequently got part of it published. There were many flaws in the design. They didn't provide a rationale for the doses and margins chosen. They were somewhat arbitrary. They didn't provide you the data on how much of a motion adjustment they had to make. And there was evidence of bias, several different parts of the stuff, and it was substantially more expensive to do the MR guided, so I would not buy one of these machines to treat prostate cancer. And this is my favorite quote related to that study. You can fool all the people some of the time, this is Abraham Lincoln, and some of the people all the time, but you can't fool all the people all the time. And they didn't fool me. So hypofractionated radiation should be considered, it's critical that you understand the anatomy. It's critical that you use image guidance technology if it's available. You need to understand what the dose constraints are, and patient selection is a major factor in determining which patients should receive this treatment. Thank you very much for your attention.
Thank you so much, Prof. Are there burning? Yeah. I'm sure there are, Prof.
Thank you. My question is, you have shown us how rectal distension can have an impact when it's distended and not. And I can't help but notice you mentioned you are not a fan of these rectal spacers. So can I know why that is? Thank you.
So if you look, first of all, the randomized trial, this is about spacer or no spacer. The randomized trial that was done compared patients that got spacer versus no spacer. The eligibility was low risk or favorable intermediate risk because the FDA did not think it was a good idea to put spacers in patients who might have extracapsular extension. Because if you're putting this material there, you could displace the extracapsular extension outside the field. And there's actually a surgical paper where they put in a different spacer material before prostatectomy and showed that the positive margin rate was higher. So it is suggested that that's a reasonable concern by the FDA. But people are routinely using this spacer for every patient. I've had patients rotate from other institutions, like not patients, medical students come from other institutions, and they present a case to me, and I say, well, what would you do? And they say, well, first I'd put in my spacer. And I'm like, what? You know, so I'm not a fan just because I don't like the idea that we're doing a surgical procedure in a bed, potentially impacting the blood supply, and then we're going to radiate that. But in addition to that, if you look at the toxicity during the treatment, there was no reduction in toxicity during the treatment. Usually when you're radiating somebody, if you're giving too much dose to the rectum, they're usually going to notice that while you're doing it. But there was no difference in toxicity. The toxicity was seen out at like 15 weeks. And again, this was not a blinded study. It's what they call a single-blinded study, meaning that the patients were not supposed to know whether they had the spacer in there or not, because at the time of fiducial placement, they were putting in gold marker seeds, fiducials, they were putting the spacer in at that time. So, but the doctors all knew when the patients had the spacer, because they could see the spacer when they were doing the planning. Now, the first author and the third author were stockholders in the company, and the other authors were consultants for the company, and the statistics were done by an employee of the company, and it showed basically a 3% reduction in grade 1 toxicity. Grade 1 toxicity is like, I think maybe I could tell a difference. You know, so when you have all the physicians would have to do, you know, what I've been told is that they then sold this company, this product, to Boston Scientific for $600 million. That's what I was told. Okay. And then you have a company that now has this product that if you spend $600 million on a product, it means you plan on making billions from that product. And if you're going to make billions from that product, you're going to pay doctors, both urologists and radiation oncologists, to use that product. And so there's been aggressive marketing. So I have patients that have come to me and say, Dr. Roach, what about the spacer? And I say, well, I don't really believe it's necessary. That Jackson paper that had over 6,000 patients showed a incidence of grade 3 or higher toxicity, GU toxicity of 1%. So you're going to put in a spacer. There's a study that looks at the cost effectiveness of spacers. They say it would have to be worth $100,000 to be cost effective because the complication rate is so low based on that study. Since then, there have been multiple papers presented at the AUA from places like Australia, where they had fistulas and complications, and there's a MAUD report, manufacturer use device report that goes out, and it shows that there are patients that have died due to spacer replacements, having fistula due to spacer, and we end up with colostomies and so forth. So the bottom line is the complication rate, particularly in people that are adopting this, are much higher than suggested in this registration study. The evidence, if you're doing good quality, you know, we were talking earlier about the use of fiducial markers. The good news is they put in fiducial markers. But if you're going to put in the spacer, which costs substantially more than gold marker seeds, the gold marker seeds are 2 cents worth of gold. They're 1.1 by 3 millimeters, and you're just putting in 3 of them. They will tell you precisely where the prostate's located. These spacers, in many cases, are not put in symmetrically. So what happens is there's multiple publications showing that, you know, the spacer material can, especially with spacer OAR, it turns hard. So when it's put in, it's kind of lumpy. One side is this thick, the other side is that thick, and so forth. So there are I have numerous concerns. Number one, I don't think we need it. Number two, I don't think it's cost effective. Number three, the literature is biased because of the, you know, the potential for conflict of interest in the authors and for placebo effect in the patients. And again, I think the complication rate is real. We've had complications at our institution. But if I have a patient who's adamant about getting spacers, I did have a patient in with one a couple months ago, I tell them, yes, my urologist will be happy to put it in there. And so we do occasionally use it, but I don't recommend it.
Thank you. Any other question?
Oncologist. So that's, and then I'll actually talk about the application of IGRT in radiation therapy. And then we'll have a little conclusion. So we all know that the fundamental tenet of radiation therapy is the delivery of a high dose of radiation to the tumor. That's all we want to do, deliver a very high dose to the tumor while limiting the dose to normal tissues. However, there are organs at risk and normal tissues whose tolerance have limited amount of the dose that can be delivered to the tumor. So how do we achieve this basic tenet? You know, over the years, some of us, when we got into the field, we did not have MLCs, but nowadays we've developed MLCs. There's a lot of technological development that has helped the culturing and being able to deliver conformal radiation therapy. So with conformal radiation therapy, then there's the ability to increase or escalate the dose while limiting the dose to normal tissues, with the possibility of providing better local control of the disease, enhancing the quality of life, and reducing treatment-associated morbidity. From the perspective of repeatedly, you can hit something that in the new era is high precision and high accuracy. This is something that I published all the way in 2008. So with IMRT, SRS, SBRT, do we need high precision but poor accuracy? No. What we need is high precision and high accuracy. Is what is required to consistently hit the right target, high precision and high accuracy during the course of radiation therapy. But we have a problem. Radiation therapy is a very long, complicated process, and every step in that process has potential for errors. And these errors include the output measurement, which we physicists have worked very hard to minimize them. And then there's the geometric errors, which is part of and parcel of the process of radiation delivery, is to minimize these geometric uncertainties. So the sources of geometric uncertainties are, patient movement, inaccurate patient positioning, organ motion and deformation, machine-related errors. These ones, we physicists have worked hard to minimize them. And there's the target volume delineation, which Professor Rausch said earlier on that is one of the biggest sources of error in the delivery of radiation therapy. And if all the way back, I also wrote an article that tumor delineation is the weakest link in trying to minimize errors in radiation therapy. As I'm going to illustrate, when you delineate something wrong, then it becomes a systematic error, and that patient will receive that systematic error throughout their treatment. So the consequences of geometric uncertainties are insufficient dose coverage of the tumor, resulting in effective tumor control. On the other hand, you can overdose the normal tissues, and resulting in excessive adverse reaction. Either way, whether it's ineffective tumor control, excessive adverse reaction, the patient does not receive the appropriate treatment that you had prescribed. So the possibility of geometric miss happens when there's inaccuracy in tumor delineation and tumor localization. And this is even more important in the era of IMRT, VMAT, where we assume that we can deliver the dose to a very conformal area, and then we've limited the margins. And then, of course, there's a high dose fall-off. All of these compound to add the possibility of a geometric miss. And this is illustrated here, where you can see that in the picture to your left, with big margins, even when the target is not as accurate as it should be, you still cover the target. But to the right is nowadays where you have more conformal radiation therapy and smaller margins. If the target is not identified correctly, there's a possibility for you to have a geometric miss. Geometric uncertainties, again, as I said, some of them are to do with patient positioning, and the patient position and movement can be minimized by patient positioning systems, rigid immobilizations. These set of errors are both random and systematic. By understanding whether it's a random or systematic, it helps in the process of eliminating them. Organ motions can also contribute to the uncertainties that we're trying to talk about. A change in the patient's positioning can affect the location of the target. Again, the 15 minutes is quite a short time to be able to address the issues of geometric uncertainty, so I'll just go through them a little faster than normal. And then there's the organ motions, physiological causes. The changes in the patient's conditions, such as weight loss, weight gain, variation in rectum and bladder fillings, cardiac actions and respirations. These are all sources of errors that need to be minimized to be able to deliver the dose precisely. When we add all of this together, you come up with the setup errors, defined as a discrepancy between intended and actual treatment position. It consists of both the systematic errors and the random errors. Random errors kind of smooth out, where systematic errors shift the dose to a different location. And those can be very detrimental to the delivery of, precise delivery of radiation. So the systematic error is a deviation that occurs in the same direction and is of a similar magnitude for each fraction throughout the treatment course. The random error is a deviation that can vary in any directions and magnitude for each delivered treatment fraction. So the solutions, if I identify the errors, so what are the solutions? First, in the old days, the solutions were account for the errors using margins. So you start with your CTV, and then you add you start with your GTV, you add a margin, it becomes a CTV, and that margin includes the subclinical and microscopic anatomical spreads that the imaging modalities cannot identify. And then from the CTV, you add another uncertainties and margins, you come to your PTV. So these margins are what you add to account for some of these errors. However, margins have problems. The margins are based on assumptions built from clinical and pathological experience and are subject to high degree of uncertainty, making target delineation highly imprecise. So, then comes IGRT. IGRT has been around for a while. It's the introduction of image-guided radiation therapy. As the famous Canadian medical physicist said, his name is Harold John, if you cannot see it, you cannot hit it. If you cannot hit it, then you cannot cure it. So that's where imaging comes. You need an image to find it, and if you find it, then you can hit it. So, so image-guided radiation therapy encompasses any imaging technique that is used for anatomical, functional localization, as well as response to assessment in the treatment room. So this is quite a broad term. Different people might have different definition of what IGRT stands for, but it is images used in radiation therapy. So the rationale for IGRT, as we've, I've laid out the problem. Radiation therapy is a localized intervention. So you localize is somewhere that you want to find it. It's not like a chemotherapy that's systematic. It goes all over your body looking for the cancer. Here with radiation, it's localized. So you need to find it. That's why you need images. And you need images for patient modeling and treatment planning. You need images for dose calculation. You need images for delineation, to draw the target, to draw the organs at risk. You need images. You need the images for setup verification. You need the images for procedural guidance. Radiation therapy. You need the images. So everywhere, images. So roughly and quickly, I'll go through the process. We all know you use images for simulation. You need planning. The images help from 2D to 3D. Using CT images for the treatment of prostate. Again, we have a normal CT versus a CT sim. A CT sim must have a flat tabletop for reproducibility. It has to be similar to the same setup as for your treatment, for your linac, so that you don't have a change in your body contour. If you CT, you have a CT scan, then you go for treatment, you're on a flat surface, there will be a change, and that will affect your localization. CT sim have a larger bore because, sometimes you have to move your arms, you need more space. And of course, the CT sim will rely on external lasers for localization. And the first use of the CT were to generate digitally reconstructed radiograph, DRRs, and to use for when you use them for treatment delivery. Of course, we're moving from treatment planning to treatment setup. The initial images were portal images from the EPIT. So this uses the treatment beam. Historically, we could use films. Of course, we moved from film to electronic portal imaging device, the EPIT. Of course, you're using mega voltage. It's all dependent on the Compton effect. So there's no big difference between soft tissue and bone. Of course, at the diagnostic KV level, you have the photoelectric effect. We can show differences between bone and soft tissue. In terms of from a KV to MV, you don't have huge contrast between your bone. So the images on EPIT are quite fuzzy. But again, the usefulness of EPIT is I can give you your treatment fields. So it's used for treatment verification. There was advancement in introduction of in-room KV imaging system. You had rail track mounted KV system, you have ceiling floor mounted KV system, and you have the gantry mounted system. So the rail track mounted, as you can see the rails there, you have two rails versus three rails. The rails provide motion, guidance, and stability. Exact Track was one of the companies that provided KV and inflow mounted systems for KV images. And then the more advanced that you have everything incorporated, integrated in one Linux, where you have your KV, the kilo voltage, and then you have the MV detector, you have the KV detector, and then you have your X-ray source. So the X-ray source to the left will provide the X-rays, and then you have to the right you have a KV detector. At the bottom you have the MV. So the MV is for the mega voltage energy. So you can use them to provide the KV, you can use them to provide MV scanner images, and then you can use the KV to provide CBC to cone beam. So exactly planner imaging, similar to diagnostic X-ray scanner, they are mounted to the gantry and offset at 90 degrees from gantry head. So the KV matching can be used for alignment, often the AP and lateral, and then you compare them to the DRR to give you a good matching. And then you can use fiducial markers to improve on your alignment. And then Dr. Jeffrey in the early 2000s developed the cone beam. It's a cone beam, cone-like geometry. For a normal CT, you have slices and you move the couch. For a cone beam, because your patient has to be centered. There's no, you cannot move the patient. So you have a cone that can encompass the area that you're trying to opposed to the fan beam, the table does not move in a proper image quality. With the cone beam, you're using KV, kilovoltage X-rays, and with kilovoltage X-rays, the interactions are photoelectric effects. You have better soft tissue bone contrast. So you get the quality similar to a normal fan beam CT scan. Again, with limited time, I wanted my talk to focus more on the errors that we need for proper precision, rather than going through the different modalities that are available for imaging. Of course, there are new techniques. You have the MR, LINAC, you have View-Ray, Philips, Electa, and they treat the patient while simultaneously imaging with the conventional 1.5 Tesla diagnostic MRI. Of course, we know when it comes to images, different modality like MRI, CT scan, ultrasound, they all pick different aspects of your body. The MRIs are more to react with the protons in your body, so it's able to give more soft tissue differences. X-rays can give more difference between bone and soft tissue. Ultrasound is another one that was used a long time ago in prostate. There was a system called BAT, B-mode acquisition and targeting, but that one had gone out of fashion. There's surface imaging. It's an emerging modality that generates three-dimensional surfaces in real time, enabling image guidance for radiation therapy, a process referred to as surface-guided radiation therapy. Again, this is another modality that will take images of the body. It's mostly used when you're treating the breast, but again, it's used for like breath hold cases where you want to see whether there's any motion. And surface-guided The true beam comes with identified system that can be used. The main advantage of surface-guided radiation therapy is non-ionizing in nature, and thus enabling its use throughout the entire radiotherapy workflow. There's which I didn't put a slide here, there's the biological guided radiation therapy from reflection that can also be used, that combines the PET, positron emission tomography, and CT scan to deliver radiation. Again, this will pick up functional imaging, and therefore we'll be able to identify where the tumor is more active. All this is to do with localization, that if you cannot find it, you cannot hit it. By finding where the target is, then we can hit it, then we get better outcome. So the big question is, will errors ever be zero? It is impossible to completely eliminate all geometric errors. There's always uncertainties in how you define your GTV and how you define your CTV. IGRT systems will not be perfectly accurate because of detection and observer errors in the imaging system, and the delay between imaging and treatment leading to short-term organ motions, and there's a limit on accuracy of the correction process. Since this topic was IGRT in a low resource environment, of course, precision is precision regardless of whether you have whether you're in a low resource or not. The key to proper delivery of radiation are, to me, 3 items. One is the improvement in the workforce. We need a lot of radiation oncologists, we need a lot of medical physicists, we need dosimetrists, and we need radiation therapists. Having all of those personnel properly trained to use whatever you have, then you will be able to deliver the radiation accurately. If you have an equipment and you don't have the proper personnel, then you will not deliver the radiation to the highest precision that is required. So you need proper trained personnel and the workforce. Have enough radiation oncologists, have enough medical physicists. We need physicists to be able to calibrate the machine. You have a machine and it's not calibrated properly, even though everything else is correct, the dose that is being delivered to the patient is going to be wrong because that machine was not calibrated correctly. So the precision is out of the window, even though you have the best IGRT system in the world. But without proper calibration, it will deliver nothing. And then the proper utilization of the equipment. So those are my 3 points: improvement in workforce, proper training of personnel, and the proper utilization of what you have. Again, there's so many, there's MRI, there's SGRT, there are a lot. But whatever you have, use it effectively. So in conclusion, imaging, as I've gone through, is everywhere in radiation oncology. Every step in the process of radiation therapy needs imaging. There are different modalities available, but for low resource does not mean, low resource means optimizing what is available without compromising safety and precision. And there are new trends that are coming up, and you can jump on there if you have, but jump with the right personnel and with the right training. So I would like to acknowledge the Indiana University for financial support. I used some of slides from Dr. Joe Weinert, and thank you very much.
Thank you so much, Prof. A round of applause for him. So in the interest of time, I think we'll take questions after. We are running way behind schedule. So what we'll do is we'll break for lunch. Lunch is downstairs. It will be until 2:45. You need to be back in the room so that we finish the topics from the team, the theranostics team, who have are with us, and we appreciate that. After that, we'll break off for plenary. Just some few announcements. There's dinner today at 7. There will be transport from the hotel. And just to remind the people who've presented that we are going to have awards for people who presented their original work. So please come through for the dinner, and we're looking forward to seeing you there. So see you at 2:45 on the dot. Thank you.
Hi everyone, it's Dr. Catherine Nyongesa once again. Today was the official launch of the African Radiation Oncology Group Conference, and we had dignitaries. Among them, the CS of Health, Honorable Aden Duale himself. We had Professor Anyang Nyong'o. We also had Professor Shaukat, and it was amazing. So we kicked off the meetings at 8:30 in the morning, and in that period before the official launch, we discussed many things. Among them, still, patient voice was very key. We discussed broken pathways for cancer patients. Sometimes it's not just the equipment, it is the journey that they go through, and a lot of time is lost when they try to navigate the complex system. Afterwards, we discussed about smarter ways of treating patients using shorter fractions of radiotherapy, which are evidence-based. We also went on to discuss about the role of artificial intelligence in improving access to care. And more so, we had industry players presenting innovative ways of treating cancer patients, showing us state-of-art equipment. And what we know is, apart from the equipment, you need the people. Our CS committed himself to support cancer care in Kenya and positioning Kenya as a leading country in the region. We also talked about partnerships, multidisciplinary care, because no one can do it alone. We had the president of KESHO, Kenya Society of Hemato-Oncology, Dr. Gladwell Kiari herself, who came to talk about PARP inhibitors in prostate cancer. These are new therapies in prostate cancer. And she also reminded us about the upcoming KESHO conference, which will be in November this year in Mombasa. We also met the chair of the Oncology Nurses Society, who also talked about the upcoming conference in September. It will be here in Nairobi at the Weston Hotel. We are all in this together. We talked about the three musketeers, who are radiation oncologists, medical physicists, and radiation therapists. And we also reminded by the Ministry of Health and in support by NCCP that we also need to add on more people. Biomedical engineering should also come as part of sustaining radiotherapy. Many cancer centers, the radiotherapy machines are down because of biomedical engineering support. We had talks by the National Cancer Institute, Dr. Elias Meli, the CEO, who told us what the NCI is doing in expanding research. In fact, they have allocated funds for research focusing in oncology. This afternoon, we had more talks, industry players, individual Hi, everyone. It's Dr. Catherine Nyongesa once again. Today was the official launch of the African Radiation Oncology Group Conference, and we had dignitaries. Among them, the CS of Health, Honorable Aden Duale himself. We had Professor Anyang Nyong. We also had Professor Shaukat. And it was amazing. So we kicked off the meetings at 8:30 in the morning. And in that period before the official launch, we discussed many things. Among them still patient voice. We discussed broken pathways for cancer patients. Sometimes it's not just the equipment, it is the journey that they go through, and a lot of time is lost when they try to navigate the complex system. Afterwards, we discussed about smarter ways of treating patients using shorter fractions of radiotherapy, which are evidence-based. We also went on to discuss about the role of artificial intelligence in improving access to care. And more so, we had industry players presenting innovative ways of treating cancer patients, showing us state-of-art equipment. And what we know is, apart from the equipment, you need the people. Our CS committed himself to support cancer care in Kenya and positioning Kenya as a leading country in the region. We also talked about partnerships, multidisciplinary care, because no one can do it alone. We had the president of KESHO, Kenya Society of Hemato-Oncology, Dr. Gladwell Kiari herself, who came to talk about PARP inhibitors in prostate cancer. These are new therapies in prostate cancer. And she also reminded us about the upcoming KESHO conference, which will be in November this year in Mombasa. We also met the chair of the Oncology Nurses Society, who also talked about the upcoming conference in September. It will be here in Nairobi at the Weston Hotel. We are all in this together. We talked about the three musketeers, who are radiation oncologists, medical physicists, and radiation therapists. And we also reminded by the Ministry of Health and in support by NCCP that we also need to add on more people. Biomedical engineering should also come as part of sustaining radiotherapy. Many cancer centers, the radiotherapy machines are down because of biomedical engineering support. We had talks by the National Cancer Institute, Dr. Elias Meli, the CEO, who told us what the NCI is doing in expanding research. In fact, they have allocated funds for research, focusing in oncology. This afternoon, we had more talks. Industry players, individuals, showcasing their science, the research they have done. And of most important, we are also looking beyond cancer treatment. We are looking about cure. How can everyone else get involved in this cure? We have talked about financing. Cancer care is very expensive. And we had people committing themselves on how they will finance cancer care. We've also talked about education in oncology, and many companies committed to promote education, both virtually, running workshops to reach more people, to create more awareness. And at the center of everything, the patient is the most important person, and all efforts should be going towards improving cure. We know that in our country, cure rates are very low for cancer. Why? Because access to care is very low. Kenya and other sub-Saharan Africa statistics show that whereas we need access to 50% of the cancer patients, actually access to care is still very much limited. It's below 10%. So how do we come together to improve this access to care, such that it doesn't matter where you stay, whether you are in Lodwar, you are in Kisumu, you are in Mombasa, you need to access care, quality, timely care when we need it. It was also mentioned that SHA has improved its package to support cancer patients. Like for cervical cancer, patients are able to access 3 sessions of brachytherapy before they're only accessing 2. During this meeting, it also came out that majority of the cancers are afflicting women in our community. 60% of cancer is in women, and the top leading cancers are breast and cervical cancer. These cancers can be cured, can be prevented, can also be screened, and we get early detection. To improve cures, we want to move away from the low cure rates to very high cure rates as we approach the World Health Organization strategic plan on improving cure for both breast and cervical cancer. We've also talked about prevention. For example, cervical cancer is a preventable disease. We are encouraging parents to take their young girls for HPV vaccination. And for the women, please go for checkup, go be screened, check your breast, go to have a doctor to check your cervix, because we don't want to lose many people to cancer when these deaths are actually preventable. So we have just ended the session with the cutting of the cake for the CROSC and also AFROG. We launched the Clinical Radiation Oncology Society of Kenya, in short, CROSC. We've also celebrated the 18 years of AFROG. It was started 18 years ago, and we had a celebration. We had the board members, previous presidents of AFROG. For example, we had Chigula Mugambe from Uganda. We had Professor Tajudeen Olasinde from Nigeria. And we are really grateful. And he has said, Professor Olasinde, that really AFROG should be the anchor society, and other international and country societies can join. We want AFROG to grow to be the ISTRO, to be the ASTRO of America and ISTRO of Europe. So AFROG will be the African society of choice to support and increase access to radiotherapy for our patients. We've also learned that in Kenya and other sub-Saharan Africa, the radiotherapy machine, when you really need about 1 machine per 500,000 to 1 million patients who really need it, it is not accessible. So how do we devise better ways of treating cancer without buying new equipments? And we just need to do research and prove that short treatments also work. Professor Shaukat also talked about how IEA can support us in terms of capacity building. We know IEA has played a big role, the International Atomic Energy Agency, in training doctors, medical physicists, RTTs, but how much more can they do? We also taken through the history of these African countries and the colonization. And the surprising thing is that people or countries who are English speaking, who are colonized by English speaking foreigners, they are doing much better than those who are colonized by the French. So it is high time that this, like Europe, the French, they really come back, and America, to support African countries because we need to grow. We need to be self-sustaining. We need to get solutions for our country. We also had a presentation from India where they are saying they're actually trying to find solutions, low-cost care for cancer. China presented machines that because they went through what we are going through as Africa, and they decided to manufacture their own machines, and now they have low-cost machines. We also met, the CS also went to the booths of major sponsors, and there was a commitment from AstraZeneca that they are going to ramp up their efforts in terms of cancer prevention and awareness. Siemens, in conjunction with Varian, they have made a commitment that they are going to ensure the Varian machines in the country are well maintained to reduce this downtime. Many patients miss treatment and abandon it because of when they come and they find a machine is broken down, they just go back, and this increases the out-of-pocket cost. We've had cancer survivors who have really been encouraged. They've learned a lot, and they've had an opportunity to ask questions. And as I close this day, I really want to make a dedication to a cancer patient who came all the way from Ethiopia to seek care. She was a cervical cancer patient with advanced cervical cancer, stage 4. And because of lack of access in her country that time, she had to come all the way to Nairobi. She traversed more than 1,400 kilometers to seek for care. After treatment, she felt better. And when she went back to Ethiopia, she bought for me this gown that I'm wearing today. Even though she succumbed to cancer because she arrived too late when the cancer was in the last stage, I just dedicate this Afro conference to her. And it's a wake-up call that we need to bring cancer machines closer to where the women are. They don't have to traverse 600 kilometers or more than 1,000 kilometers to seek for care. And through AFROG, we'll bring care close to their homes, close to their counties, so they don't have to abandon their families, their livelihoods, their dreams for their children to seek for care in a county or in a country far away. Thank you so much for watching me. Thank you for following AFROG. And tomorrow is the last day of the conference, and I want to invite you to join us very early in the morning, and we'll crown everything by having a dinner at the Carnival restaurant in Nairobi in the evening from 7 p.m. up to 9 p.m. So all those people attending the conference, this will be free entry. So I want to see you there. Bye. Hi everyone, it's Dr. Catherine Nyongesa once again. Today was the official launch of the African Radiation Oncology Group Conference, and we had dignitaries. Among them, the CS of Health, Honorable Aden Duale himself. We had Professor Anyang Nyong. We also had Professor Shaukat, and it was amazing. So we kicked off the meetings at 8:30 in the morning, and in that period before the official launch, we discussed many things. Among them, still, patient voice was very key. We discussed broken pathways for cancer patients. Sometimes it's not just the equipment, it is the journey that they go through, and a lot of time is lost when they try to navigate the complex system. Afterwards, we discussed about smarter ways of treating patients using shorter fractions of radiotherapy, which are evidence-based. We also went on to discuss about the role of artificial intelligence in improving access to care. And more so, we had industry players presenting innovative ways of treating cancer patients, showing us state-of-art equipment. And what we know is, apart from the equipment, you need the people. Our CS committed himself to support cancer care in Kenya and positioning Kenya as a leading country in the region. We also talked about partnerships, multidisciplinary care, because no one can do it alone. We had the president of KESHO, Kenya Society of Hemato-Oncology, Dr. Gladwell Kiari herself, who came to talk about PAP inhibitors in prostate cancer. These are new therapies in prostate cancer. And she also reminded us about the upcoming KESHO conference, which will be in November this year in Mombasa. We also met the chair of the Oncology Nurses Society, who also talked about the upcoming conference in September. It will be here in Nairobi at the Weston Hotel. We are all in this together. We talked about the three musketeers, who are radiation oncologists, medical physicists, and radiation therapists. And we also reminded by the Ministry of Health and in support by NCCP that we also need to add on more people. Biomedical engineering should also come as part of sustaining radiotherapy. Many cancer centers, the radiotherapy machines are down because of biomedical engineering support. We had talks by the National Cancer Institute, Dr. Elias Meli, the CEO, who told us what the NCI is doing in expanding research. In fact, they have allocated funds for research, focusing in oncology. This afternoon, we had more talks. Industry players, individuals, showcasing their science, the research they have done. And of most important, we are also looking beyond cancer treatment. We are looking about cure. How can everyone else get involved in this cure? We have talked about financing. Cancer care is very expensive. And we had people committing themselves on how they will finance cancer care. We've also talked about education in oncology, and many companies committed to promote education, both virtually, running workshops, to reach more people, to create more awareness. And at the center of everything, the patient is the most important person, and all efforts should be going towards improving cure. We know that in our country, cure rates are very low for cancer. Why? Because access to care is very low. Kenya and other sub-Saharan Africa statistics show that whereas we need access to 50% of the cancer patients, actually access to care is still very much limited. It's below 10%. So how do we come together to improve this access to care, such that it doesn't matter where you stay, whether you are in Lodwar, you are in Kisumu, you are in Mombasa, you need to access care, quality, timely care when we need it. It was also mentioned that SHA has improved its package to support cancer patients. Like for cervical cancer, patients are able to access 3 sessions of brachytherapy before they were only accessing 2. During this meeting, it also came out that majority of the cancers are afflicting women in our community. 60% of cancer is in women, and the top leading cancers are breast and cervical cancer. These cancers can be cured, can be prevented, can also be screened, and we get early detection. To improve cures, we want to move away from the low cure rates to very high cure rates as we approach the World Health Organization strategic plan on improving cure for both breast and cervical cancer. We've also talked about prevention. For example, cervical cancer is a preventable disease. We are encouraging parents to take their young girls for HPV vaccination. And for the women, please go for checkup, go be screened, check your breast, go to have a doctor to check your cervix, because we don't want to lose many people to cancer when these deaths are actually preventable. So we have just ended the session with the cutting of the cake for the CROSC and also AFROG. We launched the Clinical Radiation Oncology Society of Kenya, in short, CROSC. We've also celebrated the 18 years of AFROG. It was started 18 years ago, and we had a celebration. We had the board members, previous presidents of AFROG. For example, we had Chigula Mugambe from Uganda. We had Professor Tajudeen Olasinde from Nigeria. And we are really grateful. And he has said, Professor Olasinde, that really AFROG should be the anchor society, and other international and country societies can join. We want AFROG to grow to be the ISTRO, to be the ASTRO of America and ISTRO of Europe. So AFROG will be the African society of choice to support and increase access to radiotherapy for our patients. We've also learned that in Kenya and other sub-Saharan Africa, the radiotherapy machine, when you really need about one machine per 500,000 to 1 million patients who really need it, it is not accessible. So how do we devise better ways of treating cancer without buying new equipments? And we just need to do research and prove that short treatments also work. Professor Shaukat also talked about how IEA can support us in terms of capacity building. We know IEA has played a big role, the International Atomic Energy Agency, in training doctors, medical physicists, RTTs, but how much more can they do? We also taken through the history of these African countries and the colonization. And the surprising thing is that people or countries who are English speaking, who are colonized by English speaking foreigners, they are doing much better than those who are colonized by the French. So it is high time that this, like Europe, the French, they really come back, and America, to support African countries, because we need to grow. We need to be self-sustaining. We need to get solutions for our country. We also had a presentation from India where they are saying they're actually trying to find solutions, low-cost care for cancer. China presented machines that because they went through what we are going through as Africa, and they decided to manufacture their own machines, and now they have low-cost machines. We also met, the CS also went to the booths of major sponsors, and there was a commitment from AstraZeneca that they are going to ramp up their efforts in terms of cancer prevention and awareness. Siemens, in conjunction with Varian, they have made a commitment that they are going to ensure the Varian machines in the country are well maintained to reduce this downtime. Many patients miss treatment and abandon it because of when they come and they find a machine is broken down, they just go back, and this increases the out-of-pocket cost. We've had cancer survivors who have really been encouraged. They've learned a lot, and they've had an opportunity to ask questions. And as I close this day, I really want to make a dedication to a cancer patient who came all the way from Ethiopia to seek care. She was a cervical cancer patient with advanced cervical cancer, stage 4. And because of lack of access in her country that time, she had to come all the way to Nairobi. She traversed more than 1,400 kilometers to seek for care. After treatment, she felt better. And when she went back to Ethiopia, she bought for me this gown that I'm wearing today. Even though she succumbed to cancer because she arrived too late when the cancer was in the last stage, I just dedicate this Afro conference to her. And it's a wake-up call that we need to bring cancer machines closer to where the women are. They don't have to traverse 600 kilometers or more than 1,000 kilometers to seek for care. And through AFROG, we'll bring care close to their homes, close to their counties, so they don't have to abandon their families, their livelihoods, their dreams for their children to seek for care in a county or in a country far away. Thank you so much for watching me. Thank you for following AFROG. And tomorrow is the last day of the conference. And I want to invite you to join us very early in the morning. And we'll crown everything by having a dinner at the Carnival restaurant in Nairobi in the evening from 7 p.m. up to 9 p.m. So all those people attending the conference, this will be free entry. So I want to see you there. Bye. Hi, everyone. It's Dr. Catherine Nyongesa once again. Today was the official launch of the African Radiation Oncology Group Conference, and we had dignitaries. Among them, the CS of Health, Honorable Aden Duale himself. We had Professor Anyang Nyong'o. We also had Professor Shaukat. And it was amazing. So we kicked off the meetings at 8:30 in the morning. And in that period before the official launch, we discussed many things. Among them, still, patient voice was very key. We discussed broken pathways for cancer patients. Sometimes it's not just the equipment, it is the journey that they go through, and a lot of time is lost when they try to navigate the complex system. Afterwards, we discuss about smarter ways of treating patients using shorter fractions of radiotherapy, which are evidence-based. We also went on to discuss about the role of artificial intelligence in improving access to care. And more so, we had industry players presenting innovative ways of in treating cancer patients, showing us state-of-art equipment. And what we know is, apart from the equipment, you need the people. Our CS committed himself to support cancer care in Kenya and positioning Kenya as a leading country in the region. We also talked about partnerships, multidisciplinary care, because no one can do it alone. We had the president of KESHO, Kenya Society of Hemato-Oncology, Dr. Gladwell Kiari herself, who came to talk about PAP inhibitors in prostate cancer. These are new therapies in prostate cancer. And she also reminded us about the upcoming KESHO conference, which will be in November this year in Mombasa. We also met the chair of the Oncology Nurses Society, who also talked about the upcoming conference in September. It will be here in Nairobi at the Weston Hotel. We are all in this together. We talked about the three musketeers who are radiation oncologists, medical physicists and radiation therapists. And we were also reminded by the Ministry of Health and in support by NCCP that we also need to add on more people. Biomedical engineering should also come as part of sustaining radiotherapy. Many cancer centers, the radiotherapy machines are down because of biomedical engineering support. We had talks by the National Cancer Institute, Dr. Elias Meli, the CEO, who told us what the NCI is doing in expanding research. In fact, they have allocated funds for research, focusing in oncology. This afternoon, we had more talks, industry players, individuals, showcasing their science, the research they have done. And of most important, we are also looking beyond cancer treatment. We are looking about cure. How can everyone else get involved in this cure? We have talked about financing. Cancer care is very expensive. And we had people committing themselves on how they will finance cancer care. We've also talked about education in oncology, and many companies committed to promote education, both virtually, running workshops to reach more people, to create more awareness. And at the center of everything, the patient is the most important person, and all efforts should be going towards improving cure. We know that in our country, cure rates are very low for cancer. Why? Because access to care is very low. Kenya and other sub-Saharan Africa statistics show that whereas we need access to 50% of the cancer patients, actually access to care is still very much limited. It's below 10%. So how do we come together to improve this access to care, such that it doesn't matter where you stay, whether you are in Lodwar, you are in Kisumu, you are in Mombasa, you need to access care, quality, timely care when we need it. It was also mentioned that SHA has improved its package to support cancer patients. Like for cervical cancer, patients are able to access 3 sessions of brachytherapy before they're only accessing 2. During this meeting, it also came out that majority of the cancers are afflicting women in our community. 60% of cancer is in women, and the top leading cancers are breast and cervical cancer. These cancers can be cured, can be prevented, can also be screened, and we get early detection. To improve cures, we want to move away from the low cure rates to very high cure rates as we approach the World Health Organization strategic plan on improving cure for both breast and cervical cancer. We've also talked about prevention. For example, cervical cancer is a preventable disease. We are encouraging parents to take their young girls for HPV vaccination. And for the women, please go for checkup, go be screened, check your breast, go to have a doctor to check your cervix, because we don't want to lose many people to cancer when these deaths are actually preventable. So we have just ended the session with the cutting of the cake for the CROSC and also AFROG. We launched the Clinical Radiation Oncology Society of Kenya, in short, CROSC. We've also celebrated the 18 years of AFROG. It was started 18 years ago, and we had a celebration. We had the board members, previous presidents of AFROG. For example, we had Chigula Mugambe from Uganda. We had Professor Tajudeen Olasinde from Nigeria. And we are really grateful. And he has said, Professor Olasinde, that really AFROG should be the anchor society. And other international and country societies can join. We want AFROG to grow to be the ISTRO, to be the ASTRO of America and ISTRO of Europe. So AFROG will be the African society of choice to support and increase access to radiotherapy for our patients. We've also learned that in Kenya and other sub-Saharan Africa, the radiotherapy machine, when you really need about one machine per 500,000 to 1 million patients who really need it, it is not accessible. So how do we devise better ways of treating cancer without buying new equipments? And we just need to do research and prove that short treatments also work. Professor Shaukat also talked about how IEA can support us in terms of capacity building. We know IEA has played a big role, the International Atomic Energy Agency, in training doctors, medical physicists, RTTs, but how much more can they do? We also taken through the history of these African countries and the colonization. And the surprising thing is that people or countries who are English speaking, who are colonized by English speaking foreigners, they are doing much better than those who are colonized by the French. So it is high time that this, like Europe, the French, they really come back, and America, to support African countries, because we need to grow. We need to be self-sustaining. We need to get solutions for our country. We also had a presentation from India where they are saying they're actually trying to find solutions, low-cost care for cancer. China presented machines that and now they have low-cost machines. We also met, the CS also went to the booths of major sponsors. And there was a commitment from AstraZeneca that they are going to ramp up their efforts in terms of cancer prevention and awareness. Siemens, in conjunction with Varian, they have made a commitment that they are going to ensure the Varian machines in the country are well maintained to reduce this downtime. Many patients miss treatment and abandon it because of when they come and they find a machine is broken down, they just go back, and this increases the out-of-pocket cost. We've had cancer survivors who have really been encouraged. They've learned a lot, and they've had an opportunity to ask questions. And as I close this day, I really want to make a dedication to a cancer patient who came all the way from Ethiopia to seek care. She was a cervical cancer patient with advanced cervical cancer, stage 4. And because of lack of access in her country that time, she had to come all the way to Nairobi. She traversed more than 1,400 kilometers to seek for care. After treatment, she felt better. And when she went back to Ethiopia, she bought for me this gown that I'm wearing today. Even though she succumbed to cancer because she arrived too late when the cancer was in the last stage, I just dedicate this Afro conference to her. And it's a wake-up call that we need to bring cancer machines closer to where the women are. They don't have to traverse 600 kilometers or more than 1,000 kilometers to seek for care. And through AFROG, we'll bring care close to their homes, close to their counties, so they don't have to abandon their families, their livelihoods, their dreams for their children to seek for care in a county or in a country far away. Thank you so much for watching me. Thank you for following AFROG. And tomorrow is the last day of the conference. And I want to invite you to join us very early in the morning. And we'll crown everything by having a dinner at the Carnival restaurant in Nairobi in the evening from 7 p.m. up to 9 p.m. So all those people attending the conference, this will be free entry. So I want to see you there. Bye. Hi everyone, it's Dr. Catherine Nyongesa once again. Today was the official launch of the African Radiation Oncology Group Conference, and we had dignitaries. Among them, the CS of Health, Honorable Aden Duale himself. We had Professor Anyang Nyong. We also had Professor Shaukat. And it was amazing. So we kicked off the meetings at 8:30 in the morning. And in that period before the official launch, we discussed many things. Among them still, patient voice was very key. We discussed broken pathways for cancer patients. Sometimes it's not just the equipment, it is the journey that they go through, and a lot of time is lost when they try to navigate the complex system. Afterwards, we discussed about smarter ways of treating patients using shorter fractions of radiotherapy, which are evidence-based. We also went on to discuss about the role of artificial intelligence in improving access to care. And more so, we had industry players presenting innovative ways of in treating cancer patients, showing us state-of-art equipment. And what we know is, apart from the equipment, you need the people. Our CS committed himself to support cancer care in Kenya and positioning Kenya as a leading country in the region. We also talked about partnerships, multidisciplinary care, because no one can do it alone. We had the president of KESHO, Kenya Society of Hemato-Oncology, Dr. Gladwell Kiari herself, who came to talk about PAP inhibitors in prostate cancer. These are new therapies in prostate cancer. And she also reminded us about the upcoming KESHO conference, which will be in November this year in Mombasa. We also met the chair of the Oncology Nurses Society, who also talked about the upcoming conference in September. It will be here in Nairobi at the Weston Hotel. We are all in this together. We talked about the three musketeers, who are radiation oncologists, medical physicists, and radiation therapists. And we also reminded by the Ministry of Health and in support by NCCP that we also need to add on more people.
specialist. I'm also a consultant radiologist. So I'm going to share our experience at Aga Khan University Hospital on radioligand therapy. So these photos are just to show the day when we did our first therapy. You can see the smiles on the team that facilitated that. Myself, my colleagues, nuclear medicine physicians, our radiopharmacists, and also the team from South Africa also. So this was in May 2025. So now it's slightly a year later. That's almost a year and 2 months. So I'm going to share what we've achieved in that timeline. So before that, maybe you can just start with defining what theranostics is. And basically, theranostics is coined from two words. That's therapy and diagnostics. And that means that we usually incorporate both to decide which patient will benefit from theranostics. So in theranostics, we only treat what we see to see what we are treating. So that's one unique thing about theranostics. And what basically we do is that if, for example, I'm to use prostate cancer, so we use ligands which are able to sort of identify the proteins on the which are the proteins expressed on the prostate cancer cell surface. That is the PSMA. So this ligand, the screen is so big. Yeah. Okay. So as I was saying, sorry for that, we have the ligand, which can be similar for both imaging and therapy. And for therapy, what we do is we just switch the radioactive particle, which we used for imaging. We replace it with a particle which is going to emit either alpha or beta particles, which are used for therapy. So we have several proteins which are expressed on or overexpressed on cancer cells. And what we are commonly targeting now is the PSMA, and we also have the SSTR proteins for neuroendocrine tumors. So currently at Aga Khan, we are able to treat both patients with prostate cancer and also patients who have neuroendocrine tumors, especially the unresectable tumors. So where do we start? The first step is to image these patients so that we can make a decision whether they're eligible for treatment or not. So for example, for neuroendocrine tumors, we start with a dot-ated PET scan. And if it's avid, we look at the level of avidity. Ideally, it should be above the liver background for the patient to be eligible for treatment. For prostate, we do the PSMA PET scan also to evaluate the avidity of the lesions. Sometimes we are required to do FDG PET scan. Normally, we don't do the FDG, F18 FDG PET scans for all patients. We select patients who we think maybe may have like a disease heterogeneity to do an FDG just to make sure that there's no significant avid FDG disease. Then after that, we start the therapy. So for most patients, we discuss them in the multidisciplinary tumor boards, just to make sure that the patients we are selecting for therapy are the appropriate patients and they're going to benefit from the treatment. So in this tumor board, or other multidisciplinary tumor boards, normally we have a nuclear medicine physician, medical oncologist, if it's for prostate cancer, the urologists, radiation oncologists also are involved, and sometimes the medical physicists when needed. So once the patient is approved by the multidisciplinary tumor boards, then they are sent to us in nuclear medicine for further evaluation and for the treatment. So when they're sent to us, what do we review? We review the disease status. Currently, for prostate cancer, we are treating patients with metastatic castration-resistant prostate cancer. The guidelines have only approved those patients who have metastatic castration-resistant prostate cancer. In future, hopefully, as trials are being done, we might be able to use this radioligand therapy as a first-line treatment, even for these prostate cancer patients. Again, we look at, for patients like for neuroendocrine patients with inoperable disease, we look at the prior history of therapy. Have they received chemotherapy, ARPIs, and all any prior treatment they might have received. We also review the images for PSMA PET for prostate and daughter Tate PET scans for patients with neuroendocrine cancers. Then we also, at the same sitting, make a decision on whether we'll need to do an FDG PET CT just to look for any variable, like FDG avid disease, which will sort of make the patient not benefit optimally from the lutetium therapy. Labs, we have to look at the liver function, renal function, the blood counts, because most of because the therapy, there's a potential of affecting the bone marrow. So we have to look at the HB, the white blood cells, and platelets, so as to sort of approve whether a patient is appropriate for treatment. So that's for patient selection. I think I've just mentioned what we look at. For prostate, patients who are progressing despite being on ADT or prior chemotherapy, they're usually candidates for this radioligand therapy. And they should have adequate organ function. That's why we have to look at the liver function, the renal function, and the bone marrow function as well. So exclusion, we don't have absolute exclusion criteria as such. Most of the exclusion criteria are relative and can be discussed on whether the patient can benefit from the treatment or not. So we look at patients who are negative on the PSMA PET or the daughter Tate PET. Those patients are usually not eligible for this kind of therapy. If a patient has discordant imaging findings, when we compare the FDG PET and the other PET scans, that is the PSMA or the daughter Tate PET scan, they tend to be poor responders, these patients. Again, patients with poor performance status, mostly patients who are ECOG 1 and 2, we are comfortable giving these patients therapy. Patients with extensive marrow infiltration, because most of the time they might even present with severe cytopenias, so we approach such kind of patients with caution. Again, severe renal impairment with a GFR of less than 30, we also don't normally give these patients treatment. So the protocols, they're similar for lutetium PSMA and for lutetium daughter Tate, but there's some slight differences. For PSMA, we give 4 to 6 cycles, and the duration between cycles is 6 weeks. For daughter Tate, the duration between cycles is 8 weeks, and we give a maximum of 4 cycles. We tend to do the daughter Tate as inpatient. For the prostate patients, we give the lutetium as outpatients. For the daughter Tate, the additional treatment they get, or rather an additional component to the treatment is amino acids, because they're not to be protective to the kidneys, and the daughter Tate is known to sort of bind to the kidneys and so increase the risk of having renal issues. So on the day of treatment, we do pre-treatment with antiemetics. Sometimes we also give steroids and hydration, around 500 to 1,000 mils, and then we go ahead to administer the treatment. For lutetium PSMA, it's just a slow infusion for 3 minutes. For the dotatate, it's usually for 30 minutes, and we do it in combination with amino acids to protect the kidneys. So what are some of the side effects we've experienced so far? We've had a few patients who have experienced some mild side effects, such as nausea during treatment. And this is mostly common in patients getting the lutetium dotatate because of the amino acid component. And that's why we have to give the antiemetics before we start the treatment. Some patients complain of fatigue after the treatment, xerostomia, because there's also a significant uptake within the salivary glands as well. And sometimes some patients have experienced transient pain flare. But the good news is that so far we've not had any severe side effects, and this is in regards to the renal function, liver function, and bone marrow function. We've had a few patients who developed had some reduction in the platelet count, but they were all grade 1. We didn't have any patients with severe thrombocytopenia. So how do we assess our response? So we look at the general clinical presentation of the patient after treatment. Are they feeling well? Are the symptoms improving? And I'm glad to say that we've had quite a number of patients who've presented with significant improvement clinically. I remember there's a patient who, when he came for the first cycle, was on wheelchair and was in so much pain. And after we gave the first cycle of lutetium, they said that within a week, they actually said by day 5 of treatment, most of the pain had gone. And by the time they were coming back for the next cycle, they actually came walking. So in addition to just treating the disease, we can see that there's patients are experiencing quite significant improvement in their quality of life. We look at the labs. We do continuous monitoring for the labs almost after every 2 weeks, just to make sure that we don't experience any, or rather we don't miss out on any severe adverse effects from the medicine. And of course for imaging, so normally what we do with imaging, after every cycle of the therapy, we image with the same lutetium we've given the patient. We don't do like a separate PET scan. The lutetium itself has gamma photons, releases gamma photons, which we are able to do SPECT images. And so we use those serial SPECT images, which we acquire 24 hours after the therapy, to just monitor response in these patients. So when do we consider discontinuation? We've discontinued patients because of progression. We've also, another consideration would be severe toxicity, but as I said, so far we've not had any patient experiencing severe toxicity. I think the main other reason why there's discontinuation is financial challenges, because it's quite a costly therapy. One cycle costs around 1 million Kenya shillings. That's around $8,000 US. So it's quite costly for an individual to go all the way for the 6 cycles. You find that sometimes they get 1 cycle and then they are not able to continue the treatment because of the cost implication. So I'll just show a few samples of what we've done and how our patients have responded. So we have this case 1. This is a patient with disseminated metastatic prostate disease. And as you can see on the first image, you can see that that's a PSMA PET scan. There was quite significant disease in the bones. And then in the second image, that was the first cycle. So this scan was acquired 24 hours after the first cycle. and then the second one 24 hours after the second cycle, and then the third one after the 24 hours after the third cycle, you can see that there's significant reduction in avidity of the skeletal metastases. And this was also reflected on the trends on the PSA levels. You can see the patient presented to us because of rising PSA levels. And then when we started the therapy around November 2025, there has been a significant gradual reduction in PSA levels. So these are patients who we are possibly going to continue maybe up to the 6th cycle, depending on how they'll continue responding. And for these patients, they've significantly improved clinically. They don't complain of pain anymore. Second case, I must also show the not so good cases. So these are patients who first responded very well. You can see how the PSMA PET, they have disseminated avid skeletal metastasis. So they received the first cycle. The second cycle, we could see there was some slight reduction, but by the third cycle, we started seeing that, for example, if we look at this lesion in the right shoulder region, there was some slight increase in avidity. And after these 2 cycles, we decided to do PSMA PET just to evaluate the status of the disease. And you can see when you compare this PET with the first PSMA PET scan, there's significant increase in the extent of the skeletal metastasis. And this also reflected on the PSA levels. You can see they presented to us with increase in PSA levels at this point. Then we had initial reduction in the PSA levels. Then the PSA levels started increasing again. So these are patients we stopped the therapy and sent them back for the, to the oncologist for review. This is another patient who has responded fairly well. He presented to us with severe left shoulder pain. We've given 4 cycles so far. Actually, the last cycle was just yesterday. And you can see, actually, if I could just, we could use the lesion in the left shoulder region, which was actually symptomatic. There has been significant reduction in avidity over the if we could say 3 cycles, because the 4th cycle we gave yesterday, so we still yet to see the effects of the 4th cycle. This also reflected on the PSA levels. You can see his PSAs have come down significantly from, it was around 90 to now we have 25, and the patient is also pain-free. For the, this was another patient who had nodal skeletal metastasis, and this patient has received 2 cycles so far. And if you look at the SPECT images, the first image is the PET. From the PET, we do see those nodal disease sites in the pelvic and retroperitoneal region. Then the other 2 sets of images are SPECT images. That's why they look a little bit different from the PET images. And you do see that this was the first cycle, so like 24 hours after a cycle. So at that point, we don't expect there's response to treatment. It's more to confirm the distribution pattern of the therapy we've given. So after the second cycle, at least now we are able to compare what has happened between the first cycle and the second cycle. And you can see there was significant reduction in avidity and size of those nodal disease sites. And this was also reflected on the PSA levels, which the patient presented with rising PSA levels. When we started the treatment here, the PSA levels have significantly gone down. So these are patients we are going to continue treatment and monitoring. For Dr. Tate, I'm gonna present this patient who presented with a non-resectable neuroendocrine tumor. And it was actually a paraganglioma, retroperitoneal paraganglioma, which was invading the IVC and aorta, and also had lung metastasis. So we gave our first cycle, which after 24 hours, this is what we got. We could see the disease site. the retroperitoneal mass, and we can see the liver, the lung mets, which are also avid. So after the first cycle, this is 24 hours after the second cycle, you can see that there's significant reduction in avidity and even the size of the primary lesion. The lung nodule, possibly not much, but we do see significant reduction in size and avidity of the primary lesion. So this just goes to show that there's a significant role for theranostics in patients who possibly other treatment lines are not being quite helpful. So in conclusion, patient selection is very important for theranostics. So we have to do proper imaging so as to be able to pick the patients who we think will benefit from this therapy. It's also important to know when to stop patients who are not responding. It being a very expensive therapy, there's no need of going all the way to 6 cycles if a patient is already showing signs of progression, either clinically or through labs or through imaging. Again, the consideration of finances, because I think this is quite limiting the number of patients who can get the full cycles of treatment. So far we've treated, we've given around 45 cycles, that's around 15 patients. And this is just a summary of what our experience in that one or so year. Thank you.
Thank you so much, Dr. Mwani, and brilliant images, as always. Thank you. We'll hear from Dr. Harish, who works in the other public institution. So he works at the KUTRRH. He's also a radiologist who's a nuclear medicine specialist, and he's going to talk to us about introduction to theranostics, their experience at KUTRRH. Thank you. Welcome, Dr. Harish.
So, good afternoon all. Thank you, Dr. Jireni, for the introduction. As he's setting up, I think my job becomes much easier after the heavy presentation from Vanya. So mine will be just to showcase what we are doing as a public institution when it comes to theranostics. And it's always good to see like the path we walked in, how we reached this far. So mine will be not so technical, but definitely we have, after that we have a panel session, so we can always discuss the doubts we have. Okay. So as I was mentioning, it's always worth to know where we started. You know, nuclear medicine practice in Kenya started as early as 1998. And that time it was just a private diagnostic center in Mutiti Road. I don't know how many of you are aware of that. And Kenyatta, though now it doesn't have a functional nuclear medicine, it was the first place to start as a public institution. At that time they were doing some high-dose radioiodine therapy. The history is rich as much as when it comes to conventional. Recently we introduced CA9 for clear cell renal cell carcinoma, and also Dotanok for neuroendocrine tumors. These are all coming from HCG-CCK. So Dr. Moni was talking about lutetium PSMA therapy. Currently it's available at Aga Khan as well as KUTRH. HCG also started as recent as yesterday. So this is the center where I come from, Integrated Molecular Imaging Center, that is at Kenyatta University Teaching Referral and Research Hospital. 2022 January is when we first performed the PET scan there, and it's the only country's first public hospital with comprehensive radiopharmaceutical as well as nuclear medicine services What we host is a megacyclotron, as I mentioned earlier. Then we have 2 state-of-art PET CTs and 1 SPECT CT. This is one of the article where I co-authored. It was published last year in Journal of Nuclear Medicine. It states the current status of nuclear medicine in Africa. So the most common thing we notice, the paper which highlights is the barriers of the supply cost, limited infrastructure, the major bottleneck being the workforce shortage. However, with whatever little we have, IA has supported IA has played quite a major role, especially training most of our cadre, be it medical physicists or radiopharmacists. So these are the hospitals which take care of most of our nuclear medicine services, KU, Aga Khan, Nairobi West Hospital, and HCG. And also there are new joints for this, which is RFH as well as UDC. So the thing which I wanted to highlight is this, as much as Dr. Monia was saying, it costs about 1 million. This service should not be just for private alone. Even public hospitals, we need to have such kind of services so that no patient or no citizen is left out without this. So KU-Tarich is proud to say that it's the only public hospital which actually have done this. While I'm ending this, I just want to showcase our pilot project. We did it with IA and as well as on CDM Foundation. And I have taken consent, and the patient is aware that his images will be published. So this was a case, a patient who presented with metastatic castrate-resistant prostate carcinoma. Patient had undergone his conventional first and second line hormonal therapy, but this patient didn't want to start with chemotherapy. So he actually ended up with us, and we gave a trial based on the MDT and eligibility criteria. We matched it quite well, and the outcome I'm going to show you soon. So this patient, when he walked, this was how he looked in the first day of lutetium PSMA therapy. He actually had given up, and he was told that he goes back to Chagos and then he'll be put on some palliation. However, we had to work with what we have first, and the image here, you see that it was in 2025 May. He was staged at T4, which is locally advanced prostate cancer. You can see the disease here. And he also has some nodes, N1. And then he also had some bone metastasis. Then the patient was again put on some hormonal therapy whereby his bone metastasis responded. We didn't see, there was some regression in the tracer uptake, and almost you can't see it here unless you're very keen. However, the notable thing is in the prostatic base and nodal disease, the disease has progressed. So basically it's a mixed response, but actually it is progressing. I want you to see the last image. This is after 2 cycles. You can clearly see that the disease in the prostate as well as anywhere in the thorax had completely gone. So the PSA, initially we worked with, it was more than 400. After first cycle 1 month, it jumped to 22. And finally, it came to 3.45. So this is our patient. And from where he was seated and he was not able to move now, he's walking and he's doing his own things. Thank you so much.
Thank you, Dr. Arishi. Don't come down, just have a seat. Dr. Mwania, just come to the stage. And then I'll ask Dr. David Wanje to also come to the stage. So the only person I've not introduced is Dr. Wanje. He's a radiopharmacist from KU Teaching Research Referral Hospital. And also on stage is Stacy Achoki, who's our physicist. And welcome, it's nice to have all of you. And just a quick question. Dr. Mwania, you spoke about the patients that you saw. How do you assess for tumor heterogeneity before deciding that patients are getting PRRT? Is there another criteria that you use apart from what you discussed?
Okay, thank you, Dr. Jeraini. So, how we assess for tumor heterogeneity? Basically, it's through imaging for us. So we do the PSMA PET scan for prostate, or the DOTAT scan for the patients with a neuroendocrine tumor. And then we are able to review the disease sites and compare with the liver background, as well as the uptake in the physiologic uptake in the parotid glands. So if we see the significant number of lesions which have uptake below the liver, we sometimes go ahead and do an FDG PET scan to see whether there is uptake in FDG, because if there's uptake in FDG, it will mean that those lesions are already differentiated. So basically for us, we use imaging to determine which patient is appropriate for the, whether a patient is appropriate for therapy or not. I know that there are other technologies which can be used to sort of assess the tumor heterogeneity, like radiomics, whereby like sort of like a specific lesion is analyzed using some technology to just give further characteristics of the tumor lesion. But as of at now, what we look at is more of the disease, the distribution pattern and the heterogeneity among the different lesions, rather than an individual lesion.
Perfect, thank you. And I hope this now starts the whole thing about radiomics, and we can actually talk about it in our tumor boards. Dr. Harish, I know in every tumor board we are beating you down to tell us the SUV max, SUV max. So what's the value of that, and does that have a threshold for tracer uptake depending on what the SUV, or is there some other measure that you use?
Thank you for that question. Actually, I'm glad that many oncologists are here. Actually, SUV is very subjective to start with, because it depends on multiple factors, be it the injection dose, how the distribution has been in the body, and how the patient, like maybe the weight of the patient, etc. So there is no universal cutoff for SUV values. However, as Dr. Mania was pointing out, we make sure that there is a baseline for us. Meaning to say, if we are looking at probably PSMA therapy, for us, we have to look at, when you're doing F18, probably we make sure that lesion is above the normal background uptake of the liver. And when it comes to neuroendocrine, we also look at something called as screening score. It's basically like something like lymphoma from 0 to 4. 0 being there's no uptake at all, and 4 being higher uptake than spleen. So in this category, something between 3 and 4, that is uptake should be more than liver, and then uptake more than spleen is 4. That is when now we deem the patient probably you can do. But SUV value as such, it's good that you asked this question. I can tell oncologists that don't worry about SUV, because I've also seen TB going up to 25, 24, and we can't call it as malignant. Thank you.
Thank you. And then as we are moving towards more personalized oncology, I don't know if in the field of theranostics we are going to do personalized dosimetry for patients. Is that something that we need to consider or think about when you are thinking of theranostics?
So ideally, should we do personalized dosimetry? Yes. Now in radiation therapy, they do it every single day, where the physicist plans for the tumor and all the OARs are factored in. But you'll find in nuclear medicine, we give like a bulk dose, the activity for an average sized patient. So ideally, yes, in time, we should now prescribe activity based on our tumor uptake and also taking into account the organs at risk as well. So that is the way we should go.
And because I'm sorry, I'm the oncologist, I have many questions. So post chemo, radio, and especially for our prostate patients, because we are having quite a number of them, and lutetium is coming sort of towards the tail end of therapy. Are there any effects on the duration from the time you give radiation, effect from the time that you give chemo for selection for patients for theranostics?
Thank you for that question. Yes, there is. So ideally, we have to wait for at least 4 weeks, and this is because for chemo, especially for chemotherapy, some of the side effects can sort of determine whether our patient is eligible for therapy. Some chemotherapy can induce like anemia, reduce platelet levels, and all that. So we give at least 4 weeks for the marrow to recover before we can consider the therapy with lutetium.
Perfect, and that's a good ballpark figure. You'll give a month, 6 weeks before change of therapy from one to another. And then given linear energy transfer issues, and I think for the people who do radiophysics or understand the radiophysics, is there any choice criteria between choosing an alpha emitter, beta emitter? Can you use any? Can you use both?
So alpha emitters, as we know them, they're like very, very heavy particles. So most, like radium emits alpha, so that's good for bone mets. But then you'll find now we have lutetium. We have lutetium, which now at some point when we have beta particles and we have the gamma particles, the beta is good for the treatment part, and then the gamma is good for the imaging part of it. So those are the factors that come into consideration. So we look at the particle side of it, which physicists in the house, we get to bore them with the physics, and then we look at the particulate part, which helps us with imaging. Thanks.
Perfect.
Maybe just to add the clinical bit of it, we at times when we are looking at beta versus alpha, what actually determines is the amount of disease. If probably PSMA scan looks like a super scan, whereby a lot of marrow uptake is there, ideal tracer would be alpha therapy for that in that case, because we don't want further the bone marrow to be suppressed. Secondly, the only notable disadvantage with alpha therapy is it goes to the salivary gland, and then problem of xerostomy and other things comes up. Yeah. Perfect.
Dr. Mwanja, you want to add anything?
Maybe just something small. So when we talk about the LET, the end issue or what we are looking at is the range at which the particle, either the alpha or the beta particle, is going to sort of cause effect. So for the beta emitters, they have a longer range because they have a lower LET than the alpha particles. So that means that it might not affect just the cell which took up, which is emitting that beta particle. It can also affect adjacent cells. I think we call it in radiation, what do we call it? Crossfire effect or something like that. Okay. Yeah, so yeah, it's called crossfire effect. So theoretically, beta emitters are deemed to be better for larger particles compared to alpha emitters. But I think recent studies are showing that even alpha particles can be used for larger tumors. And we know the advantage of alpha particles. They sort of emit higher energy photons.
Shorter distance also. And a shorter distance.
Yeah, and a shorter distance.
So then the effects may actually be less. Yes. So Dr. Wanje, as the first trained radiopharmacist in the country, congratulations. What exactly do you do? Do you come to the tumor board? Some of these questions, should we be addressing them to you, or we call Mwania and Harish?
Well, thank you very much for that question. As a radiopharmacist, I'm very much interested in first the production of the radiopharmaceuticals. I'm also interested in making sure that they're used safely. So quality is very important for me because my colleagues have said that that the biodistribution is very important, okay? Because you want to target the tumor. However, if the product is not of the best quality, you can easily have the radionuclide going the wrong direction and the targeting molecule going the other direction. What is the result of that? You are going to get toxicity and no efficacy. So this is the very important part for me.
Perfect, thank you for that, and for clearing that up for us. And finally, what are we looking out for, or what is upcoming in terms of theranostic pairs? Is there something in the offing for us that would balance between the alpha emitter, the beta emitter, and we have zero side effects but maximum therapy?
Yeah, thanks. Again, currently we are progressing very well. The only issue is the access, as I was mentioning in my presentation. When you look at the new upcoming, the pairs which we are thinking now, is FAPI. FAPI has actually now convinced many oncologists that it is not a mere tracer, but actually adding much value because it's concentrating the tumor stroma as well as the microenvironment. And what it does is now, again, we are going to use the gallium imaging tracer and then combine with lutetium. The mechanism is still the same. We'll use the same way as we are using for PSMA or dotatate. That is one thing. And also we are going to use CA9 soon. That is now for clear cell renal cell carcinoma. That is also in pipeline. So these two, I think we can expect something maybe in early next year or something in the country. So that will be
perfect. Thank you. Just one question in the room.
Just, okay. So thank you very much for your presentations. I'm actually quite impressed, and I hope that this is going to be something that's going to add positive value to oncology. So please, to the presenter, I wanted to ask, you said in your presentation, so far you have done for 15 patients. So how many patients have you screened out for you to be able to achieve that 15? Is it that 15, every 15%, or you, like, how many people didn't meet the criteria and out of, before you were able to get those 15? Then, based on your experience now, what do you advise clinical oncologists to do for like advanced prostate cancer? Because at some point, after the disease is like high burden, you are confused, you are like trying to choose between going for further chemotherapy, targeted therapy, and everything. All of these have limited option. What do you specifically advise now based on your results and finding? And then to the last presenter, I wanted to ask specifically, it's like until the patient comes to the center before you be able to do the baseline investigations to assess whether they are eligible or not eligible. So on a practical terms now, if colleagues are going to refer this patient from other regions or counties, how do they link up with you, and what should they counsel, how should they counsel the patient so that the patient doesn't have too much hope, travel a lot, spend time, money and resources only for them not to be qualified? Thank you very much.
Thank you for those questions. Maybe I can start. So for your first question, how we got those 15 patients. So mainly we rely on the oncologists. They are our clients, if I would say that. They're the ones who sort of pick patients who've had like quite significant treatment history, and yet disease is progressing. So they're the ones who send those patients to us for review. In addition to that, we've had quite a number of patients who've come. We review and we deem them fit and suitable to benefit from this therapy. But because of finances, I think that's one major issue. And if we could possibly maybe lobby the government through SHA to sort of support these patients, because I think that's one big hindrance to many patients getting or benefiting from this therapy. The second question was on, sorry, just.
Yeah, so now I'm like, what do you advise we oncologists now in relation to the advanced prostate cancer? At what point should we send them to you? Should we exhaust all the options, or at what point do we think that may be best for the prostate cancer patient to come to you?
Okay, so I think currently there are quite variable practices. So if we start with the Vision trial, which was like the first trial which approved the use of this lutetium therapy, specifically Pluvicto, the patients were heavily pretreated. They had received chemotherapy, ARPs, and everything. So they were sent like to theranostics as a third line. But we've, after that, seen trials whereby patients are being sent even before receiving chemotherapy, and they have responded. So I think there's no one best answer to that. It's a one-on-one basis. We review the patients. We see some patients are refuse to get like chemotherapy. So we've had like 2 patients who are sent to us straight after just receiving ADT and ARPI without chemotherapy because they do want the chemotherapy, and they've actually benefited from the chemotherapy, from the theranostics. We've also had a scenario whereby the patients are on the ARPAs. We have had a patient who was on enzalutamide, and they were sent to us, and they've responded very well. So I think we review each patient case by case to determine which patient we think will benefit more from the theranostics compared to other treatment modalities. Sometimes they are combined. There are very many studies which have been done, which have shown a significant sort of benefit when combination therapy is done. So, yeah.
And just to add to that, the tumor board becomes the most important part so that the patient is discussed and sort of their treatment journey is mapped out based on the patient because it has to be individualized. And I'll tell you, we don't have a lot of patients who are doing lutetium as an upfront treatment. They are getting it sometime later, which I think is something that we need to change once now this therapy is affordable and ready. I think the last question.
So before that last question is asked, maybe just regarding, there's a study, a trial, the PSMA-4, whereby they are trying to give the lutetium before in patients who are taxane naive, and they've shown significant response to treatment compared to patients who are doing the conventional therapy.
Okay, thank you very much for the presentation. I think it's quite enlightening. This is out of interest. I've seen like some patients have responded very well. For the KU patient, I didn't see any disease after the lutetium. So I was wondering, do you continue with ADT after that, or do you continue with anything, give the patient anything because he was metastatic, or do you wait for the disease to come back? Thank you.
I think that's a very good question. I was actually waiting for that because what happens is, firstly, we are a resource-constrained region, and I can't tell the patient that now you will need at least 4 to 6 cycles for every patient. So what we did was, as Dr. Jireni was pointing out, we had an MDT, and this patient was managed both by oncologists as well as urologists to start with. We decided that this patient now, he didn't want chemotherapy, I was explaining you. So we did pre-taxane lutetium. And we could see that as the PSMA dropped significantly, as Dr. Monia was presenting very early, she said, we treat what we see. So here, in the last scan, after the 2 cycles of PET, there were no receptors to target. That's the basic thing. If you don't have enough receptors, then what will you target? So we put the patient on holiday, and he's on under the management of oncologist and urologist. And I just spoke to him 2 days back. He just had some mild pains, but nothing. The imaging was still negative, and his PSA continued to be 0.08. So he's doing very well.
Excellent, thank you for that. Just to point out the study that Dr. Monia was talking about, I think there's a slight increase in the rate of fractures, and that's maybe has been the thing that people have stepped away from giving upfront lutetium. And just to answer Susan, we go back to MDT, tailor your treatment to the patient in front of you, and you use metrics, not just the PSA. And as Prof. Roach said, PSA is a good marker, but it can also lead you down a very difficult path. So if you cannot target something, you can continue on PRRT, then we will continue on systemic treatment depending on how the patient is doing. So a round of applause for our team. Thank you so much. This was very exciting. So you can come down. And then I think Prof. Mark Roach will listen to your last presentation. Welcome.
Well, do we want to wait till the photos? No? All right, okay. Well, you know, it's interesting, these 2 areas overlap because what we're talking about are patients with oligometastatic prostate cancer in many cases. And the treatment of these patients is evolving very rapidly. One of the things I noticed when you're talking about theranostics is very frequently you don't get long-term control of the disease. When we do metastasis-directed therapy with SBRT, our control rate is very long. Many cases, permanently controlled 90%. So I think that as radiation oncologists, the question about when do you send the patients for theranostics, in the United States, the approval for the use of these agents is in patients, in many cases, who've progressed after systemic therapy, and that's typically where we use it. In the setting of people that have limited metastatic disease, my oncologist frequently will send the patients for SBRT because it's cheaper and it's faster and it's highly effective in terms of local control. So there's a plethora, I've been wanting to use that word a lot lately, of options. The one at the bottom, LUNAR, is interesting because this was a randomized trial looking at the addition of these theranostic agents, PSMA PET therapy after, well, they were randomized to receive it or not to receive it. And so we're actually moving to a place where we're doing both metastasis-directed SBRT and adding these agents with evidence of enhanced results. But there are many studies that have been done, and why are we doing these studies? What are some of the issues? Well, we now know that metastases metastasize. So part of the rationale for not leaving areas untreated is that those areas, and this is the evidence for this is based on very elegant studies where they look at the genetic profile of disease in multiple locations so they can show where it came from and that it's a metastasis. And while talking about oligometastatic disease, this is an example of a patient that I treated on a trial, RTOG 0126. We radiated only his prostate. His PSA nadir was never as low as we would expect, and it gradually started to rise. This is before we had PSMA PET. We subsequently identified which is probably a node, a periprostatic node on just routine CT. And we actually biopsied it and showed that it was a high-grade lesion. And we actually had my urologist, the other thing, these slices are supposed to be somewhat comparable, but it's just to make the point that the nodule is big on the left side and not on the other side because of respiratory motion, which is one of the reasons that you really want to use fiducials when you're doing SBRT. So we put a fiducial in that nodule, which is biopsy proven, and we radiated that specific area. We did some hormone therapy, some radiation, and this patient was controlled with normal testosterone years later. So the point is, this is a proof of principle. The patients that present with isolated oligometastatic disease can apparently be cured if their area is identified and adequately treated. This patient would not be a candidate for theranostics, but certainly is a candidate for SBRT to that area. Now, when you talk about the management of patients with oligometastatic disease, it really depends on the site of the metastasis in terms of what the prognosis is. So there's a much better looking at overall survival, much better survival in the people that have lymph node positive disease compared to patients that have visceral disease or bone disease. And one of the controversies is when we use the word oligometastatic disease, are we talking about synchronous versus metachronous? In my opinion, we really should restrict it to those patients with metachronous. These are people for whom the primary was treated, the primary was controlled, the patient pops up with an isolated metastasis. Those are the patients that we should be treating very aggressively. In the patient that walks in the door already with metastatic disease, I don't like to call those oligometastatic. I just call those metastatic. Now, when we look at the management of those patients with oligometastatic, and this is metachronous, these are people that have had a local treatment. Typically, these are post-prostatectomy patients. And these patients underwent surgery excuse me, as the preferred approach for dealing with their metastasis-directed therapy. These patients had PET scans. One of the weaknesses of this study is that some of these are C11 choline scans, which are not as good as PSMA. But the fact is they had, on average, when they looked at these patients, 2.1 nodes. So they took these patients to surgery, and they found that, that some of them indeed had what appeared to be a single node, but many of them had 3 or more nodes, at least 2. And actually, that was their initial scan, and then post-operatively, this is the bottom, 54% had greater than or equal to 3 nodes. So the point is that their preoperative assessment suggested that the bulk of the patients had an isolated node, but when they got to surgery, they found the bulk of the patients had more nodes, but even more problematic is the fact that the control rate was extremely poor. These are recurrences after salvage surgery for oligometastatic nodal disease. So the point is, the preferred treatment in patients with oligometastatic nodal disease is radiation. And this is a study looking at extended nodal radiation versus limited nodal radiation, suggesting that the pattern of failure, it was substantially better when you did extended nodal radiation, and when you do focused nodal radiation, that you tend to get more failures in other nodal regions in the area. So when you see a patient that had a radical prostatectomy or radiation only to the prostate, the PSA is going up, you do a PET scan. If you just radiate that spot that popped up on PET, those patients are likely to pop up with another spot that's going to light up in the nodes, and it's going to be more challenging to treat them again because of potential overlap. So again, the treatment of choice is the use of a more extended approach. The classic study that I think points out the importance of treating all the areas that are positive on PSMA PET, of course, is the Oriole trial. So the curve, I'll just focus on the curve on the right. If you treat all of the areas that appear to be PET positive, you get a much better biochemical progression-free survival than you do if you treat a limited area. So when you have patients that have multiple areas, you really should treat those multiple areas and probably use extended treatment. Now, these are some of the important trials addressing metastasis-directed therapy, and there's a consistent pattern. If you look at Peace 5, Storm, if you look at Radioso, Extend trial, all of these trials in general, they tend to suggest not only is metastasis-directed therapy highly effective, but a bigger treatment, a bigger field is probably better than a small field. This is from the Peace 5 Storm trial, and suggesting again that those patients that had elective nodal versus simply metastasis-directed therapy had better control rates. In the Extend trial, again, a similar pattern. Actually, this is a study that looks at metastasis-directed therapy and hormone therapy versus hormone therapy alone. And so metastasis-directed therapy improves the outcome of patients. And there are a lot of times the patient doesn't want to take hormone therapy. But I think the take-home message is that if you want to get the best results, it's better to use hormone therapy and metastasis-directed therapy. This is a study looking at radium-223 as an ablative agent. It's basically a negative trial, but this was followed up by a trial using PSMA PET, the so-called Lunar trial, and this is the one that I alluded to before, suggesting that, that if you do metastasis-directed radiation followed by or I don't remember, it was followed by or preceded by, but combined with the lutetium, you get a better overall result. And in the interest of time, this is from my old study, 9413. It basically suggests that you really need, if you're going to cover the nodes that pop up might appear to be only involving a limited area, but the fact is the PSMA PET as a staging agent is only about 40% sensitive. So if you see a few nodes, you have to understand that there are likely to be other nodes that are even higher up. So metastases metastasize. Metastasis-directed therapy appears to be very safe and effective. Large fields do better than small fields. Adding it to hormone or systemic therapy, whatever it is, and the impact of prophylactic metastasis-directed therapy remains to be determined. We don't know if it prolongs survivals, and biomarkers may help us figure out who benefits the most. So my take-home message is oligometastatic disease should really focus on those with metachronous disease, not those with synchronous disease. Systemic therapy should usually be a component of treatment. External beam is well suited and I think more effective than any of the theranostics. The theranostics are more like chemotherapy. You don't see long-term local control in many of these patients. And the issue of how to sequence, how to combine metastasis-directed therapy with what drug and when you should give the drug, all of these are factors that have to be addressed. And I think that it's preferred treatment, except in cases where you can't do it. So with my final slide, from my mentor, Ted Phillips, if you don't treat for cure, you won't cure those you treat. Thank you for your attention.
Thank you, Prof. Questions?
I'm sure all of you are doing this all the time in the clinic now.
I know.
So it's something that's going to be more, and I think you all have good experience with it. Thank you.
Thank you. So we need to move out into the breakout sessions. This remains room 1, room 2 is next, room 3 is across. Just look at your program so that we can start, and you should be ready in about 5 minutes. And we'll be back for the closing after the plenary. Just scan the QR code for your pictures. Thank you.
Yeah, I treat them all the way.
So we'll be convening back here after your breakout sessions. Please make quick so that latest 5:15 you are done. You come for the closing ceremony. We have more goodies to reveal. We'll be revealing the next country where AFROG will go. And on screen, we have the QR code for all the photos that were taken. You can scan the QR code and download. For the 3 days, the photos will be there. And then we'll also share the link for the videos. For all these presentations, you can access them online. You can share with your friends. They can also access the 3-day conference. All the presentations are there. So you can always listen over and over. So you've not missed anything. If you missed day one, you can still catch up. So please let us be back here after the breakout sessions so that we can close and then go for dinner. At dinner is when we'll be giving awards for the best abstracts. Thank you.
But every photo and video will be there. As explained, we are going to have 3 breakout sessions. This one is going to be divided into 2. Then the next one is going to be 3. So it's going to be 1, 2, 3. Okay? So you pick from the breakout session which one you want to attend. Okay? So here we have the first one here. The second one is going to be the behind. Then the third one is going to be the next door. You have to use the other door. Thank you. So here is what? Okay.
I think.
So here is Victoria 1. If you want to listen the session of Victoria 1, please stay here.
I think for Victoria 1, we have more presentations. So I want to believe all the speakers, you submitted your slides, and I will just implore you to limit yourself to the 7 minutes allotted. Please, IT, always display the time, and please just go straight to your points because you don't have time. By 7 minutes, we stop you so that at the end of the day, we can have about 5 minutes for questions and answers. So without wasting much time, this session will be on GI malignancies and brachytherapy. I will invite the first speaker, and the topic is anal cancer patterns and outcomes, Dr. Eben Ajay.
Good evening, everyone. I'm grateful to be here. Thank you for inviting me. I'll be taking the clinical pathological characteristics and survival outcomes of gastric adenocarcinoma, a retrospective analysis at the Tertiary Oncology Center in Lagos, Nigeria. You can see the authors and the affiliations, and I'm the one presenting. So gastric cancer poses a significant burden in sub-Saharan Africa, yet regional data remains sparse. These studies delineate the clinical pathological profile and survival outcomes of patients treated at my center. So the objective was to determine the clinical pathological patterns and evaluate survival outcomes and compare that with the histological subtypes. Of course, it was a retrospective analysis, and the study period was between 2019 and 2025, and the social demographics, clinical and histological data extracted from our records, and the Kaplan-Meier survival estimates generated for the cohorts. And the statistical analysis, as shown there, the SPSS version 27. So we can see here that the mean age of 87, the numbers that we had was 87 and the mean age of 58.1236, and the ranges was between 32 and 86 with a male preponderance of 69%. The symptoms, weight loss, was found in 56.3%, abdominal pain in 48.3%, and emesis in 31.1%. The adenocarcinoma was the predominant histology of 87, and intestinal type was more than the diffuse, as stated. Stage 4 presentation was 56.6, and hepatic spread was found in 19.5%. The median overall survival was 18 months, and there was no significant survival difference in the two histologic types. But it's important for us to know that the key clinical and pathological features are stated. As I mentioned before, the hepatic metastasis was found in 19.5%. Comorbidities, there was 50.6% of the patients that were reviewed had comorbidities, and all other symptoms as expressed. Advanced stage of presentation, which was most common, was in 56.6%, and reflects the pattern of late diagnosis typical of gastric cancer across sub-Saharan Africa, where symptomatic screening and endoscopic access remain limited. The predominant intestinal type is consistent with prior regional reports, even though there's a lack of statistical significance, survival advantage over the diffuse type, and suggests late stage presentation and diagnosis. The limitation of the study was the fact that it's a single-arm retrospective design, and the Lauren classification was indeterminate in 34 of 37 cases, and 37% in 34 of 87 cases, that's 39%, and limiting the subtype comparison. In conclusion, gastric cancer in the Nigerian cohort presented predominantly at advanced stage with intestinal type histology predominating. Then the absence of survival differences in the histological subtypes reflects a heavy late-stage mortality and burden rather than an absence of biological difference. Then early detection protocols and genomic characteristics are urgently needed to improve outcomes of gastric CA in sub-Saharan Africa. Thank you very much.
Thank you. I think we'll leave question and answer to after all the presenters have made their presentations. We'll move straight to the next presenter, who will be speaking on neoadjuvant chemoradiation response. Seyum from Ethiopia. So your 7 minutes starts now.
Good afternoon again. I'm Dr. Samrawit, clinical oncologist from Ethiopia, also affiliated with Kampala International University Hospital in Uganda. So I just wanted to say a few things on our experience at Black Lion Hospital in tumor resectability and pathologic response after neoadjuvant long-course chemoradiotherapy for locally advanced rectal cancer. So just to say a few things about background in Ethiopia. So as it is in other African nations, colorectal cancer incidence is increasing. So it's one of the commonest cancer in males and the third commonest in women. So this study was conducted at Tukrambasa Specialized Hospital, which is the largest tertiary hospital and the only oncology center at that time. And multidisciplinary decision, as we know, is important in the treatment of rectal cancer, which includes surgery, radiotherapy, and systemic therapy to the least. And there was a persistent gap that we identified, which we're going to see, as there was a lack of evidence of resectability and pathologic response in resource-limited settings. So our objectives were: how often does neoadjuvant long-course chemoradiotherapy result in tumor resectability and pathologic response in resource-limited setting, and what factors were associated with this? So evidence in the African setting were very limited. So in this cohort of predominantly locally advanced rectal cancer, so we were able to see that there were prolonged treatment time intervals, and fewer than half tumors were considered to be resectable by the end, and only 1/3 of our patients had underwent curative therapy in the end. So our methods were 87 patients were identified within that 5-year interval that took long-course chemoradiotherapy, and 9 patients and 20 patients were excluded due to incomplete documentation and not completing of radiation. So finally, our cohort consisted of 58 patients for the analysis. So our eligibility criteria were T3, T4 tumors who had completed this neoadjuvant chemoradiotherapy and had a documented post-treatment assessment, and logistic regression was done to assess which factors were associated with the resectability and pathologic response. So I'm going to skip on operational definitions, which are clear for the majority of us. So the interesting about the baseline characteristics of our study patients were the median age of our patient was 45 years, which is in line with the current evidence showing increment of colorectal cancer among the young population. So, and majority of our patients were most advanced patients, with around 85% having a positive circumferential resection margin. And so treatment characteristics, so this is something we could actually be proud of. MDT discussion was available for around 98% of our patients. So this is one of the good things that we have found, and a radiation dose of 45 to 60 gray was used in our study. So when we see the treatment timelines, so we had significant delays both in initiation of radiotherapy and initiation of surgery. So the time from diagnosis to radiotherapy initiation was said to be around 64 weeks, which is very, very disappointing, but this was what was happening. And the time from long course chemoradiotherapy to surgery was around 10 weeks, which is not as significant as the radiotherapy delay, but still beyond the recommended timeline. So in the end, less than half of our tumors were deemed resectable by the MDT. And from those, only 30% had underwent curative intent of resection. The reason for avoiding surgery were patient developing metastasis in around 11 patients, and patients being unfit for surgery and patient refusal were among the reasons. So of the 19 patients which had undergone surgical resection, so we did not have any complete pathologic response, and more than half of the patients did not have any pathologic T-stage downstaging. So we attributed this to likely having an advanced disease at presentation and a long treatment interval, as well as a long time for surgery. So among factors that were significantly associated with resectability, we found an earlier stage, T-stage, having a favorable association with resectability, which is what we expect. And total neoadjuvant therapy was actually shown to have a negative association with resectability. We attributed this to having an MDT discussion, and patients being assigned to total neoadjuvant therapy were more advanced and had bulkier tumors. So how does this cohort compare to landmark trials? So majority of our patients had clinical T4 disease, which is comparable to the landmark trial of Polish-2, but significantly higher than the other more recent trials of Rapido and Prodig. But circumferential resection margin were positive in majority of our patients, and negative margin and pathologic response were much lower in our setup than the landmark trials. So our conclusion and our clinical implications are we had advanced disease at presentation, and most of our patients were clinically T4 and had positive CRM. So more than half had remained clinically unresectable, and delays had eroded the curative potential for our patients, both to radiotherapy delay and surgical delays. So the other one is MDT selection matters. So those patients that would actually benefit from chemoradiotherapy should be given this modality of treatment. And of course, timely radiotherapy access and timely surgical interventions are things that determine the outcome for our patients. So our limitations in the study was the retrospective design, and it's single institution based. So we can't generalize to the whole continent, but we feel like this could represent the case for many African countries as well. So as a summary, I would like to say that the significance of this study is that majority of African countries can relate to the radiotherapy delays. So this is the first cohort in my country to show actual data that pathologic response and resectability may not be as high as the Western countries while we're treating patients to long course chemoradiotherapy. And some, we are thinking molecular characteristics should be determined because our patients are young patients and they may have different biological drivers than the Western population. So finally, our take-home message is, should we consider hypofractionated short course chemoradiotherapy for a setting like ours? Considering the similar overall survival and better outcome in the Rapido and the Prodig studies that have shown that if for our setup, maybe we should consider the short course 5 days, 5x5 fraction more, so that we decrease tumor mushroom burden and we increase availability of radiotherapy for our patients. So why is this important for the AFROG? Because it speaks to most of the sub-teams for this conference, because expanding radiotherapy access is what is shown in our study, because we need to expand radiotherapy to decrease waiting times, workforce and capacity building. MDT engagement is extremely important, and research and emerging frontiers. So we need to do biological markers for our young patients, which are now presenting with advanced rectal cancers. So this is my presentation. I say thank you.
Thank you for keeping to time. We move straight to the next presenter. The topic is argon plasma coagulation for radiation proctitis. That will be by Dr. Alex Muturi. Seven minutes.
So in the spirit of passing the torch to the next generation, another colorectal in the making, Dr. Florence, will give the talk.
Thank you for this opportunity. I'm Florence Wanjiro, acknowledging my teacher and supervisor, Dr. Alex Muturi, giving a talk on argon plasma coagulation for radiation proctitis, an experience from our hospital, KUTRRH. Radiation is a major treatment modality in pelvic malignancies. And we see that in radiation proctitis, it's very common in patients receiving higher doses of radiation, especially those receiving radiation doses up to 70 grays, sorry. So radiation proctitis can be acute or chronic. Acute is where we have presentation up to 3 months after radiation has started, and chronic is after 3 months after radiation has started. Most of the patients present in the chronic phase with an average time of between 8 to 12 months. And with this period, the pathophysiology is mostly progressive ischemic. We have patients presenting with mostly rectal bleeding as the predominating symptom. Why are we discussing this? We have reduced quality of life in our patients who have constant anemia with frequent hospital admissions, and of course, we have the financial implication of this. So why are we discussing this in our setup? When I was going through data, I only found one data in Africa, from South Africa, where they studied around 58 patients in a period of 12 years. So we see this is something we need to discuss in terms of having more data from our setup to create more protocols that are tailored to our society. So when we were doing the study, the primary outcome was basically to check rectal bleeding cessation after APC, and also reduction of transfusion needs for our patients. Also, we checked the treatment efficacy of the management and also the safety profile. So the study tried to study our patients between February 2024 and May 2026 in our setting where it's KOTRH. And basically, it was with patients who presented with rectal bleeding after radiotherapy. Of course, we had to exclude any patients with active malignancy, so we have to rule out recurrence as a cause of bleeding. And also, willingness of the patients to participate was an important key factor. 74 bookings were made, but you'll see I'll discuss a total of 33 patients because APC comes with frequent, or rather more than one session for the same patient. So we analyzed 33 patients, majority were female, up to 75%, with a mean age of 62.9. The primary malignancy presenting with radiation proctitis was cervical cancer, followed by prostate cancer and vulval cancer. So clinical presentation, most of the patients presented with bleeding, as I'd mentioned, and up to 46.7% of patients presented with mild to moderate anemia with a mean HB of 9.6. We have a subset of patients up to 20% who presented with severe anemia, and we had one outlier who had severe symptoms and had HB of 4.4. So in endoscopic presentation, majority had telangiectasia, with some presenting with active bleeding. We have 9% with ulceration, which is now towards a complication of proctitis, and one who had a mass, which was later ruled out to be benign. Most of our patients had between 1 to 2 sessions. There are some who would have loved to have more, but in our setting, we have a bit of financial constraints sometimes. So maybe it's something to think about when you're talking about policy and including funding for such procedures for our patients. 39% received APC alone as a treatment modality. 42% received formalin irrigation as an addition. And there are those who received sulfate enemas as well, in addition to APC. So we just put up some images to show how this would appear in endoscopy. Actually, this is milder forms of disease, where most of the time APC and formalin therapy manages this. This is a video showing a more severe form of radiation proctitis, where we have necrotic tissue which was appearing black and white on the area, and of course the telangiectasia and a bit of bleeding. So these patients, the radiation proctitis is graded from grade 1 to grade 4. This is mostly grade 4. And you see that this one needs several modalities for treatment, including medical management, APC, and we see the use of hyperbaric oxygen therapy, which is currently not in our country due to financial issues, but it's very helpful in situations where it can be used. In terms of the outcomes, of the patients we talked to, the 33 patients, 85% had clinical improvement, with 55% actually reporting complete improvement or resolution of symptoms. We only had 15% who had like progressive symptoms of or some bleeding after the procedures. So in terms of transfusion needs, there was marked reduction in transfusion needs for the patients who had undergone APC, with only 2 patients needing transfusion after APC, and one of them was the one who presented with very severe symptoms, very severe anemia of 4, and needed up to 7 units post the procedure. In terms of the safety profile, only 6% reported minor complications which were self-limiting. Mostly the symptoms that presented was some rectal pain and post-procedural spotting, which subsided. There's only 1 patient who we had to defer the second episode of APC because of mucosal thinning and fear of perforation. So in terms of recurrence, there was some recurrence in some patients, but still they reported even if there was recurrence, the symptoms were not as severe as the initial presentation. And we note that the patients who had more severe presentation are still the patients who had higher risk of recurrence, and also are the same patients who had higher episodes of need or no need for more sessions for APC. We see that also the patients who received a combination with formalin therapy had better outcome with reduced recurrence. So what do we deduce from all this? With the clinical improvements, a pretty good safety profile, and the reduction in transfusion, it is in keeping with the international guidelines, and also both European and American, where radiation proctitis we use APC as one of the first-line endoscopic management for radiation proctitis because of its efficacy, safety profile, and improvement in quality of life of the patients. So what do we take home from this? That APC works as a first-line endoscopic therapy. Of course, we can use it with other modalities, such as formalin therapy. We should anticipate more than 1 session for our patients, so even when you're preparing our patients, that's something to prepare them for. And of course, there's need for more African data so that we have better standardized protocols for our setting. And also, you're welcome to KTRH and bring your patients for APC. Thank you.
I must say kudos to Dr. Ales Muturi. This is the kind of thing we are encouraging. And for you to get around, she has done very well. Thank you very much to the 2 of you. We move next, so be prepared for the questions that will come up. Next is gastric adenocarcinoma characteristics by Dr. Eben Aji. Again. So your time starts now.
Yeah, good evening again, and thank you for the privilege. Now I'll be discussing the clinical pathological pattern and survival outcome of anal cancer in sub-Saharan Africa. You can see the authors and the affiliations, and I'm the presenter. Now, anal cancer is not typically prioritized, given to its rarity and heavy burden of more prevalent cancers in sub-Saharan Africa. and often presents at late stage with poor survival outcomes. Now, given the paucity of local and regional data, this study aims to determine the clinical pathological pattern and survival outcomes of anal cancer at our center. The aims and objective is, of course, to describe the clinical pathological pattern of anal cancer in our center and the survival outcomes, and identify factors with, that are associated with poorer survival in the population under study. It was a retrospective data collected over 5 years, 2019 to 2024, and analysis was done through the SPSS version 27, and the records were obtained from the EMR of the center. Mean age was 52.68 plus or minus 12 years, and 73.7% of them were female. Of course, the histology was squamous cell CA, and the predominant stage was stage 3 with 63.2%. The symptomatology included weight loss, anal pain, and an anal mass and swelling. And the treatment that was given was chemoradiotherapy, surgery, and chemotherapy in 68.4%, 36.8%, and 21.1% respectively. The associations found was BMI with family history, the p-value of 0.009, and smoking with p-value of 0.032, and the comorbidities with HIV status with 0.005. I had a median survival of 18 plus or minus 4 months, 2 years survival of 22.6%, and alcohol use gave a poorer predictive survival value, and the p-value of that was 0.04. The key features and the outcome stated there was the 2-year survival, 22.6%, radiotherapy, who received radiotherapy was 68.4%, the stage at diagnosis 62.2%, the anal mass and swelling down to the preponderance of the female sex at 73.7%. Discussions is the fact that high proportion of stage 3 disease was found at presentation, and this also underscores the pattern of late presentation as seen, and also reflects the low awareness and limited screening infrastructure for anal cancer. Now, modifiable lifestyle factors, smoking and alcohol use, and comorbid HIV infection appear to compound poorer outcomes in keeping with literature linking HPV and HIV co-infection with anal CA. And the limitation, of course, is the fact that this study was done in a single center retrospective study with a relatively small cohort, limiting generalizability. At the conclusion is the fact that anal cancer in sub-Saharan Africa is likely diagnosed at advanced stages with poor survival rates. Squamous cell carcinoma predominates, and lifestyle factors, smoking and alcohol consumption with HIV associated with poor survival outcomes, as we have stated. So the important lesson is the fact that we need to screen, we need to emphasize on early detection strategies, and alongside optimal care and control modifiable risk factors, which are necessary to improve the outcomes of the diseases. Thank you.
Thank you very much. We now move to the next paper, Optimizing Treatment Pathways in Cervical Cancer, to be presented by Dr. Santana Dikir. Is he or she around? Or the representative? Nobody representing her here? She was here. Okay, we move. When she's around, we take her. The next one will be low dose rate brachytherapy in gynecology by Dr. Shehu Umar.
Brachytherapy after EBRT. Found that a patient who commenced the brachytherapy less than 12 weeks from completing EBRT were most likely to have absent disease after 2 years compared to those who started it 12 weeks later. We also found that those who received cumulative dose of greater than 70 gray had tumor control compared to those who had less. And then those who had tumor size of less than 4 centimeter had better opportunity for tumor control compared to those whose pre-brachytherapy tumor size was 4 centimeters after completing EBRT. And then those who used the dilute applicator had actually better opportunity of tumor control. So what are the important discussions? The first one is late presentation is still very prevalent with us, and it's something that has been consistent with other studies. Our brachytherapy procedure conformed to the American Brachytherapy Society and European Society for Therapeutic Radiation Oncology guidelines, and delay beyond 12 weeks of EBRT completion and brachytherapy was predominant, adversely affecting the outcome. And then study also found that the pre-brachytherapy tumor size was important in tumor control, and about 15% of our patients actually had acute side effects, which was quite high compared to what was found in some other studies that recorded 8% and 6% respectively. We also found that the late side effects were also consistent with what was found in other studies. And then the study also demonstrated the inferior dosimetric value of using cylinders, vaginal cylinders, compared to using applicators, which was consistent with what was found in other studies. And then the cumulative dose of 70 gray was demonstrated to be effective for tumor control. And then low dose brachytherapy was effective part of treatment for advanced gynecological malignancy with tolerable side effect and significant effect on the tumor-free survival and overall survival. So the take-home message here is first that we should document our practice so that the other colleagues can be able to share. Though the technology has come that we have moved or advanced from low dose brachytherapy, but what it's demonstrating is that with effective technique and use of appropriate technology, we can be able to have a lot of control for our gynecological malignancy compared to not completing the treatment. So in conclusion, the low dose brachytherapy is effective in management of gynecological cancer. Poor tumor control or persistent of disease was associated with pre-brachytherapy size of the tumor, and also the duration of commencement of brachytherapy following EBRT, and also the overall cumulative dose of less than 70 gray. So the advice and recommendation is that we should develop protocol for giving brachytherapy so that we can be able to minimize this constraint and maximize the effect of brachytherapy. Patients who have more than 4 centimeter pre-brachytherapy should probably be given some form of adjuvant chemotherapy before commencing on brachytherapy to get the effect. And also, we should be able to go as more than 70 grays so that patient will be able to have proper tumor control. This study is actually a retrospective study, and many of the participants were omitted due to incomplete data. So this may have generated some bias, or some group of participants will not have been factored in. And then also it's actually, because it's a retrospective study, some of the data that we'll need may not probably be available for us to have gotten. Specifically, the indication for use of the vaginal applicator, we could not really extract them from the case folder. It is actually a single center study, so we cannot be able to maybe generalize these findings. So these are the references, and I thank you very much for your time and attention.
I think we should take the next paper on hybrid brachytherapy before we now move to Dr. Santana Dike, Dr. Cherry Okumo. Okay? Please just take note of your questions. We ask them questions after all the presenters are done. So, Dr. Cherry Okumo, 7 minutes.
Okay, good evening, good afternoon. My name is Dr. Cheryl Okumo. I'm a resident at Muhimbili University in Tanzania. I'm going to be talking about hybrid brachytherapy. All right, allow me to use this case as my rationale for why I'm talking about hybrid brachytherapy. I'm going to present the case of a 56-year-old female treated at Ocean Road Cancer Institute in Tanzania, who presented to our facility in February with cervical cancer staged at 2B. She only had parametrial invasion. In the histology was invasive squamous cell carcinoma. She had a 2-year history of on and off postmenopausal vaginal bleeding with associated discharge. So she only had positive comorbidity of hypertension, and with the other metastatic workup being non-remarkable, we planned for curative intent. She was started on induction chemotherapy with carbopacly, and this was done every week for 6 cycles, and then we initiated her on concurrent chemo-rad. She did 50 grain 25 fractions with weekly cisplatin, completed on the 18th of May. Thereafter, we did an interval assessment with MRI, and it reported no cervical mass, just the uterus size as described above. There were no nodes, and the plan, therefore, was to do 3 sessions of ICT with, at Ocean Road, we do both 3D and 2D ICT because of limitation in costs. So because she was an insured patient, she had the luxury of getting 3D brachytherapy. So this is the plan. We contoured the high-risk CTV and the blood and rectum. You can see the dotted line in red being the high-risk CTV, and in orange on the right is the rectum. You can see the rectum is also included in the 90% isodose curve. So for the 3 plans for her treatment as demonstrated, in the first plan, we can see that the D90 was 7, the dose to the bladder was 4.1, and the dose to the rectum was 5.1. Progressively, the dose is lower in the second plan for the second insertion, where the D90 was 6.5, the dose to the bladder 4.2, and the dose to the rectum was 5.3. And the last insertion, the D90 was 8, with the dose to the bladder at 3.9 and the rectum at 4.4. So in as much as we prescribed 8 gray per fraction, the only plan that attained this was the last plan. So the challenge was mostly trying to balance the tumor control and trying to protect the organs at risk from getting the maximum dose. So this was the cumulative plan, and we can see the bladder did not reach the constraint, the limit being less than 90. We're able to get it to 67.3. However, the rectum was at 73.6 with a limit of 75 and below. So the rectal dose was quite high. And for our high-risk CTV, the total dose that she got was 80.9. So this is factoring in the EQD2 after doing external beam and brachytherapy together. So we were not able to reach the accepted dose to the high-risk CTV. So the reason why we are presenting this is because cervical cancer is a major concern for many of us. As from the latest global can we see in East Africa, we trend with an incidence of 33 and mortality of 20 In Tanzania, we see in our facility alone almost 1,400 cases of cervical cancer, with about 80% of them being locally advanced. So the challenge is for some of our patients, even after receiving EBRT, we find that the tumor size is more than 4 centimeters. We tend to still continue with EBRT through tandem and ring intercavitary, or sometimes we tend to opt for doing our cone down with EBRT, which we know is not optimal treatment. So there's been several evolutions in brachytherapy. We have progressed from low dose to high dose rate brachytherapy. We've moved from 2D to 3D planning, though I've mentioned that in some centers we are still limited and do 2D brachytherapy because of the cost of being able to do 3D planning. We have now awareness of hybrid brachytherapy, where some centers combine both intercavitary and interstitial brachytherapy. And then we also now focus on the importance of image-guided adaptive brachytherapy, with a recommendation of using MRI for the same. So this is a narrative review, and we're just talking about why hybrid brachytherapy should be considered in our setting. And we see the dosimetric advantages of doing hybrid brachytherapy in that they can be improved high-risk CTV coverage, we have better dose conformity, and better organ at-risk sparing. So I've mentioned the problem statement in our setting, and I'm sure it could be applicable in many other centers as well. So the rationale is, we know the limitation of brachytherapy facilities, not just in Tanzania, I'm sure in many other countries. In our country, we have only one center, which is Ocean Road, which offers brachytherapy in the nation. In Kenya, I believe it's about 5 to 6 centers as well. So we say that with 2D brachytherapy, large tumors may overgrow the point A, and the dose prescribed to the point may not be enough to encompass the large tumors. So the tumors that are outside that region might not be able to get the treatment, and therefore we have inadequate treatment of our patients. And then the other thing is, for the patients that are doing 3D brachytherapy, most centers, even in Tanzania and here in Kenya, we're using CT guided instead of MRI, and the limitation in this is that the differentiation of soft tissue is better with MRI, so that's why it becomes a gold standard recommendation for treatment planning. So the aims or objectives of me presenting this is to address the need for technical competency in interstitial brachytherapy, and to create awareness on hybrid brachytherapy for locally advanced cervical cancer, especially for patients who have large tumor sizes before and after EBRT. So I'll discuss some of the papers, that just one or two, that point out the importance of hybrid brachytherapy. So this is a study by Ladbury, reported in 2023, and it gives the indications for hybrid brachytherapy for large tumors where the high-risk CTV is going to be more than 4 centimeters, if there's parametrial extension with a lateral disease of more than 2 to 2.5 centimeters from the midline, for patients who have poor response to EBRT and patients who have asymmetrical target, they can be considered for this combination. So this study by Rogoski et al. In 2022 reported the outcomes of using the Venezia, which is a specialized applicator that has both the technology of inserting the needles for interstitial and also has a tandem and ring for intercavitary. And the report was that, so they assessed 46 patients with locally advanced cervical cancer, and out of this, the high-risk CTV was, the median dose was 92.3, and the toxicity, most of the toxicity was grade 1, about 74%. So therefore, 87% of the patients who received this combined IC-IS technique demonstrated high operability and consistency in terms of clinical adoption. So this is the local control that was demonstrated with about 97.6%, and the overall survival and distant metastasis-free survival, as we can see in the curve there. So this was not a comparison study, but just to wind up, I'll give one that compares the 3 treatment options. So we can see from this study by Walter et al., and he compared the high-risk CTV dose, the mean dose when using 2D, which is point A, when using intercavitary alone, and combination. So we can see the dose for point A is 73. When using IC alone, it's 95. And when using the hybrid, it was 100. And we can see the organ at risk, the dose that they were receiving was also much reduced with hybrid compared to IC and point A alone. So in the interest of time, just back to the case, how could we better optimize the treatment of this patient in order to achieve optimal dose for tumor control without normal tissue toxicity? We would say things like better biopreparation, which is true, but if we have the opportunity to be able to incorporate hybrid brachytherapy, then we can use the interstitial needles to be able to target the parametrial extension and be able to reduce on the CTV so that we can reduce the toxicity that the organs at risk are getting. So the point of this presentation was to be able to create advocacy for international collaboration to see if there are opportunities for training for interstitial and hybrid brachytherapy in East Africa and Sub-Saharan Africa as a whole, and resource allocation to equip facilities to be able to carry this out. Thank you.
Thank you very much. We now move to the last speaker. Optimizing treatment pathways in cervical cancer. Dr. Santana. Okay.
Hi, good evening. My name is Dr. Santana, the one and only Maasai oncologist. I'm a consultant radiation oncologist from Narok County Referral and a visiting consultant in Nairobi West Hospital. Today I will be presenting optimizing treatment pathways in cervical cancer, the impact of procedural innovation in radiotherapy duration. I did this as part of my thesis, and I was supervised by the president of AFROG, Dr. Catherine Nyongesa Sawata, and the head of department, Dr. Colin Onyambu, at the University of Nairobi. So the people who've come before me have explained what the disease burden looks like for cervical cancer in our setup, and it is the leading cause of cancer mortality in women, which makes it a pain point for the most of us. Our early disease is mostly a surgical disease, but from stage 1B3 to stage 4A, it is basically a radiation oncologist bread and butter. And when I was in school, I did wonder what our overall treatment duration was, because there are biological costs of delay. So the 56-day deadline is the recommended maximum overall treatment time for definitive chemoradiotherapy. Why? Because there's tumor repopulation, which happens after 56 days because it triggers accelerated cellular repopulation, actively undermining the therapeutic benefits. And there is local drop for every single day of extension beyond the 8 weeks disease local control by 0.5 to 1% for every day. So you radiate, but you miss out on your gains when you extend your overall treatment time. So for my study, I tried to figure out a few things that we could modify. So modifiable factors, which I postulated to be pretreatment hemoglobin, the EBRT technique, and brachytherapy scheduling, and the effect they would have on the chemoradiotherapy treatment duration. So it was a retrospective design. I analyzed 137 patient files, stages 1B3 to 4A, who were treated with definitive concurrent chemoradiotherapy at KNH National Hospital from the year 2019 to 2023. Now, why that period? During this period, the University of Nairobi, together with Kenyatta National Hospital, started a radiation oncology program, which meant there were more residents and we had more labor. So I postulated that then our overall treatment time should be shorter than what has been recorded in Africa, because our clinic went from having around 8 radiation oncologists to an additional of twice that thrice that number. The analysis was using SPSS version 25. I evaluated the bivariate and multivariable models. I controlled for confounding factors, and I got ERC approval. So what was my baseline cohort? The median age for my patients was around 49 years. Early disease accounted for around 40% of my patients. Locally advanced disease, like in most African countries, was around 60% of the patients. Anemia was prevalent, and we would expect it because patients present with chronic bleeding. The most common EBRT technique we were able to use was 3D CRT, and accounting for 65%, and 2D 35%. So when I analyzed my data, pretreatment hemoglobin levels, the hypothesis that pretreatment anemia leads to biological treatment breakdowns and delayed recovery did not produce any statistically significant data or variance in overall treatment time. The mean overall treatment time for patients who are not anemic was around 65 days. For the anemic patients, there was around 66.7 days. So it was not statistically significant. Then I compared the overall treatment time for patients who got 2D versus 3D. And for 2D patients, it was around 69 days, as compared to the 3D patients who the overall treatment time was around 63.41 days. And that was also not statistically significant. But the game changer was the timing of brachytherapy. So there was effect of scheduling on overall treatment time. So we had patients who were doing interdigitated brachytherapy, which is administered concurrently. So typically, in the third or fourth week, we initiate brachytherapy if the tumor is less than 4 centimeters or there has been significant regression of the tumor. Against the sequential. The sequential is when you wait to finish your EBRT and then you start your brachytherapy. So as you can see in the data, the patients who got sequential brachytherapy, the overall treatment duration was 69 days versus the interdigitated, and the interdigitated had an overall treatment time of around 51 days. I think that is a remarkable improvement, and it brings us closer to data that has been postulated in the Western world. Like Embrace 2 recommends less than 49 days, and 51 days is so much closer to the international guidelines, and it actually is better for the patient. So the findings demonstrate the integration of brachytherapy is the most significant modifiable factor for reducing treatment prolongation. So therefore, if we are able to optimize clinical workflows and prioritize interdigitated scheduling, we will have efficacy and precision in taking care of our cancer patients. My recommendation is mandate interdigitated scheduling, active care coordination. So when you're reviewing your patients in clinic, initiate brachytherapy if you're able to during our EBRT. Process optimization, as we move forward, we have MRT, SIV, we should embrace them, and scaling capacity. Again, active brachytherapy slots and proactive scheduling. Thank you. This was a retrospective study, so there were many limitations, but it gave us data that we need. The other thing I forgot to mention is our overall treatment time in Kenyatta is around 64 days, which is excellent as compared to our counterparts data that has been shown around East Africa. Uganda, the overall treatment time was around 88 days. So we're doing well, but we can do better. Thank you.
I think all the presenters have presented. So just let's move straight to questions and answers. maybe you can take maximum of 2 or more hands are springing up. So, okay, maybe 2 from this side, 2 from this side. Okay.
Thank you. To the presenter, Ajay, what was the N or what was your sample size for the patients with anal CA? Maybe that was missed out, we didn't get that. And then to Dr. Muturi and team, Rosemary, that was excellent. And I think for the many patients and for us as radiation oncologists, it's always good to now see sort of some of the side effects that we get. That being said, please let me know how many patients you've actually given APC. I think I missed that. And then Coptic Hospital does have hyperbaric oxygen. So maybe it's where some of the patients can be sent to if they need it. Thank you.
Should we ask the questions first or response at a time?
They might forget.
Okay.
Let's move to the answers. You want to go back? Thank you. Okay. Let's
start. No, the point about Coptic having hyperbaric oxygen is true. And I think they are more affordable than Aga Khan. I hope Aga Khan are not hearing me. But we need to be cautious about what the role of hyperbaric oxygen is. If you have mild form of radiation proctitis, that is grade 1, grade 2, up to grade 3, you don't have cavitation or deep ulcers. Really, we are able to manage with APC and the other topical therapy, that is endoscopic application of formalin, also Crofit. We reserve hyperbaric oxygen for the ulcers and those who have necrosis. It does not per se lead to healing in its own. It's an adjunct modality. You want, as much as possible, the granulation tissue to form. So that's the role of hyperbaric oxygen. And if you want to consider the patient for surgery, especially if they have a rectovaginal fistula, the other thing hyperbaric oxygen does is to soften the scar so that it becomes pliable and the tissue planes are easier to dissect. So that's the role the hyperbaric oxygen has. We had up to 78 patients registered. In private, I have 52, 54. So we were hoping to present a cohort of about 120 patients, but the record issues, IRB approval for private hospitals is a bit of a challenge. But in our setup, we only managed to reach 33, because what we wanted to do is to be able to get hold of the patient by phone so that we can get a real world experience of what are they going through, what was the distressing thing that brought them to hospital, and have we managed to address that.
On the same, do we have many centers in Kenya offering APC in the public sector?
Yeah, well, in private we have 2, that is Nairobi Hospital and Aga Khan. In state, it's only KU. Kenyatta has the equipment, but those probes are expensive, so they keep breaking down and replacement becomes an issue. So at KU, the cost of a single session of APC is 25,000. Used to be 40, we've come down because the numbers are very high. So we try and accommodate as many people as possible. Really, the cost of the service is buying the probe, because the probe costs 20,000. So we are literally charging patients 5,000 shillings. Yeah.
So thank you. Please let us make Dr. Muturi very busy.
Sorry, it was 63 patients. 63 patients over the period of 5 years that was studied.
Okay. To Dr. Muturi as well, again. I could see that at least 85% of the patients who are treated for radiation proctitis were able to be healed, which is great. At least that is so positive on our side. But there was about 15% from the trial that you presented that were not able to get treatment. At that point in time, what kind of treatment did you give them? Maybe if you could explain to us, because at least majority of the time we see such kind of patients, so that beforehand, even before we send them your way, at least we have something that we can tell them that, you know, the treatment modalities per se. If, for example, they're not able to get APCs or hyperbaric oxygen. Thank you.
Can you use the mic?
So the 85% was the patients who had clinical improvement, The 15 I mentioned, they still complained of persistent symptoms. And I also mentioned that this correlates with the presentation. Those who presented with very severe diseases are the same people who did not see like much of a clinical improvement. But of note is that with more number of APC sessions, which sometimes there's some limitations, there is some improvement. That's why there's a slide of higher, in terms of worse presentation, higher blood or transfusion needs, and also more need for more APC sessions.
Thank you.
Let me just make one quick comment. APC treatment, although very beneficial for ablating those vessels that are bleeding, can be a very dangerous tool in the long hands because you can burn the patient. You can actually create more of those ulcers and those cavitary lesions if someone is not well trained. If they don't know the precautions of using the energy settings have to be right. You have to prepare the patient. And then even how we insufflate, how we control the volume of the rectum as we distend matters. Because you see a difference when you see someone who is well trained and someone who is just practicing. Because a good number of this 15% she's talking about who still had symptoms, it's regrettable that sometimes you can cause symptoms with this energy. A patient who was mildly symptomatic can turn into overt ulcers and erosions because of the amount of thermal energy you have subjected them to.
Thank you.
Prof, Shehu, you are using low-dose rate brachytherapy. And I saw for the patients having more than 4 centimeters, most of them they were not able to achieve complete response. We have data from the brick and less, from the interless trial, showing giving induction chemo, we are going to do cytoreduction. At our institution, we have been doing this even before the data of interless came out. For us, our cut of size is 6 centimeters. We have been using it like a standard. Any tumor which is presenting before you start EBLT 6 centimeters, we give induction chemo, then we send to EBLT and everything. In the interless, their cutoff was just 4 centimeters. Have you tried this one, or is something maybe you could consider? Thank you.
Okay, so thank you very much for the observation. Currently, we no longer use low-dose brachytherapy. We just try to document the practice that we've done over the years. And then this particular study we had, it's independent of the chemotherapy status. Most of our patients will have had induction chemotherapy, had EBRT. So what is to happen is before the patient prepare financially for the brachytherapy, there used to be delays and the whole thing. And then what we're trying to bring is for patients who had tumor greater than 4 centimeters, we should probably give some form of adjuvant chemotherapy before we go for brachytherapy. But most of these patients that are having 4 centimeters already had the induction chemotherapy prior to this EBRT and also brachytherapy. But your comment is well noted and it's in line. Thank you very much.
Any question from this end? Asking question. Very good.
This is for Dr. Muturi.
Dr. Muturi, I have something to say also.
Which are the common malignancies you see that then post radiotherapy you see the proctitis? Are there common malignancies you're experiencing this way?
I would say they're evenly split between cancer of the cervix and cancer of the prostate. The presenter who was talking about brachytherapy got me interested in the doses that are used because increasingly patients who get both external beam and radiation proctitis, and intracavitary radiotherapy seems to be at a slightly higher risk than those who are getting external beam radiotherapy alone. So it's 1-to-1 between male and female in terms of CA prostate and CA cervix, but a slight preponderance among female who get brachytherapy on top.
I think a slight correction there. So for standard of care for all cervical cancer patients, they get both EBLT and brachytherapy. We have just a small percentage, less than 5%. Those are patients with fistulas or other complications. These are the ones we give only EBLT. But I think here it is more of the technique, or like it depends like which kind of form of external beam they have got, and even the center, we know that. If the patient is getting very high dose from using 2D, you do APPA. These are the patients who are coming very high, have higher chances compared to 3D. If you have very good like internal checks, like you ensure like the dose is going the right place with the CT planning and everything, it is less common with the 3D. So I think most of these patients, maybe we could look at that data again. We find out like, are they coming from the centers who are doing the 2D or 3D? So it can help us to improve among ourselves.
Okay. Okay. Dr. Joseph, maybe the last one.
My question to
maybe the opportunity. Okay.
My question, Dr. Shehu, regarding again the brachytherapy patients. I saw that your cutoff for the early brachytherapy treatment was 12 weeks after EBRT. Whereas it should be like 2 to 3 weeks. I wonder why you went up to 12 weeks rather than a shorter period. Was it because the clients were so few, or maybe none? I got surprised that you didn't use the 56-day rule.
Okay, thank you very much, sir, for the question. So, as I said, this is like a retrospective study. We didn't control any particular factor. What we're just trying to assess, one of the things we wanted to assess was what was the interval between patients completing EBRT and commencing brachytherapy. And then we saw that we now divided it into maybe early within 12 weeks and later greater than 12 weeks. However, many of our patients, even using that generous margin, still commence brachytherapy later than 12 weeks. So these delays are not what we prescribe. It's just due to the natural factor of patient preparing for the brachytherapy and some of the delays within the system that are beyond our own control. But one of the things we are recommending is we should be able to reduce those delays so that patient can come for brachytherapy as soon as they complete EBRT, which the study found that was one of the prognostic factors for complete tumor eradication, having the brachytherapy at least within 12 weeks of commencement of this. So we're not even going to stay at the boundary of 12 weeks, so we are going to push to as low as 2 or 3 weeks moving forward. Thank you very much, sir.
Prof, if you may allow, please. Santa, you show us 2 bars. One of the bars was like consecutive, one was concurrent. So what is the percentage of your patients you are doing concurrent? And why, even the time was long, the gap was just small difference between the concurrent and consecutive? Not you, Santana. You got the question?
No, I didn't
like
get it.
in the last, in the second last of your slide, it showed 2 bars where you are giving patient consecutive radiotherapy, like EBRT followed by a brachy. Sorry, sequential, sorry. Then the other one you are doing concurrent.
Yeah.
So what is the percentage of your patients, and what makes you decide which one do you use?
So for patients, it depends with regression of disease. So in week 3, 4, if you examine in clinic and you find that the tumor has regressed to less than 4 centimeters, then we were able to start the high-dose brachytherapy, and it was interdigitated. If the tumor had not shrunk appropriately, then we did try and get to the end of EBRT. The percentage was around 35 were able to start interdigitated as compared to the sequential, which was the large number, which was 65%.
Thank you. To our colleague from Ethiopia, if the time from diagnosis to treatment is 64 weeks, I think that is too far. Just like Dr. Kigula asked the Dr. Shehu Umar, what are you doing to reduce this? Because it's not acceptable. It's not. Then to Dr. Muturi, I'm very happy to listen to this, your presentation by your mentee. This APC, because most of the late effects we will get from patients we are treating at the pelvic region, whether cervix or prostate. Look, most of them will have proctitis at late stages of their disease. So what are you doing, like a multidisciplinary team, I'm sure, with your other colleagues, so that this is a good work you are doing with good response to, because a patient 2 days ago raised an issue openly here. And I'm sure Dr. Nyongesa will discuss about this case with you, so that if you are doing multidisciplinary team meeting, you'll be picking such cases. It's the same thing everywhere, proctitis, proctitis, proctitis. So, thank you. But let's start with our colleague from Ethiopia.
Okay. Thank you, Professor. So yes, this figure was deeply painful for us also to see while we're doing this retrospective study. So regarding what has been done, so over the past 2 years, 5 new radiotherapy centers were started in the country. During the study, this hospital was the only hospital that was giving radiotherapy. So after that, we have launched 5 new radiotherapy centers, and now the 6th one under commission. So it's nowhere near the IAEA guideline, but still we are getting there.
Creating awareness to the populace, ensuring that patients present early enough.
Yes, of course. Early presentation is associated with a better response, like we have seen in our study also. So public awareness is also one of the major things that we are also doing.
Dr. Muturi?
I think the suggestion about a multidisciplinary approach is very highly welcome. And also, we use some of these forums, and I'm very happy that Dr. Catherine Nyongesa and her team were able to include us in the conference as a way of feedback, because these pelvic malignancies, the treatment, it's a team sport. You will have radiotherapy, you will have oncology, you have chemotherapy, and you will have surgery. And it's very important that the 3 team members are aware of what each other is doing and the kind of delayed treatment effect the other team member sees. I was just discussing with my colleague here from Nigeria. We're saying occasionally you will get patient bleeding after radiotherapy for CS cervix who are labeled as having internal hemorrhoids. But that actually speaks to the person who is doing the sigmoidoscopy not being aware of what they are looking at. Because you know the term radiation proctitis implies that there is inflammation. Actually, the majority of the time it's not inflammation. What you're going to see there are abnormal capillaries. So the rectal surface is not inflamed at all. It just has some new abnormal tiny blood vessels scattered through the anterior surface of the rectum. So if you look at them without a keen eye, you may actually dismiss them. You may think that's not what is causing bleeding. But with time, you can be able to tell that this is the point that is causing bleeding. So feedback, continuous learning from each other, I think will get us to less and less of these treatment side effects. Thank you.
Okay. You see, as you are just rounding up, I just saw the lady coming in. Eh? So.
Yeah, and thanks, Dr. Yes, thanks, Dr. Muturi. And we also need, I think, to retrospectively check, because now evidence is also coming up on reducing external beam. Instead of giving 15-25, at least let's come down to 46 or 45 in 25 or 45 in 20 to see if that dose to the rectum can reduce. But when you also look at the literature, they are talking of the biggest culprit is brachytherapy. It's brachytherapy that is really causing this rectal proctitis. So probably we'll also need to relook at that brachytherapy. When we audited some data in KNH, we realized most of the patients who got 15-25 on COBOL, they came back with severe proctitis. And now we're trying to reduce the dose to 46, and things are getting better, but I think it is something to look out for in terms of research, and also just relook at our brachytherapy. Thank you.
Thank you very much. Because of time constraint, Dr. Muturi, please just raise up your hand. I want her to recognize you so that you can have discussion after. Because I was just talking, you are just answering about her, and she just walked in. So she will see you, and Dr. Inyogesa too will discuss a case with you. I think this is a session I really enjoyed. Can we clap hands for our presenters and even you participants for listening attentively, because it's not good to have a last session and for people to be so attentive like this. So I really enjoyed chairing this session, and once more, I thank you all, both the presenters and the participants, for listening attentively. Thank you very much. Round of applause.
Yeah, Chair, you need to take photos, memorable photos with those presenters, please. Yeah.
even taking your time out of your busy schedule to send papers and present. My agenda currently is just to reveal where we'll do the next AFROG conference 2027. Any guess? Okay, there's Ethiopia, Malawi. Who is from, I saw one from Ethiopia. Who is from Malawi? I only saw, yeah, Ethiopia is one. Who is from Malawi? Any other country? Nigeria. Okay, how many are from Nigeria? We want to see representation. Okay, who can count for me? Luther, how many are from Nigeria? Three. Okay. Any other country? Uganda. How many are from Uganda?
Me and Professor.
One. Okay, so in terms of democracy, members, what do you think? Where do we go next? You are in Kenya. Where?
Nigeria.
Mombasa, Kenya. Nigeria. Okay. Kampala.
California.
Kilifi, you are rigging, you are saying California. Okay, so I think majority are from Nigeria. So do we give it to them? Yes. Then the following year will be where? Oh my God. Ethiopia. Okay. Ethiopia? All right. All right, so we'll still confirm that in Nigeria. We don't know where Professor Olasinde will take us, whether it's to Abuja, to Lagos. I think the local organizing committee will make us aware. So please, we are looking forward to AFROG 2027. Yay! So without further ado, I'll ask Dr. Njoki to come and do a vote of thanks as she invites us for dinner.
So thank you, Chair. So we are going to Nigeria next year. So get ready, start putting your abstracts together. The conference is going to be in July 2027. So just remember that there's a bus to take you for the dinner. It's going to be downstairs at 6 o'clock. That's why we need to wrap it up because the bus is waiting. I hope you have your dancing shoes today for the dinner and the dancing that comes after. So my work is very simple. First and foremost, it's a round of applause to everyone who came for the 3 days. I think it's been both exciting, challenging, and of course, a lot of discussion that have gone about in terms of us advancing radiotherapy in the continent. I also want to thank the people who took their time to audit their work, put in abstracts, prepare the presentations, mentor other people to make presentations, so feel appreciated and honored. At the same time, I want to thank our exhibitors for this conference, Lion Care Kenya, Clarity, Vital Signs, Ivy, Glenmark, Texas Cancer Center, ICA Lion, Hetero, and the Nairobi West Hospital. A round of applause for our exhibitors and all the goodies that they gave us. The scientific session sponsors were HCG, Max Healthcare, and the Aga Khan University Hospital. Round of applause. And then our conference partners were the NCI, Kenyatta University Teaching Research Referral Hospital, and the Kenyatta National Hospital, or the mothership as we like to call it. Then our bronze sponsors, which was Vision RT and Apollo Hospitals. Thank you to our bronze sponsor. Our silver sponsor was Shinva. Our gold sponsor was AstraZeneca. And our platinum sponsor was Siemens Healthineers. So we are looking forward to having more people on that list of sponsors, and we already start preempting them for the conference. So my work is to thank you. Thank you for sitting it out even when you got late today. Thank you for participating. Thank you for all the energy. So we get ready for dinner. So we appreciate each other. The round of applause. And I will not end without appreciating the people who've ran around and made sure everything is working out. So I appreciated them. Vital Signs. Vital Signs. They've done very well with the audiovisual. Then I'd like to thank our conference partners, MMS, who've been very good at running around and doing a lot of things. And of course, to Krosk, the new baby, who we are hoping that a lot will get done. And again, remember, please register to become members of AFROG so that we can continue this conversation. Thank you very much. Yes, it'll go up, the details for registration. And for the Kenyans, don't worry, we have M-Pesa for everything, so you can join. Even Dr. Muturi, you can become a member. Thank you.
Okay. Yeah. So let us meet downstairs. Get ready. Freshen up for those who are staying here. Go to the washroom who are staying far. Let us meet at 6:20 downstairs.
Dave. I got you.